Morning, friends. So, on behalf of Debate-2026, it's a great pleasure and honor to invite you all for the Day 1 2026 wonderful scientific session program. It's a great pleasure to invite Dr. Usha Agri Madam to conduct the workshop 1.
Can I have the slides for workshop 1, please? So, good morning, everyone. Let's kick off Hall B in style. We have a wonderful workshop on fatty liver disease, or MASLD as it's now called. Right, where are we, please? Okay, you're doing this? Okay, fine. I'm trying to do it from here. Okay, lovely. So I would like to invite our 3 panel members, Dr. Bhavna Sosale, Dr. Matthew John, and Dr. Manoj Chawla, all of whom are very well known to the debate audience. So I'm not going to go into in-depth introductions because I would rather give you the science than the language. Dr. Manoj will be joining us in a minute. Now, today's session, basically I want everyone to be able to identify who is a low risk and who is a high risk patient with MASLD, whom to refer, how to stratify this risk. It's easy to say this patient is low risk, this patient is high risk, but actually how do we do it? What are the scores? And then more importantly, to understand the drugs, because where MASLD management is concerned, there are as many myths as there is actual data and science. So by the end of this session, you should be able to identify, stratify, refer when necessary, manage what you don't refer. That's the objectives. Now, the reason this is important is MASLD is not a one-way street. We know that it starts out with at least 5% fat accumulation in the hepatocytes. And as the amount of fat increases, then it leads to fibrosis and eventually to cirrhosis and hepatocellular carcinoma. You will see the numbers at the top of the screen. At each stage, the numbers may look to be small, but please understand that in India, the background prevalence of MASLD in obesity is, Dr. Manoj Chawla is also with us. Good morning. The background prevalence is about 60%. When you have diabetes plus obesity, it can go as high as 80 to 90%. So when the prevalence is this high, even a 5% eventual translation into hepatocellular carcinoma, for example, is huge numbers. And the earlier we can manage it, at least the initial stages are reversible and later it gets intractable. So I'm going to start with a poll. Can I have my Slido poll, please? So who are you most worried about? Somebody who has a mild ALT elevation, somebody who has a fatty liver on ultrasound, or somebody who has a normal liver enzymes but has diabetes, obesity, any of those risk factors, hypertension, dyslipidemia. Do I have my Slido? No, I don't. It's okay. Show of hands. We're only about 15 people here. So who says A, mild ALT elevation? I'm very worried. Who says B, fatty liver? Who says C? Oh, good. At least I have some votes. Nobody's saying anything. Good. I think actually we have delivered the message. Can we go home? Go back to breakfast maybe? Okay. So the points I'd like to make is that liver enzymes are a poor marker or a poor screening tool. You can't just count on a raised ALT to diagnose fatty liver disease, because in about 40 to 50% of people with fatty liver disease, the ALT scores are normal. The second thing, it is fibrosis, not steatosis, that predicts CV mortality and liver outcomes. Remember, people with MASLD die of cardiovascular disease, not of liver disease. And do not treat MASLD as, oh, it's just a fatty liver. It is certainly not a benign entity. It has the potential, as I said, it's a CV risk marker. It has the potential early on to be managed and reversed. But more importantly, it tells you what else you need to look at and what else you need to manage. So straight to the cases. Case 1, it's a 64-year-old woman with diabetes for about 6 years. She is obese, BMI 28.6, also has hypertension and dyslipidemia with an occasional bit of alcohol. You can see the numbers there, ALT, AST and platelets, and on ultrasound it shows a fatty liver. Who says she is low risk? Who says she is medium risk? Who says she is high risk? Okay, how are you saying she is high risk? Based on what? Okay, so if she had a BMI of 22 or 23 with the same numbers, you'd say she's okay? What if I made that BMI 24? Would that make a difference? Okay, now let's come to this. Who wants to take this question, please? So I'm going to go to Dr. Bhavna?
Yeah.
No? Okay,
I'll take it.
Dr. Matthew John. So what is a FIB4 score? How do we calculate it? And can I please ask you guys, any medical calculator you have or any Google search engine that you have, just open and put in FIB4 score while Dr. Matthew is telling us and tell me what her FIB4 score is. And Matthew,
Yeah.
do we need to do anything else? What is the next best step? What are you going to refer this patient? How are you going to?
Yeah. So we'll go back to the slide, the previous slide, so it's easy for everyone to calculate also meanwhile. So I think while we calculate, now just like you told, this person has got 28.6 of BMI, hypertension, dyslipidemia, and type 2 diabetes. So basically these two risk factors, obesity and type 2 diabetes, actually confers a very high risk of having a MASLD in some form, and fibrosis, a high possibility of having fibrosis. And just like Usha told, the aim is to actually pick out people from a large group of patients that we see who are having any significant fibrosis, because all this data has been linked between fibrosis and the risk of liver-related outcomes and cardiovascular outcomes. So that is the reason why we are trying to pick up. So when it comes to fibrosis, the best screening tool that we have as an initial screening tool, which is very simple, is to have a FIB4 score. And that will actually decide.
I've put it in the group. All the FIB4 scores are in our WhatsApp group.
Yeah.
Pulse is 1.96.
So I think you can,
Yeah, I want
they
to
also calculate.
and then I want to have
So it has got a formula. I think Usha will show the formula later, but you can use the calculator. You don't need to use the formula as such. You can use the calculator.
Know the formula. Just use the calculator. That's why I said Google it.
So once you calculate the FIB4 score and your FIB4 is less than 1.3, that almost like it's a very low possibility of having significant fibrosis. So you can leave out those guys who have less of fibrosis, that is FIB4 less than 1.3, and then consider evaluating anyone with a FIB4 of more than 1.3. That means, and if it crosses like 2.67, you have a high chance of having advanced fibrosis. So basically,
what's the
FIB is
FIB4
like,
score?
yeah.
Who's got it calculated? It is, yes. No, it's 1.93. It's in the group.
Yeah.
I'll show you the score. I'll show you the formula. That is the formula, but honestly, it doesn't matter. I don't remember the formula. I just use a standard calculator. Simple.
So can I just
Yeah,
take
please go
the
ahead.
discussion ahead? So interestingly, the FIB4 formula, this is also age-based. So if it's age less than 65, your cutoffs, the formula is the same. The cutoff of 1.3 that Dr. John said is for age less than 65.
Less than 65.
If it's more than 65, then you have a leniency up to 2. Now, funnily enough, the case that Dr. Usha has shown is 64. How much does it really matter? So 64 and 65, yeah, what are you going to do about that, John? So many people don't even know their right birth age. So.
Okay, so I think this is a continuum, and most of the time you need to look at the other risk factors also while looking at the FIB4 score. Like, it's very well known that if you have type 2 diabetes or you have obesity, that itself can pull down the FIB4 score a bit low. So it is good to, I think, not to confuse everyone, you could even consider going to a much lower FIB4 score in a person with diabetes or obesity for calculation. And a person who is older will tend to have this exclusion will fall at a higher level, like you told, Manoj told. Like, so 2 can be taken as a sort of cutoff. So it's a very dicey area, but I think you should have a clinical judgment. The main thing is not to, is to actually separate out people with likelihood of fibrosis from those who don't. So 1.3 will virtually exclude those people. And you may over-investigate some people between 1.3 and 2, and you rule out fibrosis, well and good for them.
So what will you do next in this patient?
So
Are you
now
going
you
to
have reached
investigate or park
1.9,
her?
isn't it? 1.9 is what we... Bhavna, you want to... I'll complete
Yeah,
it?
one question to
Yeah,
you
I'll complete it.
completely.
Okay. Yes, so further evaluation is required. So anything more than 1.3, you can, instead of think about different cutoffs at different ages, you can consider 1.3 and take the evaluation further. Because there is some data which is saying that for Indians there is an ethnic specific 5.4, we won't come to that. So you go for the next test. The next best test will be to go for a fibroscan or an ultrasound shear wave elastogram, like whatever infrastructure that you have access to, and that will decide whether the patient fits into the criteria for advanced fibrosis or any degree of significant fibrosis. So do we
Does this
have
patient
the...
need referral?
Yeah, so I think just at having a FIB4 of 1.9, I won't think I will refer as an endocrinologist. I would like to go further, evaluate, and then based on the liver stiffness measurement, I will consider referring the patient. Or I think for most practical purposes, we would treat the patient ourselves. Isn't it, Usha?
Absolutely,
Yeah.
because the other thing is, look at her, hypertension, dyslipidemia, diabetes, obesity. She needs management aggressively for her cardiovascular risk, irrespective of what the liver is doing. The
And one
reason I
thing-
put this case like this is because I knew the BMI right at the top will be a red herring. People will start going towards the BMI, but look in the FIB4 score. Where is the BMI criteria in the FIB4 score? It's not.
So I think one of the red herrings here will also be the platelet count, which is
Yeah.
at around 1.7 lakhs. So that is a very red herring. And you can see an ultrasound has already been done for this patient, which shows fatty liver. So I think this guy fits into the criteria to go for a liver stiffness measurement any day, because he's got
Yeah.
enough and more things showing up.
Excellent. So case 2, Dr. Chawla, I'll come to you. So this is a 42-year-old man with just a BMI, obesity, no other comorbidity, but an ALT that is just above normal, AST just above normal, ALT 40 for our lab, AST 35 for our lab, platelets of 260, asymptomatic, and has a fatty liver. So are you going to assess this patient further? Are you going to refer this patient? How frequently will you follow up? What is the most important intervention at this stage?
Sure. So I think
Again, calculate the FIB4, please. I'm putting it out there to everyone.
so. Clearly, we start with looking at the FIB4 score,
Just
which
for
is
us to cheat, I've put the FIB4 scores in the group.
I'll wait for them. I think it'll be faster
Yes.
coming from there rather than me searching there. So FIB4 score, I think, as Dr. John also said, it's a screening tool. It's a non-invasive tool to figure out the extent of screening for fibrosis. So probably every patient out there with diabetes, hypertension, so-called metabolic syndrome should be screened with a FIB4 score. Especially in India today, it's getting easier. A lot of your patients are coming with the whole package done. So having these reports, your SGOT, PT, or your AST, ALT, your CBC with platelets, all of that is available. Just yesterday or day before, we were having a discussion for somebody from, I think, the US, where they said doing the platelet count is far more expensive than other aspects, because that requires, it's not always going to be automated counting, it's going to require manual counting. So in some of those places, getting platelets is a larger task for them. But for us,
But
I
for
think
us,
as
they
that,
come with 64 pages of reports.
yeah.
We
So-
have no problems.
And so essentially it's starting with the FIB4 score. Clearly you're seeing that the platelet is higher than the previous case. You have your SGOT-PT there. The age is lesser. So the lower age goes in favor of the patient. So do we have the FIB4 score? How much is the FIB4 score? 0.89, 0.9. So clearly just the fact that the sonography is showing fatty liver may not be the best means of directing towards the presence of fibrosis. The fact that the FIB4 score is
0.9.
at 0.9, at this point I'm not going to be doing anything for this patient. It's going to be wait and watch, probably reduction of BMI and risk factors for the longer term. So advising on aspects of lifestyle change, but just the fact that the sonography has picked up a fatty liver, should I be subjecting this patient or referring this patient for further evaluation may not be required. So should this patient be referred? Probably not. Any further assessment required? Well, any other workup from the metabolic profile point of view, you want to look at the lipids or any other risk factors to start working on reducing the risk factors. So weight management here will be one of the focuses for this 42-year-old individual. How frequently will you follow up? Probably 6 months. 6 monthly should be good enough for this individual being a non-diabetic normotensive intervention. And what is the most important intervention? It's going to be lifestyle change. But with a BMI today of more than 30, we of course can start considering any of the weight management aspects, including weight management drugs. If this young man desires to lose weight and his own efforts have not paid off, today we can start considering help with any of the anti-obesity medications which this patient qualifies to get.
See, what I wanted to illustrate between case 1 and case 2. Case 1 has normal LFTs, has a lower BMI, and has a FIB4 score that's higher and presents a higher risk. It's deceptive. Don't just go by what you look at. You've got to calculate the FIB4 score. Case 2 has a higher BMI, has abnormal LFTs, has a fatty liver, but has a lower FIB4 score. This is somebody you can park and sit. That is somebody who requires much more aggressive I don't mean park and sit, don't do anything. Obviously, as Dr. Chawla has said, we need to take into consideration the overall metabolic risk, but from the liver point of view, you can wait an year or two before you repeat the indices. But for that previous patient, we need to be much more aggressive with metabolic management. Would you agree?
Just another point. So in the past, when we were not looking at FIB4 scores or not being so well informed, many of us looking at this borderline raised liver enzymes would have started giving some ursodeoxycholic acid.
We'll come to drugs, yes.
So, you would have done a lot of that masala treatment to get that. Clearly, this is showing that it may not be needed from that point of view.
I like that word, masala box. Bit of this, bit of that.
So one more thing is that if this person continues to have an elevated transaminase levels after 3 months or so of evaluation, he should definitely be looked at for other reasons like Hep C, Hep B, things like that, or any other reason for a liver disease. I think most of us as endocrinologists and diabetologists are speaking from pure metabolic perspective. I think the other sort of differential diagnosis for elevated transaminase also should be in the picture.
Remember, MASLD is a diagnosis of exclusion. Once you've excluded alcohol and other causes, right? Okay, I'll come to you, Dr. Bhavna. Case 3, 61-year-old BMI 27, diabetic for 10 years, already into secondary prevention as far as the heart is concerned. AST, ALT, let's say normal, platelets 140, ultrasound showing a fatty liver. So what are you going to do here? And more importantly, does the normal liver enzymes make this patient a low risk, number one? Number two, from the liver point of view, are you going to refer and manage? But most importantly, what is your focus in this patient for overall risk management?
So the patient is obviously obese, long duration of diabetes, already pre-existing cardiovascular disease, so there's a higher risk of CV mortality going ahead. We cannot, as we already discussed earlier, look at 30s range of liver enzymes and assume that a patient doesn't have MASLD. So we still have to put in these values and calculate the FIB score.
Help Dr. Bhavna out and calculate the FIB4 score, please. Sorry.
Yeah. 2.8. So that automatically tells us it's high risk. So another clue is that the platelet count is much lower. And we actually would, before FIB4 and, we had more access to fibroscans in the last 3-4 years. For several years before that, we've looked at platelet counts dropping closer to 1.5 lakhs, referring patients to gastroenterologists, and they would already have advanced cirrhosis at that time. So a low platelet tells you that it's actually a more advanced form of disease. So we know the FIB4 is high. We could, at this point, directly refer to a gastroenterologist. If you have access to do a fibroscan, do it so you also know the fibrosis score, and you can send the patient to the gastroenterologist with that report. But I think, as Dr. Matthew said, rule out other causes of chronic liver disease. Hep B, Hep C we can screen for quite easily. We also have sometimes cases of cryptogenic cirrhosis, low BMIs, it doesn't fit into MASLD. We've also seen 1 or 2 Wilson's disease, which have been diagnosed by the gastroenterologist, and when the patient came back, they realized, okay, this is the reason. So there could be other causes as well. So the ultrasound per se at least tells us that we don't seem to possibly have portal hypertension in this. We only see fatty liver. But still, the gastroenterologist would need to work up, do an endoscopy, and evaluate further.
So again, I come back to this. Numbers are deceptive. Do your FIB4 scores. We've got the FIB4 scores because I've calculated for everyone. But by the end of these 6 cases, I really want everybody to be thinking FIB4 when they think muscle.
So, all your 3 cases, Dr. Usha, you're showing us what the ultrasound is saying, right? It's not always going to be, it's not necessary that patients will have ultrasound as a screening tool. So, you're trying to talk about the importance of FIB4 score even without the ultrasound.
It doesn't matter what the ultrasound shows,
Exactly.
frankly.
And yeah,
I
because
agree.
Every patient, an ultrasound doesn't happen in that 999 rupees, 1,000 tests packages
True.
all over. So,
But we also see patients coming in when we also do the fibrosis score, and the LSM is much higher. It's in that 15 to 20 range, which we say is cirrhosis. But an ultrasound may not show a shrunken liver, may not show features of splenomegaly, portal hypertension, etc. So
So the brief for
again,
today
the
was,
ultrasound
what
is
can
in
the
everything.
average physician and diabetologist take away from here today and start practicing in their clinic from tomorrow? Whom to identify, how to risk score, how to refer. Because in most clinical situations, they're not going to be doing the elastography, they're probably going to refer. So I want to get everybody universally to the point where they identify and know whom to refer.
So I would say from my clinic's aspect, it's easier. Everybody coming into the clinic is an individual with diabetes.
You and
which
I
is the-
are a
Exactly. So
rarefied
for
kind
us-
of atmosphere.
For us, FIB4 score is a no-brainer, and we got to do it for every individual, like you're going to be screening for any of the other routine tests. And I'll let John continue, and who in a regular physician's clinic, who
So how many of you have used a FIB4 score before today? How many of you have calculated? And that is the point of today. And that's the point of today, because it was 4 people in the audience who've heard of a FIB4.
Yeah, one more thing, Usha. I think here it's always important to, although we are using FIB4 as a very good screening tool, I think it's always important to consider the patient in total in terms of the risk factors, in terms of enzymes. I think one take home will be that transaminase being normal does not rule out fibrosis or cirrhosis. Even you can have advanced cirrhosis with normal liver enzymes. So LFT with transaminase alone will not rule it out. You can use a prothrombin time, or you can see your albumin AG ratio reversal, things like that. But SGOT, SGPT will not rule that out.
And out of all the 4 criteria in the FIB4 score, I think a low platelet count probably sets off my alarms the most,
Yes.
more than anything else.
That also gets us to another question. Which are the areas where FIB4 score may not be relied on? What about individuals with thrombocytopenia or megaplatelets not getting picked up on the numbers? How do we handle those situations?
Refer. In your practice, for the best thing is to learn whom to refer so that you protect the patient more than anything else.
But if you look at overall, I think this, at least from the Western data, I think Krishna also has got some data here. If you look at the total number of type 2 diabetes patients attending your outpatient department, around 30 to 40% may qualify for a liver stiffness measurement.
Yeah, absolutely.
So I
agree
think
with
don't hold back a liver stiffness measurement for a person who is having, say, a FIB4 score of 1.2, and he's got elevated transaminase, he's got multiple risk factors. Go ahead and do the liver stiffness
How many
measurement.
of you have access to a center that will either do a fibroscan or a liver stiffness measurement near you? Again, that's the problem. 3 people out of the audience. And
So I
this is
think-
why.
Yeah, one thing is that most of the, if you're working in a hospital or you have got access to an ultrasound, someone doing an ultrasound, most of the new ultrasound machines can get adapted to doing a elastogram, shear wave elastogram. Although it's not that validated like a fibroscan, it still has got a really great value, because now a lot of studies trying to compare these two and saying that both are equally good. So, and now the new softwares from GE and all will also look at the, instead of the cap which comes in fibroscan, they have something called UGAP, that is the reflection of fat in the liver, quantification of fat in the liver, which comes with ultrasound also. So you can talk to your radiologist, ask him to purchase that extra software and probe and the machine, and he makes his buck, and you get your results also.
There you go. So I'm going to skip to case 5. I'll come to you, Matthew. So 49-year-old woman, BMI of 23.5, diabetes, ALT, AST, I guess I would call them practically normal. I mean, maybe a little above upper limit of normal, platelets of 160, ignore the ultrasound. So, I mean, she's thin, she's young. Is she a low risk? Again, calculators out. Tell me, how is she low risk? Would you evaluate further? And what should we focus on for management? Yes.
So the score is ready. So depending on the
Okay,
score, too
who's
much.
got the score? Fastest finger first, okay. Yeah.
Yeah. So that person definitely has to go to the next level of management. So I think we are trying to highlight here that the person with a low BMI, but still with risk factors like type 2 diabetes, could be having a significant liver
And those
fibrosis.
platelets.
And platelets are
And
also on
those
the lower
platelets.
side. So I think this is a red herring, multiple red herrings.
Yeah. I mean, I did the cases with red herrings as learning points because do not say low BMI, they're fine. Normal liver enzymes, they're fine. They're not. They have a 1.87 FIB4 score. So this is high risk. It's got to be worked up further. You go on to do at least a fibroscan, if not an elastography, right? So a low BMI, normal liver enzymes, nothing rules out MASLD. That was the learning point. So final case, who would like to take it? 56-year-old BMI, A1C, FIB4, I've put it there, 1.3, and liver stiffness, 7.5.
So the patient is.
So this
clearly
patient has been
obese.
nicely worked up and ready for you. So what is your management now? I guess we agree that not very low risk, maybe moderate risk. Where would you focus your management? What are good drugs for?
So there is obesity. The diabetes is uncontrolled. The FIB4 per se 1.3 is the upper cutoff, but the LSM is okay. So up to 8 LSM is fine. So at least it tells us he's needs lifestyle change plus drugs which can help him lose weight. But at this point, at least we're not worried about extensive fibrosis and progression. So we need to be thinking of medication which have shown evidence for MASLD. And with respect to the anti-diabetic drugs, today it is the GLP, GIP group of agents. SGLT2 inhibitors help to lose weight, so that is also, of course, beneficial. Anyway, at this point, this person doesn't have fibrosis. Metformin with that and exercise and diet.
Okay, I'm going to come to the
Statins
audience.
Statins also.
How many of you use ursodeoxycholic acid, obeticholic acid, any one of those for fatty liver disease? Okay. How many of you use vitamin E for fatty liver disease? Okay, I think we have a discussion coming up. Okay. How many of you use a statin for fatty liver disease? Please listen to the question. Statin for, okay, I have 3 hands up. So, statin for fatty liver disease. Statin for fatty liver disease, I'm being very specific. Yes, they have coincidental, cardiovascular risk and everything. But this is why I'm asking the question specifically, because I know, and I see it even from my gastroenterologist, I see all these deoxycholic acids, obito, so whatnot and whatnot. I see vitamin E's, I see statins, I see a whole range of prescriptions. Dr. Chawla, evidence-backed, do any of these have any evidence, metformin, do any of these have any evidence for fatty liver disease alone, outside of the setting of metabolic risk?
So, today is a time that you do have some drugs which are approved in different geographies for the use, but, cut back to some time earlier, the only suggested therapies with probability of helping the patient were the drugs which are being mentioned. So, vitamin E in the right dosage would have been one of the drugs, though not approved by the US FDA or any, but these are the suggested therapies. What can you offer to the patient for help? So vitamin E was one of them.
But actually, there is really no evidence to
There
say
is
that
no
improves
evidence.
anything in
So
terms
what
of
I'm talking about
parameters.
when you talk about
Yeah.
the list of drugs, if
Yeah.
you had to talk about which are the drugs that are helpful, so I'm coming to that vitamin E would have been one of them.
Historically. So
for
please note,
patients-
he's talking
For
historically.
patients with diabetes, it would be pioglitazone, then again ursodeoxycholic acid. These were the treatments being offered. Well, none of them have had any evidence showing that they are going to be helpful or beneficial today to support the patients. And today is, of course, a time that you have drugs with proven benefits, with some of them having even the labels or approval, as I said, in different geographies. And we'll probably come to those drugs for the same,
All for you.
right? So,
For the panel, we have 10 more minutes, so I'm going to stop with this question, and then we're going to come to the audience. So let us drill down into the drugs, because I think this is important for us to take away from here and understand what is evidence-backed.
Yeah, so I think UDCA, pioglitazone, vitamin E, etc.,
And metformin,
metformin, and saroglitazone.
yes.
So basically these were drugs which we had at some point of time, which had shown benefits in terms of reducing the transaminase. And ultrasonological studies showing that the liver fat comes down. But at that point of time, I should say that, Usha, those were the only drugs that we had. And we did not have any evidence that GLP-1 RAs or resmetirom or tirzepatide was not in our portfolio at that point of time. So I think those were considered good enough with the standards
enough
at that point
point
of
of time.
Yeah, but
Yeah.
now the picture has changed, that you need to have histological evidence of benefit before you approve a drug for MASLD. And that's the reason why those drugs are no more considered. But then for the patient, you put a UDCA to a patient, that SGOT, SGPT comes down. For the patient, that is the immediate benefit that they see. So, but I think we should move beyond that
We
to
should
look at
stop
long-term
doing
benefits.
that,
Yeah.
absolutely, because we are not really making any difference to either the cardiovascular or the liver outcomes. And outcomes is what we should be treating, not numbers. So right now we have tirzepatide, we have semaglutide, so GLP, GLP-GRP agonists, GIP agonists. We have SGLT2, as Dr. Bhavna mentioned, and we have resmetirom, but very little outside that. That is backed by evidence in terms of treatment. So grade A, grade B, that's it. Everything else is you treating yourself and the numbers, not really benefiting the patient.
So yeah, of this, of course, semaglutide today has a label in the US for improvement or reduction in MASL. In India, it still does not have that label, probably would get it. Tirzepatide, by the way it works and the weight loss it causes, has shown benefit, but yet does not have the label indication for reduction in MASL. Resmetirom is a drug which is approved in the US, has a US FDA approval for management of MASL, and
I think
most of you-
saroglitazar has an orphan drug license for,
so the trials are on in the US. In
Yeah.
India, I'm trying to
there
remind
is
you,
an orphan,
saroglitazar
yeah,
has an
an
approval
orphan drug license,
for
yeah.
that. But what you should also be aware that resmetirom that we talk about is available in India now on so-called humanitarian compassionate grounds, made in Bhutan and comes in here, and far more affordable than the US pricing. So these are the options in hand.
So what we understand now is a 15% weight loss, and this is sort of data that is pooled together and chopped and analyzed, dissected if you will, that a 15% weight loss translates into an approximately 30% intra-abdominal fat loss and approximately a 2/3 liver fat reduction, improving insulin sensitivity and fatty liver disease. So this weight loss thresholds, a 5% starts improving your steatosis. It does not resolve it, 7 to 10%, but you really need more than 15% to start making a difference. So your weight loss plus obesity drugs are perhaps your best bet. But what I would like
Yeah, Usha,
everybody
one thing, just one thing here. So I think there is a concern that costs will sometimes interfere in terms of our treatment.
3
with-
months.
No, I'm telling about tirzepatide and
No,
GLP-1.
3 months I'm saying, in terms of semaglutide.
So pioglitazone and SGLT inhibitors, is there any take-home that you would like to put it? Because these are two drugs that we have with us.
So pioglitazone selectively, if you have somebody who is very insulin resistant, and there is some data to suggest that it redistributes fat into the subcutaneous depots away from the visceral fat. So if you are lost for anything else and your patient can't afford anything else, yeah, that or saroglitazar. But remember, SGLT2 inhibitors indirectly by improving insulin sensitivity and again by reducing your E-lift study, isn't it? That showed EMPA having some benefit. But remember, in 3 months' time, 1st of April, the costs for certainly semaglutide are coming down, and I think we'll certainly be using them more than we are doing at present. But please, the take-home point I want is don't treat the liver, treat the overall metabolic profile of each and every one of these patients. Now, I'm throwing it open. The panel is there. They're your experts. Please ask questions. Please get the benefit of their knowledge in the next 6-8 minutes.
So while any of you comes up, I would still say that pioglitazone in this situation is a great drug. In fact, many would argue and say that it's the only insulin sensitizer that we have. Metformin, the way it works, is not even clear after so many years. It's supposed to be a sensitizer, but it probably isn't the best sensitizer. So unless there are contraindications to the use of pioglitazone, old age, osteoporosis, blah, 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 one should consider offering the benefit of pioglitazone with or without other drugs to anybody that you've identified with MASL. Every physician will have their own whims and fancies about drugs to use.
Oh, yeah.
I would say that I'm going to be more for pioglitazone, inexpensive, easily. So unless contraindicated or risk factors for that, do consider using it with the other drugs.
So, straight to the audience,
We
please come up to the
discussed
mic,
yesterday
state your name,
also.
ask the question. Sorry.
To add to the pioglitazone, yes, we do use it, but the studies have shown benefit with the 45 milligrams, and we don't usually
I
go
didn't
to
want
that
to
dose.
go there, Bhavna, but I so agree
But,
with you. I so agree with you.
But still, it could be used. So if we are seeing
See.
some benefit, it could be used.
All the data for pioglitazone exists as a 45 milligram dose. The 7.5 and 15 that is doled out in India, I'm never convinced that it does anything. In fact, if you look at the preclinical trials for pioglitazone, the 15 was worse than a placebo in terms of its effect on fasting plasma glucose and glycemia. What its effect on insulin sensitivity was at 15 and 7.5, we don't even know. But in India, it seems to be the holy grail, so I don't go there. I value my life and my sanity too much. So please come up to the mics, introduce yourselves, ask the questions. We've got another 5 minutes for the panel. No, any last? Oh yes, ma'am, please come here.
Sir, a quick question.
Please come, madam.
Sir, why are most of the guidelines are not endorsing this? Though the data is very good, interim data for SEMA has come, but most of the guidelines per se, as we see, they are having still a reserved approach. They are not straightforward telling like use GLP-1, ADA, EASD, World Gastroenterology Society. The much guidelines have come in the past 6 months at least.
Okay, so if you look at the data, in fact, they are now endorsing because now the ESSENCE trial has very recently come out, the ESSENCE for semaglutide. And ESSENCE trial, the whatever data which is now there is, I think, is a 72-week data. This is part of a large trial which is going to continue till liver outcomes are there. So with the evidence, histological evidence, now semaglutide 2.4 milligram has been approved as a treatment for at-risk MASH. That means the F2, F3 group of MASH that you would see. And resmetirom has been approved. So those two are approved. So there's no doubt. And now ASLD guidelines, the evolving new guidelines from 2026 will definitely, everyone will mention that. But for tirzepatide, the current data is from the study called Synergy NASH, which is again a smaller study. Even though it showed histological benefit, I don't think that will qualify enough for FDA to approve that as a molecule. So they have a Synergy larger trial going on, which will definitely come out, and we don't
So
know.
we have 2 minutes, madam, your question, and then we'll wind up the session.
Until
Thank
Madam
you.
comes, as we mentioned, the approval is for F2, F3. So please identify patients early, screen. Don't wait till they get to F4 because then the treatment options are very less.
F1, F2, maybe F3, but by then you've missed the boat by F4. Yeah, madam.
I am Dr. Subhashini.
Hello.
In a person with the fatty liver and non-diabetic, can we use pioglitazone? If so, how long? And in such cases, can we use vitamin E? And what is the duration? What is the time limit up to which you cannot have it for lifelong, isn't it?
Well, vitamin E is going to be an adjuvant or a placebo at the most. So we don't have data for its benefits. As we said, when we didn't have any of these approved drugs or drugs showing evidence, we were offering vitamin E. So vitamin E may not be the best option for this patient. And even pioglitazone, in non-diabetics, we don't have any data for its help in those patients for fatty liver. So looking at the others, so your patient who's non-diabetic and with MASL assuming F2, F3 level of fibrosis, you'll have to consider the other drugs also based on patients' BMI and other comorbid conditions. Of course, today a larger dose of semaglutide is approved for a BMI of more than 30 or a BMI of 27 and above with the comorbid conditions. So if your patient fits into that criteria and currently can afford, that's going to be an option. Or the other option is going to be use of resmetirom, which I mentioned is available here through a couple of pharmas. This would be the option. If there's just nothing and then we want to continue something, then it's going to go to your vitamin E and ursodeoxycholic. Pioglitazone in a non-diabetic, I don't think there's any evidence for the same.
Thank you very much.
Okay,
I'm
thank you,
going to
thank you,
hand
sir.
back to the organizers, and thank you so much to my panel, Dr. Matthew John, Dr. Bhavna Sosle, and Dr. Manoj Chawla. Thank you to the audience for turning up for a 9 o'clock session. Look at the hall. This is good. Thank you, audience.
Thank you so much for a nice presentation, panel discussion to Shaya Giri Madam, Matthew John sir, Bhavana Scully and Manoj Chawla sir. For the next session on the first medication for most patients with diabetes should be SGLT2 or GLP-1 receptor analogs. For this session, I would like to call Dr. Balamurugan sir to chair the session and take over the session.
Check. Good morning, all, and happy to start with the debate today. And the topic is the first medication for most of the patients with diabetes should be SGLT2 or GLP-1 receptor agonist. We all know that the therapy of diabetes has evolved over years with better understanding of the pathophysiology of the disease the last couple of decades. And பழையன கழிதலும் புதியன புகுதலும் வலு அழ கால வகையினானே சொன்ன மாதிரி மாற்றம் நடந்து கொண்டிருக்கின்றது. What sort of scientific data will support the usage of SGLT to GLP-1 as the first should we start? So first in the debate, I invite Dr. Gauri to talk that the GLP-1 SGLT2 will be first drug of choice. Absolutely. Over to you, Gauri.
Thank you, Krishna sir. Thank you, Balamurugan sir. நீங்க தான் சார் அது எங்க காட்டியிருக்கோம் சார் பரவாயில்ல சார். Thank you, sir. So the question is, should SGLT and GLP-1 should be the first choice or otherwise? So as we gear up on, like we will just move on to a small, we call it as data story. It was in year 2015. So there was a study which got published. This study, there were about 7,000 individuals were studied in this study. You all can understand what we are talking about. 1/3 of the patients were put on normal management, whatever we were using, like it could be metformin, it could be sulfonylurea, DPP-4, all these things. And another 2/3 of the people, in those 2/3, 1/3 of them were put on 10 mg of the drug, and another 1/3 of the people were put on 25 mg of the drug on a higher dose. So the people were studied for about 3 years. All the people who were recruited for this study had a high atherosclerotic vascular disease. Even before the trial ended, the trial was prematurely stopped because at the end of the study, even before the end of the study, within 3 years, they were able to see that the cardiovascular deaths which was happening in the study, in the drug which we were studying, was about only 10%, whereas in the other arm it was about 12%. So which study are we talking about? You all can understand that it is EMPERIC. EMPERIC showed very, very clearly that be it the cardiovascular death, heart failure admissions, or heart failure is coming down with this study. But what is much, much more that we need to understand is, it is not just like the data that it has produced. Like when we treat these individuals, statin, if you see, like if you treat 30 people, the cardiovascular events come down within about 5 years. But when you give empagliflozin, whether it is 10 mg or 25 mg, you need to treat just 25 individuals for the prevention of an event. 25 individuals, if you treat, you prevent an event. So that set of data came with empagliflozin. Rather, we will put it in this way for us to understand. If people are treated, let us say 200 people are treated for about 3 years. When they were treated for 3 years, by controlling the glucose, how many people were prevented from a CV event? It is just 2 people. But if you treat 8 people with statins, the CV events were prevented. And empagliflozin showed almost the same data. So the borderline point is, even treating the patients with glucose is not going to be important. Whether the patient is going to be on empagliflozin or not is the important point. So sugar control is not the important denominator here. Whether you have put on empagliflozin, if you have put on empagliflozin, the patient events, the CV events comes down by, in 8 people it comes down, whereas glucose control reduces the event only by 2. So this is something which we need to fundamentally understand, that this drug is an awesome drug. So there we scored in the first round. So always we can tell that it is all in the high risk population. I said like initially at the end of the debate, so that study that we had done is only about the high risk individual. We can say it is all people with 100% atherosclerotic vascular disease that we have put on. So can we extrapolate to most of our patients that we quoted in the debate? So that is not the patient that we see normally in our clinical care, isn't it? So we need to understand why these studies are done in high atherosclerotic vascular disease. When you use these patients in a high atherosclerotic vascular disease, when you use these drugs, either it will benefit them, or you can show that this drug is not benefiting them at all and you can downplay it. Or is it at par with the other drug? So this is what we understand. So if it works in high atherosclerotic vascular disease, it means that the drug will work in other people also. Like we can think about something like a seat belt. So why do you wear a, how do you test if you want to test a seat belt, how will you test? Will you put the seat belt and drive the vehicle for 15 years and see the event? Or will you put a crash test, make the vehicle to get crashed and see the event? So it is something similar to that. SGLT and GLP-1 are something like a seat belt. You have to use the drug even before the event happens. Not you anticipate the event to happen, not that the event happens and you start treating them. So people, even with the atherosclerotic vascular disease, has to be used. So the reason that they are tested is only because we can, if we test them in high atherosclerotic vascular disease, the safety of the drug is much proven. So Rajesh will use the drug seatbelt when he start driving the vehicle, not when he sees an accident en route, or not when he encounters some event. By the time it will not be useful. This is the second point that we need to take. So is there an industry influence? That is something which we all can relate to. So much of money is being pumped into this drug. The economy is so booming. The economy of GLP-1 is the first of all the drugs. This is the number one thing as far as the economy is concerned. So is there an industry influence that we all can ask? So this was asked by a very good friend of mine in the year like 2000. That sir, it is about 7 minutes. No? Okay. So there is no industrial influence. We need to understand. I will just take 2 minutes. We can reduce it by doing the debate. So it should not be 7 minutes. It should be 5 minutes. Okay. Okay. So, sir, yes, sir. So we need to. I will just go there. So if you see ADA guidelines tries to place this drug even before the other molecules, all the other molecules are concerned. Why does ADA give such a prime importance even before the other molecules? So we need to understand the reason why ADA has given, because it is all studied in, where it all studied in, we use metformin, then we use SGLT. We use metformin, then we use GLP-1. So metformin is the standard on. So can we say that we can just replace metformin with SGLT or GLP-1? It is not so, because this particular study, the one which I am quoting, this showed something called as random effects analysis. What did they do in this random effect meta-analysis is, this study, what they have done is they try to see people, say any study, whether it is empiric or otherwise, 70% of the people will be taking metformin and the desired drug. 20% of the people will not take the desired drug. They will not be on metformin, only on SGLT and GLP-1. So they try to compare these people who are not taking metformin with the people who are taking metformin, SGLT and GLP-1. So when they tried to do this, in random effects analysis in this particular study, whether you use metformin as it is seen in the top, or whether you don't use metformin, no metformin at all, the effect is almost the same. So it means that these drugs are as same as the other. It has been shown in other 2 trials also. So there is no push and pull. It is all safe. It is all evidence based. I'll just take 1 more minute.
See, the purpose of looking at a diabetic is not to wait till he gets stage 4 CKD and treat him. Correct. The purpose of taking care of diabetes வந்து வருமுன் காப்போம்.
மறுக்கா கேட்போம்.
See, the purpose of looking at a diabetic is not to wait till he gets stage 4 CKD and treat him. Correct. The purpose of taking care of diabetes வந்து
So when do you treat diabetic people? After the event has come? Now I will ask
வருமுன் காப்போம்.
whether he will use these drugs which has been studied, or will he use any other drugs? So you have to treat the patients early. Which drug are we going to use? The drugs which has been studied, or some other drug? We will listen to him. What drugs that he has? So we have a wealth of outcome-driven events. Now there comes the cost. The common thing that we all discuss is cost and problem. So we can just see the cost of the drugs. It is almost the same as far SGLT is compared. So as far as SGLT is concerned, when it comes to GLP-1, I can come over there and tell you like how we can use these molecules for a cost less than 800. So cost is also no longer a problem, and absolutely it is at the cost of no risk of hypoglycemia and amazing weight reduction data. With this I end. I will come back again for a rebuttal. Thank you.
Yeah, check. So Gauri, accident வர்றதுக்கு முன்னாடியே seat belt போடணும். So before the cardiovascular event starts, start giving good drugs with a proven benefit னு சொல்லியிருக்காரு. Now RP Rajesh is going to say certainly not. How are you going to counter இது எப்படி counter பண்றான்னு பாப்போம்.
So good morning to all. Am I audible? Yeah. So thank you, sir. And let me thank profusely Dr. Krishna sir for giving this opportunity. And I should again thank him for choosing an opponent like Dr. Gauri, who's my close friend. The beauty is that I'm traveling with him for the past 15 years, and every day is a debate for us. We debate for everything, for anything. And the irony is that he has never been defeated. For the simple, for the simple reason, he's not defeatable. For the simple reason, he doesn't accept defeat. The simple thing. So, with this, let me just move on to the topic. First medication for most patients with diabetes should be an SGLT2 inhibitor or a GLP-1 receptor. Certainly not. Certainly not. See, first of all, are we addressing the right question? That is more important. This debate is not about whether SGLT2 inhibitors or GLP-1 receptor agonists are good drugs. We all accept it. They are wonderful drugs. And I'm using it. I'm a preferred user. I'm a hardcore user of these molecules. Dr. Gauri knows that, but he doesn't use it that I know that. So that's a different story. But these are all wonderful drugs. No doubt on that. But the main question is, should they be the first medications for most patients with diabetes? If you ask this, certainly it is not. Why? We all know diabetes is a garden-variety disease. The patient, the heterogeneity in the patient, as well as the available evidences, as well as the principles of rational pharmacotherapy does not suggest, does not endorse using one molecule, one size fit all as a first line drug. So this is the basic thing. So with this, now And again, let us define the denominator here. What do you mean by most patients? The most patients means these are not the patients who are all involved in the cardiovascular outcome trials which were reported. These patients are all high-risk patients. When we talk about starting them as a first-line drug, where do we use them as a first-line drug? For drug-naive patients who are newly detected to have diabetes. And these patients are all do not have established CV disease, do not have heart failure, do not have CKD. Most of them are asymptomatic. So, if you look into the high-risk patients, if the patients have all these complications, probably 10 to 20% of these patients will be fall under that. They will not be called as the most patients, they will be called as the few patients. So, most patients do not fall under this particular category which Gauri quoted. And again, and if you are going to recommend a high-risk data and extrapolate it here, then what happens is that you are not practicing precision medicine, you are only practicing blanket medicine, remember that. And again, yeah. So, what the trials actually tell us, that is important. Whatever Dr. Gauri projected, what these trials actually tell us. All these trials have been used these molecules as an add-on therapy. So, they are all add-on therapy trials. Background, they are all taking metformin. On top of metformin, they are all taking these particular SGLT2 inhibitors or GLP-1 receptor analogs, no doubt on that. And all of these patients are all high-risk patients. They all had established cardiovascular disease or they have high risk of developing cardiovascular disease. What they did not study is that they did not study these molecules as monotherapy, initial monotherapy. They did not study in newly detected diabetic patients. They did not study these patients as a first-line drug or in comparison with metformin. So now when you are going to extrapolate the data which is arrived from an add-on therapy trial and when you are going to universalize it, then probably what you are practicing is not evidence-based medicine, then that is extrapolation-based medicine. So I think Gauri is a person who always practices evidence-based medicine. He will not accept this. He himself will not accept this. And when you look into the clinical trials, what they have done with the low-risk patients, when you do it in low-risk patients, what happens is that if you look into the relative risk, it may look impressive. But what you have to look into is that absolute risk reduction compared to the baseline risk, where how much risk reduction is there. Then absolute risk reduction is only meager in low-risk patients. Where it is profound, it is in high-risk patients which are all shown in the clinical trials. When the absolute reduction is very, very minimal, number needed to treat is not like what Dr. Gauri showed. You have to treat a huge number of patients to get that particular risk. So I'm just going to show you a very clear example here. So when it is a high-risk population, exactly what Dr. Gauri said is right. You just treat 35 to 40 patients to prevent a cardiovascular death. But when it comes to low-risk patients, look at the chart here. You have to treat 300 to 1,000 patients with these molecules when you want to prevent one cardiovascular death. This is really worth using it for low-risk patients. I'm not going into all of these details, but just understand. So these drugs are really wonderful drugs. For whom? For high-risk patients. For low-risk patients, you can use any drug. They do not have any special category. They do not enjoy the special category with respect to low-risk patients. And again, what is important is that starting a first-line therapy is not a reward. Just because a drug has excelled in all the aspects, you cannot give it as a reward. Okay, you use it as a first-line. That is evidence. You need long-term safety data. Metformin is a drug. I'm not talking about metformin. Any drug you will take. Like metformin, you have 25 years of data. You don't have so much of data with these drugs. No doubt they are all efficacious drugs. They are all wonderful drugs. They are all disease modifiers. But again, understand that they are not benign. You can get risk of UTI. You can get risk of genital myocardial infarction, GI intolerance, volume depletion, gallbladder disease. All these things can happen. I'm not talking anything against the drug, but understand that in low-risk population, they do not score much. And again, if you look into the tolerability issues, again, compared with all you don't consider them as more tolerable. They are all equal. The tolerability is almost equal. And if you look into the discontinuation rate, it is even more with GLP-1 receptor agonist. And again, just give me 1 more minute, 1 or 2 more minutes. Yes. And if you look into that, the effectiveness of a molecule depends not only on a molecule, about the adherence. Only if the patient is adhering to a molecule, the effectiveness will not be there. It will be there, sorry. So, on the other hand, when you see, when there is tolerability issues, when there is affordability issues, what happens is that patient may not continue it. What we have seen is that In clinical trial, completely it is a different scenario. Drugs are given free of cost and they are all highly motivated environment. So there they continue it. But in real world situation, it's not like that. When they do not continue it for so many reasons, what happens? Effectiveness will not be there. So this is what is important. So again, what do we need is that you should not choose a drug by thinking at how much pathophysiological defects it is addressing. What is more important is that in low risk patients, in newly detected diabetic patients, you have hepatic glucose output, you have insulin resistance. All these are very well addressed by metformin itself. And I'm not supporting metformin. I'm just against the absolutism of using SGLT2 inhibitors or your GLP-1 agonist. You can use it, but not for everybody. So let me be very clear here. Let me make a very clear statement. Who all will get benefited? Where should you use it? So these are the group of patients. Patients with established cardiovascular disease, patients who are obese, and patients who have heart failure, patients who have CKD. These are the recommendations. When you are going to use these molecules in these group of patients, you get the maximum benefit. But again, do not restrict these drugs only for these patients. The reason is, understand GLP-1 receptor agonists as well as SGLT2 inhibitors. They are all not only glucose reducing drugs, they are disease modifiers. Understand, they change the course of diabetes. So what you have to do is that use them early, not after an event. I accept that. Use them early. But again, when you are going to use them early, but be very careful in universally prescribing them for most of the patients as the first line drug. There is a difference between using them as a first line drug and using them as an early drug. So there is a difference. And again, when projecting the cost, again, I'm not talking into the cost, but again, people think that cost is not a science. Cost is a scientific variable. So when Dr. Gauri projected it, he did not mention about the GLP-1 receptor agonist cost, so that's a different matter. Okay. So I'm against use of these things as an universal first line therapy. So now, to conclude, when I asked Dr. Gauri, honestly, I got irritated. What is this, Dr. Gauri? Why are you projecting like this? I asked him, in your practice, are you really using these drugs as a first line drug? For most patients, when I asked him very furiously, his reply was simply this. So this is the reply which Gauri does. The simple reason is, he's a very nice person. He's a scientific person.
Yes.
And again, you know that he may blabber. He may talk something like rubbish. But when it comes to practice, he always follows things. He always keeps away. He doesn't involve in all the rubbish activities. So with this, I end my talk. Thank you.
தேங்க்யூ ராஜேஷ். டிபேட்டில் வந்து ஏதாவது பேசிட்டு போயிடலாம் அப்படின்னு நினச்சிட்டு யார் பேசினாலுமே ரெக்கார்ட் பண்ணுவாங்க, ஞாபகம் வச்சுக்கோங்க இனிமே. ஐ திங்க் I'll give 1 minute to Gauri to counter this. சொன்னார், இப்போ நீங்கள் வந்து எல்லா பேஷண்ட்ஸுக்குமே இது யூஸ் இருக்கா? இல்லை most of the patients, is it going to be useful? That is a good question. And also cost factor also. I think Gauri will give a counter for it.
You all understood what he said by most of the patient and all the patients. This is what confusing. So when we come to debate, we should understand something. Like when I throw a ball, if the ball comes down, immediately what do you think? The ball comes down because of the weight. Isn't it? That is what we think, no? But what does science tell? It is not coming because of the weight, it is coming because of the gravity. So I am talking science. He is talking practical thing. Science takes sometimes for us to accept. Science takes sometimes to universally accept. Science takes sometimes to endorse. So, but the pure science is, let us ask, is diabetes a CV risk equivalent or not? Will you use statin in all your patients, all your diabetic patients, more than 40 or not? If I am going to use, then better take these molecules. It may take some time, mindset. But science is, this is what I have talked, this utter science, pure science. We should accept, endorse science. That is what my message is.
Yeah. Anything? What is the last word from Rajesh?
Yeah, so
Before.
the irony is that when you don't have data, you always talk about gravity, fall, all these things, you deviate from the data. So I accept all the data, but all these data which projected by Dr. Gauri was done in high-risk patients, not in the low-risk
Gauri?
patients. So all of us understand that meropenem is a wonderful antibiotic. Don't we? We all understand, we all accept it. But do we have to start meropenem for every OPD patients who are coming from common infections? That's the question. And my friend Dr. Gauri said that diabetes is a cardiovascular equivalent. We understand it, but it is not a newly diabetic diabetes. Diabetes was across 8 years of duration. That is only cardiovascular equivalent. So be little cautious. Don't give blanket recommendations. You use it early, no doubt on that. Please use it early. Don't reserve it to the last.
Yes.
But should you use it as a first line drug for most of the patients?
ரெண்டு பேருமே அவங்க கருத்துக்களை சொல்லிட்டாங்க. I think can we take some opinion from the floor? Who wants to give? Dr. Bhuchandran? Jayashri? Yeah, just couple of quick comments from the floor.
I have to say, both of you convinced me.
No, what is your own?
What I wanted to ask Rajesh was, and I think this is what we struggle with. When we see this person newly diagnosed with diabetes, how do we exactly categorize? Is it someone who is truly low risk? We all have people who are in their 80s with very mild diabetes with nothing going on. We are not going to hit them with SGLT2 and GLP-1. Versus the person who at the age of 40, suddenly drops dead of a heart attack. And then that troubles us. So I think always the difficulty for us is in determining on the trajectory, the accelerated CV risk, or how do we determine that this person is going to benefit from? If you look at the guidelines, they say high risk for ASCVD, even if they don't have ASCVD now. High risk for ASCVD. Sure, we use all the markers, but I think it is important that we judiciously apply the people like obese. Suppose you have somebody who's obese, hypertensive, strong family history, smoker, newly diagnosed with diabetes. Would you not consider using these medications?
Absolutely, madam. If you ask me in this stage, I will only say that medicine is not mathematics. We have to wait for the evidence. In the low, what you said is perfectly valid. But in the low risk group, whether they are really going to do a huge benefit, that's the big question. But that should not prevent us from using it from these patients. Understood that. But are we going to use it universally as a first line drug and replace metformin or other drug? That's a big question. Maybe 2 years or 5 years down the line, if you have new evidences, definitely we will be talking exactly the opposite. But as of now, you have hardcore evidence or not. We are only extrapolating the results.
Okay.
That doesn't mean that I'm talking anything against it. I'm just talking about evidence.
I think
One question I will ask you: who is a low risk diabetic patient? How do people over there know who is a low risk or not?
See, you can't equate everybody with somebody with 10 years of diabetes, who's smoking, who's sedentary, who's obese, who has a strong family history of CVD or CKD. You can't equate them with just somewhere around 40 years, less than 40, does not have any other risk factor like that.
most patients.
Do not fall under this category. That's the thing. You just tell me what is the prevalence of
No, I think,
incidence of CVD in patients who are newly detected to have diabetes. It's less than 20%, not even 15%. So, when it is 15%, they don't come under most patients' category.
Let me put you another line. So the reason why we treat our diabetic patient is prevention of CV events, prevention of heart failure, prevention of renal events. So Rajesh, no, right, that video. So even before those events come, you should appreciate, understand and treat the patient. How will you treat if you are not taking these molecules? That is my question.
Yeah, okay. Rajesh, now
We have to treat it early, not as immediately. Whether we should treat it as first line, we may have to treat it only if we have
I think speakers can just wait and we will ask Dr. Bhuchandran, your comment please.
Yeah, that was a very good discussion. But I think the low risk patients, you'll have to be very careful using the high-end drugs. And also patient compliance is something you must take into account. The low risk patients, you start them on, GLPs and SGLTs, then you're going to put them into more this one. And patient compliance is also an issue, which should also be considered.
Anybody else from the floor to give their opinion on that? Okay. I think, we have done and actually, I already introduced in the talk itself, opening itself, the management of diabetes has changed over years. Yeah. கண்ணதாசன் சொன்ன மாதிரி மாற்றம் என்பது மானிட தத்துவம், கல்லாய் மரமாய் காடு மேடாக மாறாதிருக்க யான் வனவிலங்கள் என்ற மாதிரி the science has evolved over the years. when we were students in medicine, we had only glibenclamide and metformin. But the last 2 decades have shown a tremendous, how many clinical trials? In fact, you said about the Vanda Pinnadi Kaakalaanadu, it started with Emfarag, later we moved on to Canvas, which had a 65-35% population in terms of cardiovascular risk. Again, we have Savatimi, which has included almost, the people who not developed the events also. And we have even data from studies like Steno study, which when you are able to multifactorially address these complications, we are able to prolong the lifetime. So even though we have good friends like metformin and sulfonylureas, we have traveled with you from your school days, you have an experience with them, you know them well, they are very friendly and they are dependable, you can discuss anything with your school friends, not with now all other new friends now. Even though you have a lot of friendliness and your experience and confidence with them, now we need to go with the science, how the science has evolved. And so the new science has shown that definitely a lot of, apart from the anti-hypoglycemic effects, all the newer drugs have shown multiple extra benefits, pleiotropic benefits, controlling blood pressure, controlling cholesterol. So, single drug doing so many things, So in a country like India, patient cannot afford for everything, and most of the patients spend from the pocket. Now we are not fully insurance driven at this point of time. So taking very costly drugs sometimes difficult, but we should go with the science which shown lot of benefits with the newer drugs. Even though we are not totally saying the older drugs are not valid, and they are not, I'm not here to tell they are useless, but இன்னைக்கு மாற்றத்தோட சேர்ந்து நம்ம போகணும். We have to adapt and learn and try to use. And you said about the high cardiovascular risk. Diabetes per se is called the cardiovascular disease risk equivalent. A lot of debates have been there. And so people are, if you look at the angiogram of a patient, coronary angiogram of a patient with long-term diabetes, uncontrolled diabetes, we have seen few of our close relatives recently. The vessels are really very bad. This is not amenable for an angioplasty. They need to only do a CABG with a lot of difficulty. So it means a lot of uncontrolled diabetes over the years has caused it. So should we wait for that? So should we start treating them very early itself? And unlike type 1 diabetes, type 2 diabetes most often, today our teaching was when we were students, that the diabetic complication occurs 5 to 10 years after diagnosis. This was an undergraduate teaching way back in 85, 88, when me, Jay, Sri, Krishna and all were at Madras Medical College. Now, today, we see type 2 diabetic patient presenting with a myocardial infarction, presenting with a neuropathy, presenting with a proliferative diabetic retinopathy. So, there is no need to wait. So, start early, and can we take an audience view? Can we have a voting from the audience? Should the drugs be started early? Yeah. First line drug. Yeah. First line. I think most of the audience also have a view that this drug can be started as a first line drug. Yeah. இல்ல first கை தூக்கிட்டாங்க. அதனால ஓவரால் ராஜேஷ் நல்ல சிறப்பா பேசினாரு. Older drugs are important. They are not to be thrown off in the dustbin. And especially in economical, first time in the ADA guideline, they've introduced cost as a factor of therapy in diabetes management. So cost also to be considered. Now all the newer drugs also going for a lot of cost reduction. So whoever is affordable, kindly give the benefit to them. So science is evolving. Because debate is done here, because practice is one, and scientific way of practice is the more relevant today. And I conclude by saying these newer drugs are quite useful, evidence-based, and even though older friends are very important, we need to adapt and learn the new science and give the benefit to most of our diabetic patients who are at the high risk of cardiovascular event. Over to you. Thank you very much.
Thank you so much, Balamurugan sir, and my dear friends Gauri and Rajesh. Let us move to the next symposia. First, I would like to call Dr. Anjana to talk about the continuing relevance of sulfonylureas in clinical care.
Good morning, everyone. At the outset, let me thank Dr. Krishna Shishadri and the team of Debate for having me here today. Today, I'm going to be talking about the continuing relevance of sulfonylureas in clinical care. And basically, this is a continuum from the previous fantastic session by Dr. Dauri Shankar and Dr. Rajesh. So this is just going to be a continuation, and maybe I thought I'll answer something, then I thought, "Namada next pesa porome appa sollikkalam update." So we will talk about that. Please note, this talk is supported by Messrs. USV. So we start with the global burden of, the Indian burden of diabetes, and this is from the ICMR INDAB study, which shows that in India, we have 101 million people with diabetes. Now, not only we have a lot of diabetes, how many of these people achieve the ABC goals? How many people have their A1C less than 7? That's only about 35% of the population. So the rest of them have an A1C that is high. And of note, only 7% of the population have A plus B plus C under control. Now, why have these targets not been met? We know what we need to do. We have so many drugs available. We talk about lifestyle. We do so many things. Why are these not met? Now, shown here, and we just talked about this, you've seen this multiple times, this is the latest Debate-2026 guidelines for using blood glucose drugs, lowering drugs. And where are sulfonylureas in this? Can you see that red circle in that corner there? That's where it is placed. Now let's talk about why it is so. Now the ADA, what is it based on, these guidelines? We talked about this in the previous session where we talked about comorbidities being first risk of ASCVD, heart failure, CKD, MASL. That's the first group of things they've based it on. Next, they look at weight gain and hypoglycemia. And in the third category, they have efficacy, treatment burden, and affordability that comes into play. So this is the categorization by which they're making these guidelines. But if you look at the number of people who actually have these compelling indications, and we had just now discussion about it, it's not very large. This is data from the US. But we know that in India, at diagnosis, so let's stop and talk about this in a minute. Are people at diagnosis of type 2 diabetes, high risk for ASCVD and all of these things? Truthfully, we don't know. But today we have risk indicators that we can use. The ones that we have for cardiovascular risk are based on the West. But now we have data that's coming from India. We have Indian CVD risk indicators which tell you quite accurately how much of CVD or ASCVD a person can have. So these can be used as risk markers for diagnosis at the person with diagnosis for this person. The second thing is that we also have risk engines. So we have one called as Diana, because not all diabetes is the same. Different types of diabetes have different risk categorization, and we'll talk about this. Here is a review of 33 different guidelines which look at what should we give as first line, what should we give as second line. Most everybody, have a consensus about metformin, but what happens after that? You can see whether it's the ADA, the IDF, the ISPAT, the NICE, WHO, ESD, it doesn't matter. You know that if the person is at lower risk, and we talked about how we define the lower risk now, you can start sulfonylurea as second-line therapy. ADA says that, WHO says that, NICE definitely says that, and of course the RSSDI and Indian guidelines also have it there. So what the ADA says is after metformin for someone without the compelling indications, which is known ASCVD, heart failure, MASL, or CKD, any one of 6 drugs, including sulfonylureas, can be started as second line. Now, we also know that all type 2 diabetes is not the same. So what are we talking about? When we talk about the main GLP-1s, fat loss is your central piece. But does that apply to everybody? We all have patients in whom our tirzepatides and our semaglutides are not working. We do have those patients. While they do address a large percentage of the population, there are some in whom it doesn't work. Why? Because diabetes is not the same. We have the severe insulin deficient diabetes. We have the IROD, which is the insulin resistance and obese diabetes. So this is the category of people for whom the newer drugs are going to work really well. But see how much? They're only 25-26% of the population. You then have a combined variety, and this is novel for India, where they have a combination of both insulin deficiency and insulin resistance. So that's 12% of the population. Again, in this population, you may have some effects of the newer drugs. And then you have the mild age-related diabetes, also known as mild diabetes, because it can happen at any age. So the largest population is actually the mild. Do you need the disease-modifying drugs there? Maybe not. Even any drug will work. Even an AGI, metformin is good enough there. So because of these different categories of drug and where you have insulin secretory defects, actually you may have better use of drugs like sulfonylureas. Now this is a group kind of publication on prescribing patterns of diabetes in India, and all the major diabetes people are there. There are 32,000 patients that are involved in this. And what we found is that physicians across India prescribe sulfonylurea and metformin as the largest prescription, either singly or in combination. These are still very much the drugs being prescribed across the country, and that's not new to you. So why is it, with all the latest guidelines that are coming, Indian physicians still go to the age-old drugs? Because they are the most efficacious. In India, for us, we have many things that we have to take into consideration. There's nothing wrong with the newer drugs, the SGLT2s, the GLP-1s. Yes, they are useful in a certain select population, definitely. But when you talk about efficacy, we deal with large volumes of people. We deal with people in lower socioeconomic strata. We deal with lower literacy. We deal with a whole lot of things. Sulfonylureas are cheap. They're the most effective drugs available today. Also, if you looked at the ADOPT trial, so a lot of bad name came from sulfonylureas based on this trial, wherein they showed that there was early beta cell failure and secondary treatment failure. But if you look at the initial response that came, the efficacy part of it, the sulfonylureas were best compared to any other drug. This is also another study from Thailand that looked at, and this all of you would have experienced, if you stop the sulfonylurea, it's very, very difficult to get that control back again. They are the most efficacious, cheapest, and best drugs. They work, and they work really, really well. So if you stop the drug, you do have problems. And also one must remember that we're talking so much about comorbidities, but the center of diabetes care is glucose control. And glucose is still very much the reason why we have decrease in every microvascular and macrovascular complication. So simply a 1% decrease in A1C helps you with all of these things, include mortality. So while it's important to look beyond glucose, don't forget that glucose is still the center. And when we talk about glucose being the center, sulfonylurea is the most efficacious drug. Now, also, let's look at all the CVOTs that we have. They're listed there. All GLP-1s, SGLT2s, whatever you want, it's there. What you'll notice is that we are looking for the extra things, heart failure, cardiovascular disease, etc., etc. But this is done on a baseline of already glucose control, which is happening with sulfonylureas. So look at the percentage of sulfonylurea use in all of these major trials. It's 37%, 51%. You know, everywhere you already have the sulfonylurea with metformin. The glucose control has been achieved. Over and above that, we look at the extra. So again, this is not about either or. This is about how to make it work depending on your patient. So I think the answer to that question and that debate we were having before is, should we do this? Should we do that? Is this the best? Is the modern the best? Is the newer drugs the best? It depends on the patient. And I think that is the final answer. So glucose control remains the center. What about side effects? Now, hypoglycemia is a real problem. So we do have, if you look at the relative risk of hypoglycemia with sulfonylureas compared to other drugs, it's there, definitely there. And you can see compared to all the other drugs, clearly the risk of hypoglycemia is there. But if you look at the absolute risk that you are showing, look at mild hypo, it's about 10%. Severe hypo is less than 1%. So clinically, when you come to it, this hypoglycemia, it's there, but in the absolute terms, it may not be as much as a problem. However, these are patients in whom hypo can be a real problem and one must have an eye on. Elderly patients, if there's concomitant renal or hepatic insufficiency, co-administration with insulin is usually a problem. Older sulfonylureas, which are long-acting, irregular food habits, and some drug interactions, sulfaquinolone, etc. So in these cases, what do we do? Now, the normal dose of sulfonylurea acts as initiators of insulin secretion. But if you give lower doses, then these become potentiators of insulin secretion. So you have glucose-dependent insulin secretion. So if you give that at half dose, what happens is you get the efficacy, yet you don't get the hypos along with it. So that is about the lower doses. Now, what about weight gain? Now, weight gain is also something that you definitely see with sulfonylureas, but how much of weight gain do you get? So the ADOPT trial showed 1.6 kgs in a year. Other trials have shown 1 kg in a year. Well, we can do better than that in 1 week. Can't we? Gaining 1 kg in 1 week is not a big deal. So when you look at the absolute effect of this, it's not a big deal, gaining 1 kg. And the thing that you'll find is it's of small magnitude and it's self-limiting. You don't go on gaining weight for the rest of your life. Now, what about cardiovascular risk? Here are data to show that this is looking at all MACE, cardiovascular disease mortality, cardiovascular mortality, and sulfonylurea is not, this is a real-world population-based event. It does not have extra cardiovascular risk, the newer sulfonylureas. We also know from the Carolina, this was the only study that looked at Lina versus glimepiride directly. There was no excess cardiovascular risk or mortality for the sulfonylurea drugs. When you compare it to SGLT2, this was a systematic review and meta-analyses. You will see again, it's on the line. There is no excess CV risk that is coming from the sulfonylurea drugs. Now, between sulfonylureas, yes, there are differences. The older ones do have some difference in cardiovascular mortality. The newer ones, the modified release glipizide, glyclazide, glimepiride, they are the ones that are safer. So what are we saying about risk? It's not associated with CV benefits, but there's no harm either. And it's not about using sulfonylurea again versus, but it's using both together. So you use one for CV efficacy, you use the other for cardiovascular benefit, so the patient enjoys the best of both worlds. So this part is very important because always they have a bad name in terms of reducing beta cell dysfunction. So here's another real-world analysis of about 12,000 patients in which we clearly showed that C-peptide levels are preserved in Indians with use of sulfonylureas over a period of time. And here again, there's differential preservation of beta cell function. Glyclazide was associated with lower incidence of secondary treatment failure. This is possibly due to the reversible KATP channel binding that it has. So you may have the newer sulfonylureas also preservation of beta cell function. So the last part is about the final recommendations of sulfonylurea, and this is a good one that came in 2020 from Sanjay Kalra and colleagues. So the modern sulfonylureas are effective and safe. You can use it with metformin. It depends on the situation. It can be used in combination with all classes of drugs. So compared to metformin, it has better glucose-lowering efficacy, safety, and tolerability. Compared to PIO, it has good glucose-lowering effect with significantly lower weight gain. Compared to the DPP-4, again, it has more durable glucose-lowering efficacy. We also have direct comparisons with DPP-4, where the cardiovascular benefit is not, and the weight was also pretty similar between the two. Compared to SGLT2, again, it has a non-inferior glucose-lowering effect, and compared to GLP-1, it has similar glycemic efficacy. It can be combined with insulin. Note that hypo can be a problem here. So if you're using basal insulin, it depends on how you use it. If you're using once daily, use the antipodal meal. If you're using a premix, in this guideline they say use a middle meal, but that's generally not how we use it. With comorbidity, we also talked about cardiovascular risk. We should be careful. Use the short-acting drugs in those where liver kidney is a problem, and one must take care of hypo as well as the weight gain. So in conclusion, the modern sulfonylureas are not, they're complementary to the newer drugs like the SGLT2s and the GLP-1 RAs. It's not about which one we can use. They're still the most efficacious, they're still the most affordable with the best durability. They're the best known agents we have so far. Thank you very much. Are you coming in? Am I taking questions? Okay.
Thank you, madam. Now we will move on to the next session. May I request Jayashree Gopal madam to take over the next topic, please.
Good morning. And I have to thank Krishna for always giving me a topic where I have to actually think and read. Can I have my slides, please? I think after that very reinvigorating debate session we had, it was really nice. Gauri and Rajesh did a really good job. So the title of my talk is Time to Rethink Metabolic Care from the Liver Angle, Are Pioglitazone-Based Therapies Back? And really pioglitazone, as I shall talk, it's got one, it rose, it fell, it rose again. So we have to talk about where it's positioned right now. This is my conflict of interest slide. I want to spend a few minutes talking about the role of the liver in glucose and fat metabolism. We understand that the liver is central. It is the one, it is sort of like a metabolic control place. Sorry, is there a pointer? There is no pointer. Okay, let me use the... Great. So there is a pointer. Yeah. So the... Right now, all of our livers, whoever has had breakfast, all of our livers are heavily processing the food that is coming in. It needs to metabolize not only the glucose, but also the dietary fats that come in. And it plays an important role, obviously, in glycogenesis, storing the glycogen, but also breaking down the excess glycogen. So our glycogen storage capacity is roughly about somewhere around 1 kilogram totally we'll have in our body between the liver and the muscle. And the remaining extra glucose that comes in, the carbohydrate that comes in, has to be converted into fat. And of course, the fat that we take in is also packaged and it's made into VLDL particles and sent to the adipose tissue for storage. So the liver is sort of a metabolic hub, as it were. It manages the trafficking of fat in the body. But it is a processing center. It is not a storage center for the fat. In the healthy state, the liver should contain very little fat, usually much less than 5% of its own body weight, which translates to roughly about 50 grams for an average person. If the fat accumulation is more than 5%, we call it fatty liver, MASLD, the name keeps changing. And what happens is when the adipose tissue also exceeds its capacity to store fat, the liver is like a sponge. I think of the liver like a sponge. It cannot turn away anything that comes to it. It keeps accepting all the extra calories we keep putting into it, and that is the reason why fatty liver develops and insulin resistance develops. But remember that liver is not meant to store fat. Like I said, it's only a metabolic hub for processing the carbohydrate and the fat. In fact, if you look at it, the 95th percentile for the fat in the liver is 1.85%, not the 5% that we are used to thinking about. In fact, when the liver triglyceride, the fat storage, when the liver triglyceride content is more than 1.85%, more than 2% of the liver is fat, you get all of the features of the metabolic syndrome. You have more insulin resistance, triglycerides, LDL, uric acid. So by the time we picked up fatty liver, it's already, I would say, the liver's storage capacity has been significantly exceeded. So in healthy, lean individuals, the 95th percentile of the hepatic fat content is 1.85%. So this is important to keep in mind. We always know that fatty liver leads to insulin resistance. How does it happen? It's not just that the fat is inertly sitting there. More than the accumulation of fat, it's the fact that the lipogenic pathways that get stimulated. So all of these extra calories have to be converted into fat. Like I said, the glycogen storage has a finite amount. The remaining excess carbohydrate, energy, whatever we get, has to be converted. Fat is the most efficient way our body can store energy. So all of that extra energy has to be converted into fat. So the lipogenic pathways get stimulated, and there are a formation of a lot of fatty acid intermediates. One particular fatty acid intermediate, a diacylglycerol, actually it has been very well elucidated. This diacylglycerol, the sort of the intermediary before fat is formed, that actually activates and phosphorylates one particular amino acid residue on the insulin receptor. And once that insulin receptor, that particular residue gets phosphorylated, it means that insulin receptor is not able to respond to insulin. So I think very clearly now we know why insulin resistance occurs, because of the presence of excess fat. It's not the presence of excess fat, it's the fact that the lipogenic pathways are stimulated. Why are the lipogenic pathways stimulated? Because we are putting too much into our body, too much calories. Interestingly, even a borderline rise in ALT and gamma GTP is a strong predictor of future diabetes risk. So this extra fat that accumulates causes an increase in the gamma GTP and the ALT. And I found this data very interesting. Even a gamma GTP more than 23 increases the risk of diabetes. And this was people who were followed up after 5 to 8 years. So gamma GTP of more than 23, 1.5 times risk of developing diabetes. ALT, look at the numbers. An ALT more than 21 with a gamma GTP more than 23, 2.5 times increased risk of diabetes. How often are we seeing people who come to us, younger age, their AST, ALT will be 15, 16. We are seeing them 10 years down the line, their AST, ALT is 25, 26. And I don't know if you noticed, nowadays, if I look at the labs, the upper limit of normal for the labs has gone up. Now they're putting 35, 38, because I think all of us are developing fatty liver. So that number itself is going up. But this was a very, of course, we have to correct it. This is not an Indian study. I think it came from the Taiwanese or Chinese population. I cannot remember. But suffice it to say that even a 10-point increase in your AST, ALT is a good indicator of future risk for diabetes. And other studies have also shown this. For example, in this study where they followed up people for more than 5 years, they showed that the group that was lean and that which did not have fatty liver at baseline had the lowest risk of developing diabetes, whereas the group, even when they were non-obese, when they had a fatty liver, they had the highest risk of developing diabetes. So 5 times higher risk even in a non-obese population with a fatty liver. And interesting, and this of course, again, goes without saying that obese population also had a higher risk of developing diabetes with a fatty liver. When the fatty liver resolved, so they looked at a group in which they had a bit of fatty liver at baseline, but then it resolved, the risk of developing diabetes came down. So if we pick up a fatty liver and we counsel them about lifestyle changes and get them to reduce the fat in the liver, we are reducing their risk of developing diabetes. And I want to say that though I'm talking today about a hepatocentric model, all of it goes together. It's not that this is the only problem that is occurring. This is side by side along with insulin resistance at the level of the liver and insulin resistance at the level of the adipose tissue. They all feed into each other. We cannot take one in isolation. We know that liver fat is bad. How can we reduce the liver fat? When we think about liver fat, liver insulin resistance, we are always used to thinking about metformin. But the studies have clearly shown that metformin reduces liver fat only by about 3%. Pioglitazone reduces it by about 50%. We know that pioglitazone is being used a lot now for reversal of fatty liver, in fact, even reversal of fibrosis. That is not the point of my talk, but just to say that pioglitazone is a much more powerful agent to reduce fat in the liver as compared to metformin. And this gives a comparison of all the medications and how much the HbA1c comes down. So metformin, minimal reduction in liver fat, pioglitazone, maximal reduction in liver fat, GLP analogs, second, SGLT2 inhibitors, third. Now I'm going to move on to the pioglitazone story. So the pioglitazone reached, received approval from the FDA. The thiazolidinediones has received approval in the late 90s for use in type 2 diabetes. And in the 2000s, I think it reached its peak use. Very widely prescribed worldwide, very, very popular. And then in the late 2000s, concerns arose about its hospitalization for heart failure, cardiovascular concerns, bladder cancer concerns. So at that point in time, there was a temporary ban on the usage, and now of course there is a massive resurgence. I think some of you will understand this this sort of image that I put up. The resurgence happened sort of in the mid-2000s after a trial called the IRIS trial. So in the IRIS trial, they used pioglitazone in insulin-resistant, non-diabetic, pre-diabetic patients, insulin-resistant patients who'd had a stroke, and they saw whether you could reduce the chance of a second stroke. And what it showed was that usage of pioglitazone in this group reduces the incidence of stroke and MI, and that there was no increase in heart failure risk when you excluded people with baseline heart failure, and when the dose is adjusted and the drug is stopped if they developed edema. So therefore, it sparked renewed interest in using this very powerful molecule in select group of patients. If you look at the Indian sort of scenario about pioglitazone, in 2011, I think it was banned because of this risk of a French study which said that maybe there was an increased risk of bladder cancer. But in 2013, this ban was revoked. 2016, the IRIS trial that I spoke about, and then all of the guidelines started saying that maybe it's got some use in certain situations. And then from the 2020s onwards, you could see that a lot of the guidelines have endorsed its use for people with diabetes with confirmed MASLD, NASH, biopsy-proven NASH, in diabetes, or even as a second or a third line therapy for people with diabetes. We know that it's got significant cardioprotective mechanisms. So for example, the proactive trial showed that pioglitazone in people with diabetes with a previous MI, a third reduction in reinfarction, a third reduction in acute coronary syndrome. Various other trials, the Chicago trial, Periscope trial, has shown that there is a regression of coronary atherosclerosis. Proactive also showed that there was a reduction in secondary stroke. Other studies have shown reduction in cardiovascular events in people with CKD. It reduces microalbuminuria, and of course, like I said, significant reduction in liver fat. So pioglitazone has got a lot of benefits, but we always are left to the question about what does it actually do to the heart? We cannot get away from the signal about pioglitazone showing water retention may be causing heart failure. However, what we need to understand is that pioglitazone actually does not worsen heart failure. This was one of the earliest trials which showed that myocardial glucose uptake is actually improved. So this was done in people with diabetes who received pioglitazone for 6 months. And the yellow bar is there, myocardial glucose uptake before pioglitazone, and this is the glucose uptake after pioglitazone. And these were all very carefully done, like biopsy studies, and this was a PET CT where they looked at the myocardial glucose uptake. These are all human trials. Myocardial blood flow improved at the end of 6 months of pioglitazone use. Reassuringly, ejection fraction improved, 60% at baseline, 65% after 6 months, and other parameters of heart function actually improved after usage of pioglitazone. So what is happening? How do we reconcile this with this data? It looks like pioglitazone is actually helping the heart, but we cannot get away from some of the trials showing that there is an increase in heart failure hospitalizations. What they think is happening is pioglitazone, because of its action on the PPAR gamma, actually increases eNOS production, nitric oxide. It turns on the nitric oxide synthase pathway. There is increased vasodilatation, and we know that is one of the reasons for developing peripheral edema. But this vasodilatation that occurs in the kidney also causes increased salt and water retention. So we have sodium and water retention, and this is the reason why people with on pioglitazone develop water retention. So in people with pre-existing heart failure or people who are already on insulin also, there is significant increase in the water retention, and that tips some people or precipitates heart failure exacerbation in some people because of this fluid retention and volume expansion. So I think you can see where the story is going. On the one hand, we have a molecule which is working very well. It's reducing cardiovascular events, it's got significant benefit in reducing heart attack, stroke, but it's causing water retention and it's causing weight gain, and it increases fracture risk. This we cannot get away from, we need to keep it in mind, and I'll talk about this when we talk about how to use it in the clinical situation. Weight gain on an average is about 2 to 4 kilos because of both a combination of increased adiposity and sort of the fat redistribution in the body and the fluid retention. What if we combine this medication with something that reduces water retention and that helps with weight reduction? So this is where there is a renewed interest in coming out with these pioglitazone-based combination therapies which are now available on the market. So this was a trial done in India to get the DCGI approval. It was an FTC of DAPA 10 mg and pioglitazone 15 mg for use in patients with diabetes inadequately controlled on metformin. And you can see that there is a good reduction in HbA1c, a good reduction in fasting and postprandial as expected. And this was for the DCGI approval, and now we have this combination approved, DAPA 10 and pioglitazone 15. There have been other studies also showing a good reduction, better reduction in HbA1c and not much of weight gain. So if you look at this, the DAPA 10 with a PIO, in this study, they would have used somewhere between 15 to 30 mg of PIO. You can see that the amount of weight gain is very minimal, very low hypoglycemia, the usual side effects associated with an SGLT2. On an average, meta-analysis has shown a good reduction in HbA1c with a weight reduction, a good reduction in systolic blood pressure with actually a reduction in heart failure. Two recent studies that I do have to point out, they looked at the CV effects of SGLT2 inhibitors and thiazolidinediones. The two trials that I'm going to show are large real-life data. And you can see this purple graph here. The purple graph is in people with diabetes who are on SGLT2 inhibitors and TZDs. And you can see that the 4P MACE reduction is the most in the group that received both these agents as compared to SGLT2 inhibitor alone, pioglitazone alone, or a group of patients with diabetes who are not on either drug. They had the highest 4P MACE event, and this combination group had the lowest 4P MACE event, also the lowest cardiovascular death. So no increase in cardiovascular death, same as the SGLT2 inhibitors. Similarly, non-fatal MI and non-fatal ischemic stroke came down. And a very recent study, which was published in October 2025, looking at the combination of pioglitazone and GLP-1RA, showed that all-cause mortality came down a relative risk reduction of 80%. I have a couple of slides, I'll finish up. MACE events also came down by about 80%. So significant reduction in, again, this dotted line at the bottom is a combination of pioglitazone and GLP-1 analog. This orange line is a GLP-1 analog alone. And look at this. This is about 2 lakh patients. This is a Taiwanese real-world data. 2 lakh patients followed up for 10 years. And contrary to, our worries thinking that pioglitazone is somehow going to increase the cardiovascular events, when combined with the GLP-1 analog in this study and when combined with the SGLT2 in the previous data that I showed, actually reduces all-cause mortality, reduces all cardiovascular mortality. We still need to be, this was a study that was done recently by Dr. Krishna, where he looked at the APRI score and the FIB-4 score, and he showed that the combination of an SGLT2 inhibitor and pioglitazone had better effect in reducing these scores and presumably improving the fatty liver as compared to pioglitazone alone or SGLT2 inhibitor alone, saying that the combination therapy seems to have better benefits in terms of reducing fatty liver also. The ADA still places pioglitazone where we need molecules for good glycemic control, and in people with MASLD. We do need to use it. We do need to be careful about bone fractures, so make sure that if you're going to keep someone on pioglitazone, monitor them with the bone density, make sure they're on adequate calcium and vitamin D. If necessary, put them on medications to protect their bones. The risk about bladder cancer, I think, has been laid to rest. Overall, there is no increased risk, but for cautious purposes, make sure that you get an ultrasound abdomen at baseline and monitor a urine routine. There is no risk. I don't think there is any risk, but just for, if you're planning to use it for more than, say, 10 years or 15 years, pioglitazone, because of its benefits, please make sure that you're monitoring these things. Elderly people, be careful with the heart, be careful with the risk of water retention, can be used in CKD. So this is the final slide. How do we know where to position pioglitazone? If it is a person with diabetes, high cardiorenal risk, like we've heard from previous speakers, SGLT2 inhibitors and GLP-1RA are preferred. But if you have someone with severe insulin resistance, MASLD, high risk of stroke, and if you're considering someone who is not lowering their HbA1c in spite of multiple agents, consider pioglitazone, making sure that you're monitoring them regularly or closely for the risk of edema, heart failure, and check their bones regularly. So I still think that pioglitazone has a role to play in a select group of patients, and it gives significant benefit in that group of patients, and we should not be depriving our patients who are going to benefit from it because of our worries. Certainly about the heart, I don't think we need to worry. It does not cause heart failure, but we have to be careful. Make sure you use it in a combination therapy, which may offset some of the side effects about pioglitazone. That is my last slide. I'll stop here and then answer the questions later. Thank you.
Thank you, madam. Now we will move on to the next session. I request Dr. Nandita Arun to take over the stage, please.
Thank you, Dr. Gauri, and very good morning, everyone. Always a pleasure to be part of debate. It's even more special when the organizing person and the person who's inviting you is your teacher. So Krishna sir was professor for both Anjana and me during our undergraduation and post-graduation days. So we've heard quite a bit about, in the previous two sessions, about the use of the older drugs, which are namely the sulfonylureas and pioglitazone, and when and how to use them in our management. If we think back a bit and think of our undergraduate days or our textbook learning of the pathophysiology of type 2 diabetes, it was pretty simple earlier, isn't it? We all used to learn that there is beta cell dysfunction, insulin resistance on one side, and insulin beta cell deficiency on the other. So it was always centered around the beta cells, and it was pretty simple. Looking now, we sort of fast forward 20 years later, when we think about the pathophysiology of type 2 diabetes, there's multiple levels to it. It is beyond the beta cells, and we've all come to learn that. We know that it is not just, even at the pancreatic level, it is not just the beta cells, but it's also the alpha cell hyperglucagonemia. There is the liver, of course, which is contributing to the insulin resistance, which we all knew. Then you have the kidney as a pathway, you have the brain contributing to it, so many levels of action which is actually contributing to that hyperglycemia. That being said, and now that we've understood that type 2 diabetes is more complex than it is, now that we've understood that the pathophysiology of hyperglycemia is beyond the beta cells, how can we restrict our treatment to just that, right? That being said, I will move on. So we also know that type 2 diabetes is a progressive condition, and as medicine has evolved, we now have multiple agents that has empowered us as clinicians to address these various pathophysiological features, and thus, as we looked at data even in the previous, some of the, what Dr. Jayashree was also presenting, we now are equipped with agents that are helping us reduce the risk of complications as well. So when we have a patient sitting across the table, we now know that it is not just about reducing the blood glucose, but also what agents we use that are equally important to achieve those targets. Which is why there is a paradigm shift, as you can see the title of the slide. There has been a shift in the approach to patients with type 2 diabetes. Yes, it was very glucose-centric earlier, and now we have not forgotten the glucose. The glucose still is the center point. However, it is a more comprehensive, patient-centric approach where we are looking at targeting multiple pathophysiological features, as I mentioned earlier, and we are looking at various factors to treat the patient, the age, the comorbidities, the body weight of the patient, the duration of diabetes, the risk of hypoglycemia, and last but not the least, the cost as well. So that being said, our guidelines have also evolved, and recently, the NICE guidelines, there was a bit of a, as this article is actually published in BMJ, which is a report in which what they've actually addressed is the shake-up, as you can see. I think the slide actually reads this. The shake-up in which the SGLT2s have actually been pushed so high in the ladder or in the entire guidelines. The SGLT2 and the incretin-based drugs, or the GLP-1s, have been pushed up so high that it's a literal shake-up in the guidelines if we compare it to our older guidelines. And for a valid reason, which is what we will discuss and we'll talk about. So when we look at the guidelines, we know that right here on the top is where you have, and we just saw the slide in the previous sessions as well, where the SGLT2 and the GLP-1s have been right on top because they address not just the pathophysiological features, but reduced risk of complications. So keeping the patient in mind, keeping the comorbidities in mind, choose the right drug. Similarly, before I move on to this, similarly, it is not just restricted to anti-diabetic guidelines or the ADA or the ASD guidelines. Not just the diabetologists who are moving towards this, but also the cardiologists. So this is the American Heart Association or the AHA guidelines. And we know that the scope of these drugs, the SGLT2, has now expanded beyond just diabetology or endocrinology, isn't it? Even cardiologists have started using it. And for valid reasons again. So here you can see the AHA guidelines where SGLT2 inhibitors have actually been used in the prevention of heart failure in people with diabetes or even without. And beyond that, nephrology. So this is the KDIGO, the guidelines of 2022, or even these are the latest guidelines in which you see that SGLT2 inhibitors again have been pushed up even above the DPP-4 insulin. And this is in patients with diabetic kidney disease. Again, the EGFR. Now, there's one fine point over here. The efficacy of SGLT2s is dependent on the renal threshold. So this point over here that we have to keep in mind, the fact that the EGFR of less than 20 we need to stop, is the reason being that the efficacy of, or less than 45 was initially the cutoff that we thought. So the efficacy of an SGLT2 is dependent on the renal capacity, because at the end of the day, these are promoting glucose-urea and achieving glycemic targets. So if you have a patient in whom you want to achieve glycemic control with an EGFR of less than 40 or 45, yes, you're going to get renal benefit, but you are not going to get glycemic benefit because their renal capacity or the capacity to reduce the blood glucose is not going to be as much. However, between an EGFR of 40 to even up to 20, which is the cutoff below which we need to not initiate an SGLT2, you are actually going to get renal benefit. So the renal benefit is across the spectrum of EGFR, whereas the glycemic benefit is up to an EGFR of around 40 to 45. Similarly, the ESI or the RSSDI guidelines also has sort of, you can see that there is SGLT2 almost all through the circle. So all the guidelines have accepted that the SGLT2, the newer agents, are here to stay, and they do give us benefit beyond just the glycemic control. Now, why is this so, is what we need to discuss. Of course, we've all been hearing so much about the CVOTs, the cardiovascular outcomes from all these trials, but are they, as we've been seeing in the guidelines, being pushed up? Are we doing justice by just initiating an SGLT2 and then sitting back and saying, oh, okay, I've done my bit? Not really, and that is what we are looking at. Of course, the benefit of SGLT2, the mechanism of action, of course, we know. I think I will probably just quickly go through the slide. We know that SGLT2s work through glucose-urea, as I mentioned earlier, based on the renal threshold. So they reduce blood glucose. They reduce body fat, because there is, with glucose loss, there is calorie loss, so there is reduction in body weight, body fat. Increase uricosuriya, and with the natriuresis, there is reduction in plasma volume, reduced preload, which is one of the mechanisms through which they actually help with heart failure, reduction in blood pressure, arterial stiffness, and tuberoglomerular feedback, which then improves your renal outcomes as well. So these are the various levels of action of the SGLT2 inhibitors. But beyond the glycemic benefit is what I was talking about earlier. So, of course, they reduce glycemic HbA1c, but they also reduce glycemic variability. They improve beta cell function and preserve beta cell function, because the action is sparing the beta cells, effectively reduce body weight, improve insulin resistance, improved lipid profiles. Cardiovascular benefit is of course accepted, and improvement in chronic kidney disease, reduction in blood pressure. So it is rightly so, because of all these benefits, that the SGLT2 inhibitors have been pushed up in the ladder, because they're giving you benefit beyond the blood glucose. And that is exactly what this slide also sort of summarizes. But like I said earlier, now we cannot just initiate an SGLT2 and then sit back and say, oh, my job is done. Which is where combination therapy is extremely crucial, because we know that yes, we cannot shy away from the fact that our old is gold, that our older agents also as combination will help complement the benefit that these newer agents will give us. Like ma'am was showing us in the previous slide, Dr. Jayshish was showing that SGLT2, if you noticed in that real world evidence, pioglitazone alone, or I think the other one was placebo or standard of care, pioglitazone alone did not give you the benefit. But when you combine the two, when you combine pioglitazone with the SGLT2, you get benefit beyond doubt. SGLT2 alone also did give benefit, and there was in fact, both the curves did sort of coincide. You didn't even see the difference between the two. But, so that being said, that's what the slide tells you here, that synergy is key. And you know that we, like I said earlier, we cannot shy away from the fact that we still do need our older agents. So combining your SGLT2 with metformin would be one of the ideal initiating combinations for your agent, for your patients. So when we combine the two, you're going to get benefit beyond doubt, and this is Indian data called the ADMIRE study, in which they've looked at baseline HbA1c of around 9.3 and combined DAPA and metformin in patients who, as first-line therapy, found around 2% reduction in HbA1c and around 4 kgs reduction in body weight. Beyond that, when we combine a DPP4 and an SGLT2, so previous one we looked at DAPA with metformin combination, now we're looking at incretin base with dapagliflozin. And this is, I think, sort of like a marriage made in heaven. This is probably the best combination for this, and why is what this slide shows you. DPP4 on one side with dapagliflozin or your SGLT2 on the other side. Both these drugs are fantastic agents in their own ways. So when we combine the two, you get benefit beyond what you can even imagine in terms of beyond just the glycemic benefit. How is that? Your DPP4, both these agents act beta cell sparingly. What does that mean? Your DPP4 inhibitors are going to act in a glucose-dependent action. Your SGLT2 inhibitors are going to act through your renal or glucose urea. So both are going to give you the benefit of glycemic benefit or reduction in HbA1c without the risk of hypoglycemia, number one. Number two, like I said, sparing your beta cells or preserving your beta cells. And we know that that is a big concern in our patients with type 2 diabetes. Now, when it comes to reduction in complications, you know that the SGLT2 inhibitors have proven, like I showed you data in the previous slides, that it reduces cardiovascular risk, improves renal outcomes. Similarly, the DPP4 inhibitors have also proved their cardiovascular safety, whether it is CETA, VILDA, or LINA, they have proven CV safety, and LINA also has some benefit in renal outcomes as well. So when we combine the two, what do we see? And here again, we have Indian data in which we're looking at a combination of vildagliptin with dapagliflozin. And we're looking at reduction in HbA1c across spectrum of ranges of HbA1c. The higher the HbA1c, the better the reduction in A1c. Beyond that, you also see reduction in body weight, and the body weight reduction is across up to almost more than even 5 kilograms, minimum of 2 kgs. So your DAPA is helping you lose weight, and when you combine that with, or SGLT2, when you combine that with a DPP4, which is weight neutral, you're going to get that weight reduction. Similarly, if you combine it with a weight gaining agent like pioglitazone or insulin, you're probably going to have some weight gain. But here, when you combine it with a weight neutral agent, you're going to see more of weight loss than anything else. Similarly, combining dapagliflozin with sitagliptin resulted in HbA1c reduction from 7.9 to 7.4%, reduction in fasting plasma glucose. Also, combining with sitagliptin, so, you know, when I was going through this data, I actually called one of the medical advisors, Dr. Smriti, she's here today from US. And so I was asking her, Smriti, what is the, you've put in here, we're looking at data of DAPA with CETA, DAPA with VILDA, and then we're looking at EMPA with LINA, EMPA. So I said, is there any combination that is not there? So she said, no, ma'am, there is everything. You have your DAPA CETA, DAPA VILDA, DAPA LINA, and then you have EMPA LINA, EMPA CETA, you know, permutation, combination, however you want is available. So the next couple of slides, data I'm showing you is to back that up. And most of it is Indian data, which is fantastic. You're looking at DAPA and CETA, which actually improves not just blood glucose, but also improves your time in range. This is something which is interesting. So one of our biggest concerns with the SGLT2 inhibitors is the genitourinary infections, and there is some data to show that when we combine the two, the SGLT2 and the DPP4 inhibitors, the risk of genitourinary infections actually comes down. The explanation behind this has not been very clear, but you do have, and this is a meta-analysis to actually show, you see the forest plot where there is a clear reduction in the genitourinary infections. I don't know how far we see that in our clinical practice, but it is something that is shown. So similarly, empagliflozin combinations, as I mentioned earlier, the benefit of EMPA as a molecule has been well established. Combining EMPA with LINA gives you, again, HbA1c reduction over 52 weeks. This is a fantastic paper that's Diabetes Care, in which they've shown the EMPA-LINA FDC reduces not just HbA1c, and the reduction in HbA1c, as you can see, is across the spectrum of not just very high HbA1c, but from baseline up to 0.9. Change in body weight, again, when you combine the two. Change in systolic blood pressure, when you combine EMPA-25 with LINA-5. Yeah, I think this is my last slide. So what is this benefit that we're getting when we combine an SGLT2 with metformin, SGLT2 with DPP4, and why have the guidelines pushed them up right up on the ladder? For valid reasons, because as I said earlier, we are now in an era where we have realized that treating type 2 diabetes is much more complex than just the beta cells. We do need agents that address multiple pathophysiological features. So initiating with just one agent is quite often not enough, number one. Combination therapy is probably the best way forward because we're going to be addressing multiple pathophysiological features. And when it comes to SGLT2 DPP4 combination, as I mentioned earlier, you get multiple benefits beyond just HbA1c reduction. We get reduction in body weight, reduction in pleiotropic benefits, including cardiovascular risk reduction and renal protection, lower risk of hypoglycemia. So with all these benefits, and last but not the least, when we use these FDCs, we know that type 2 diabetes being a chronic condition, which is quite a burden for our patients to be taking when they have large number of pills, these FDCs do reduce the pill burden. So as clinicians, we quite often find ourselves looking for that loophole where we can reduce the pill burden for our patients, which in turn is going to help improve adherence and reduce complications and improve outcomes in our patients. Thank you.
Thank you, madam. May I request all the three speakers to come on the stage, please? We have time for a couple of questions.
I thank everybody for a wonderful speech. Ma'am, about sulfonylureas, like what about low dose sulfonylureas? Because there was a time when I heard your father speak and say like a small dose of sulfonylurea should be continued even during insulin because it keeps the beta cell alive. So what's your take on low dose sulfonylureas?
Is this working? Is this working? Yes. Okay, so I did mention that in my talk. Low-dose sulfonylurea, I think, is a very good idea, simply because we had data to show that, number one, it preserves beta cell. Number two, it brings down your insulin dosage. So the amount of insulin that you're giving this person is definitely going to come down. Number three. Number two, because of that, if you use the modern ones, glycoside, the modern ones, they have that reversible binding. So it doesn't have all, the side effects are less with hypo, with weight gain, and all of that. So it's definitely something that I would recommend.
Now that we have DPP4, which also works on the beta cells, does it work differently? Yeah. Like, should it be this thing?
So I did show along with DPP4, so it has synergistic effects. So there's no need. So as a first line, it depends on your patient. If cost is a consideration, where you're treating this patient, so if you would start with sulfonylurea, you could always add a DPP4, and that is a very common prescription that we would do. So they have synergistic effects and complementary effects.
Ma'am, and you there's a group of patients, mainly women, even in the postmenopausal age group, where they only respond. You give pioglitazone, they do gain weight. You take that out, they come down in weight, but their control goes away. You need to go tell insulin to get them under control. In that scenario, would you still continue, or like due to osteoporosis, you need to take it out?
So I actually continue because there are some women, and no matter what you do, like you said, unless you give them pioglitazone, sugars just don't come down. So they respond very, very well. I monitor their BMD. If they have mild osteoporosis, osteopenia, I put them on the osteoporosis treatment. I start doing that anyway, because a person with diabetes, you need to do it anyway. And then I monitor. I tell them that, look, this is a concern, but considering that you're responding so well to it, so I monitor their echo, I monitor their DEXA, I just keep monitoring and continue. Yeah. So what I do is I usually try a 7.5. Sometimes I do things which are completely off-label, like alternate day 7.5. Whatever minimal dose keeps them under control. But if 15 mg is the only one that's working and they're not really gaining, you know, you have this lean group of people with diabetes who respond well to the 15 mg, don't really gain a lot of weight, continue. That is the group where they'll do well when you combine it with SGLT2 and a GLP-1.
If I could just add a point there, I think, ma'am, if you'd agree with me that the glycemic benefit that pioglitazone offers is probably dose dependent. However, the side effects, especially the weight gain and the fluid retention, quite often is not dose dependent. Even with the 7.5, the weight gain that you see with the fat redistribution or the abdominal thing is actually comparable to that you would see with 15 mg.
And a quick one about the lean diabetic that we were talking about. While they are lean, we now know that they have unfavorable fat distribution. So actually in those patients, the pio may be a good option because of this liver fat and this unfavorable. While they are lean, that is a problem that they still have.
Yeah, Anjana, yeah. I think we have modern sulfonylurea, both glimepiride and glycoside is there. Glycoside is coming in extended release. That's what we have low risk of hypoglycemia. Why not with glimepiride? That extended release has not come. And which patient do you prefer for glimepiride and glycoside?
So it depends again. Now why they don't have the extended release, we have to ask the manufacturers. I'm not the person to answer that. Regarding whether to use glycoside or not, so wherever you need the short acting, glycoside has clear benefits. It has cardiovascular benefits, it has benefits on certain CKD parameters, etc. So in older people, etc., definitely go for glycoside. In a younger patient with less of the this issues, there you can go for glimepiride. So again, it depends on the patient. There's not too much to differentiate, but there are minor differentiating points between the two.
Thank you. And thing about pioglitazone, I think you're not talked about the anemia, which is commonly seen with pioglitazone. Your comments.
So, I mean, I think that was felt to be due to the water retention diluting down the hemoglobin. I think that happens also with metformin much more commonly because of the B12 deficiency. But yeah, it's a good point. It's something to watch out for.
So we need to add any folic acid or something.
I mean, I think most people are anyway on a multivitamin. Make sure that but I would first check their parameters, the iron and the B12 and all that, and see if they're truly deficient. And I don't think we see a significant drop in the hemoglobin. Maybe it'll go from say 11 to 10.5
In the long duration,
maximum.
the long run we see now, because it's almost more than 2.5 decades now.
Yes.
And many patients are there. And this question again I wanted to, I think what is the duration you see with pioglitazone, the side effects after how many years or duration?
The side effects start almost immediately.
That's what.
Within a few weeks to months, the people are going to gain weight and the water retention, it happens almost immediately. It's nothing to do with the duration. And then it settles.
Yeah, I know.
Once they get over that little, the first 6 months of that thing, not that they lose it, but they don't continue to gain. After they have that initial spurt, it then stabilizes.
And
Thank you, madam. Sir, Sellapanian, sir, we will finish the
Last
session.
question, yeah.
No. Sir, thank you, sir. Thank you, Jayashree Gopal, madam. Thank you, Dr. Nandita. Dr. Anjana can be seated. May I request for the next session, Dr. Shrutish Chandrasekhar and Dr. Usha Ayagiri, madam, to the stage, please.
Good morning, everyone, and welcome to this session on nutrition, diabetes-specific nutrition. There it is. This symposium is sponsored by Messrs. Abbott Nutrition. So I'd like to start by saying that we have a lot of diabetes in India. We've already talked about that. But what we've not talked about is how many people meet the ABC goals in our country, and only 35% of people have an A1C of less than 7. We also know that you have the slideshow here, is it? Okay. Wait, I'll do it. It's not working. Okay, that's better. So we were talking about why people were not reaching their A1C targets. We today know that diet and physical activity alone can explain about 50% of diabetes in this country. So let's move to diet. And this was a paper from the ICMR INDIAB study that came out in Nature Medicine in 2025, which talks about the various macronutrients that are shown here. The first one is carbohydrate. 62% of everything the Asian Indian eats is carbohydrate. So it can be North India, South India, doesn't matter. Here you have every state of the country done region-wise, north, south, east, west, doesn't matter. Carbohydrate intake is high. Out of this total refined carbohydrate, white rice is 90% of everything that is eaten. What about millets? Only 3 states in the country report a millet intake of more than 30%. That's Karnataka, Gujarat, and Maharashtra. The rest of it, it's very high refined intake, white rice or refined wheat. Now, what about sugar? Sugar should be less than 5% of what you need to, of the total calories. Which are the states that are meeting that? Somehow Tamil Nadu meets that, not sure how that happened, but Tamil Nadu, Chandigarh, and in the northeast states meet this. So that's about carb. Now when you go to fat, we talk about how much fat should be there. It should be about 25% to less than 30%, and overall we are fine with that. But then when you look at saturated fat, that should be less than 7%. How many states actually meet that? Only 4 in the entire country: Jharkhand, Chhattisgarh, Arunachal, and Manipur. So what is the story so far? Refined grain, lot of sugar, saturated fat. Now let's look at protein. Protein is low, and the national average is 12%. The highest consumption is in the northeast, but overall the protein intake is low. What we also show is that somehow, even if you have a lot of refined grain, like a lot of white rice, refined rice, if you increase your protein intake, it helps with the glycemia. It lowers the sugar, it decreases your diabetes risk overall. So that is the overall source of all the protein that we take. Plant protein is the major one. Animal protein, the benefits we see are for primarily for fish, egg and chicken are neutral. So what we show here is that in order to decrease diabetes and obesity risk, just decrease 5% of the carbohydrate and replace it with protein. Which protein? Doesn't matter. Any protein is all right. Best effect is for plant protein. If you add dairy protein, it has synergistic effect. Animal protein, I told you which were the good ones. Fish was the best. So reduce the carbohydrate. So we have too much of carbohydrate, too much of saturated fat, too low protein. So when you reduce the carbohydrate, do not replace with fat because that increases your risk. Replace it with protein. That is what we're saying. So these are the recommendations for diet. Decrease the carbohydrate to about 50% of energy intake. Protein should be about 20%. Today it's at 12. Fat needs to be about 25, where it is. And fiber is at 3.5%. That needs to double and go to 6%. So these are the recommendations for cardiovascular risk and metabolic health. Now, how do you achieve this? This is really hard to achieve in normal circumstances with a normal diet. But if you add certain elements like a diabetes-specific nutrition formula, you are able to achieve these much easier. So in this particular DSN formula, there's a unique blend of carbohydrates that gives you slowly digested carbohydrates, so you don't have that peak happening with the GI. The overall reported GI is about 33, I think, which is low GI. You have myo-inositol, which I'll talk about in a minute, isomaltulose, and soluble and insoluble fiber. I'll take you through the protein blend, the fat, and the micronutrients. So why is this myo-inositol very important? Now you know that the GLUT4 transporters are the ones that take glucose into the cell. If you have this, and this is coming from this blend, it upregulates the GLUT4. So if there's upregulation of GLUT4, there's increased glucose uptake into the muscle, into the cells, decreasing the blood glucose. So that's one way in which it works. Remember, we talked about doubling the fiber intake. This is an easy way to do it. This has a combination of soluble and insoluble fiber, so it's got complementary effects. Fiber can make you very bloated. It can give you some, it can give you a lot of side effects. So if you have this kind of balance, it helps with that kind of bloating. It helps you to reduce weight. The inflammation comes down, the energy density comes down, satiety goes up, the bulking effect goes down. It also helps to bring down the glucose and the cholesterol. Now, what about the fat? Remember, we said so much about saturated fat. Here's a way to improve your good fats, which is PUFA and MUFA. So people talk about PUFA a lot. In India, we're very MUFA deficient. And what can give you this is basically nuts. These are all quite expensive. So this is an easy way here to increase your MUFA content. It gives you 10 to 20% of MUFA just from the drink that you have. And of course, these are heart healthy, improves insulin resistance and beta cell function, as well as your lipid profile. So it does have a heart healthy blend. The last one's about protein. So we do know, I just said before, that increasing protein will decrease your glucose. Here you have casein and soy, a combination of these, and these help in insulin responses, the postprandial glucose, the insulin resistance, etc. So it does have a beneficial effect. Also, the micronutrients, we keep giving people a lot of these multivitamins. Lately, there's a lot of testing also going on, cerealium, beryllium. I have no idea why we test all these things. Does anyone know why we test all this? Don't you all have patients coming with all that? But anyway, if you give all the micronutrients covered in a single shot, you don't have to keep giving capsules. So how do you dose this? Again, it depends on your patient. If you have someone with obesity and you're calorie restricting, remember this is low calorie, only 250 calories per serve. You can make it as a meal replacement. Depends on which meal, depends on the patient. You have to work with them. If needed, you can do a snack as well. For someone who's underweight and trying to gain weight, trying to increase the muscle mass, you can give 2 serves a day because it's 9 grams of protein per serve. So you can increase, a very, very good way to increase your protein. So remember, fiber goes up, protein grows up, calorie is down. It's a good blend to have. And for those who are normal weight and just looking at, it depends on protein substitution, calories, it depends on the weight. There's a lot of ways that you can play around with this. So I'm going to stop here and call Shruti to take the case 1.
Thank you, Dr. Anjana, for setting the stage. Very good morning to one and all. We all thank Abbott for having us here for this nutritional symposium this morning. So I will be talking on the first clinical case presentation. We will also show some unpublished data that we have in terms of diabetic remission from Dr. Mohan sir's group. Dr. Anjana will be talking about I think it just got accepted for publication yesterday. So she'll also talk about the real life paper for the remission of diabetes from their center. So with this, I'll start from case number 1. So this is a 45-year-old gentleman who's an IT professional. He's been diagnosed diabetes very recently in a routine health checkup. Fairly not very bad, new onset diabetes. He's currently on metformin and he is on diabetic dietary meal plan. And he's also having moderate, is pretty good, moderate intensity physical activity for 150 minutes per week. So this patient, when we talk about a patient like this who presents to you for the first time in your clinic, the goals are very simple here. So we can talk about diabetic remission, we can get a better tight glycemic control to begin with, hit them hard, hit them early. Predominantly, talk about lifestyle intervention, the chronobiology, exercise, the protein, adequate protein intake to help them with remission. And overall, if we could achieve this, what we are trying to do here is to reduce the risk of complications because of diabetes. So the question that we have here right now is somebody like this, newly diagnosed patients with diabetes, can they achieve remission with the nutritional therapy, medical MNT, the medical nutrition therapy? So for this, I'm going to ask Dr. Anjana to present her recent data as well, which just got accepted for publication.
Thank you, Shruti. So this is about spontaneous remission, real-world remission. So far, you would have heard about remission, which happens with a lot of effort, sometimes with drugs, with the GLP-1. Here we are talking about a real-world scenario of 2 lakh-ish patients who went through remission simply through lifestyle changes, diet and physical activity. Remember, I started off by saying that diet and physical activity alone could prevent 50% of diabetes. These are people who did it. So let's look at what they did. So we divided these people into those who had an A1C of less than 7. There's no pointer here. May I have a pointer? Oh. So we have A1C of less than 7, 7 to 8, and more than 8. Now we see that those who underwent remission, and a total in 2.7 years, we had 0.1%. This is spontaneous remission without effort. 0.1% remission, and 2 years after that, we saw that 80% of these people relapsed. So we have those who underwent remission, stayed in remission, and those who underwent remission and relapsed. So these are the groups of people. Let's look at what happened. Those who had A1C less than 7 were those who went into remission. So what are the characteristics of these people? They had shorter duration of diabetes, they had better C-peptides, they had lower A1C, they generally had healthier lifestyle, no smoking, no alcohol, less family history of diabetes, more physical activity. That came out as very, very significant. And of course, dietary related. Their calorie intake was lower and their protein intake was high. We go on talking about this protein. Their protein intake was higher. So these are the people who went into remission. Now, if you look at those who had an A1C in 8, a smaller group compared to this went into remission and a larger group relapsed. So these are people who are more progressed in their disease. Then if we look at how long these people were in remission, most people who went into spontaneous remission stayed there for 1 year. Then you have others also 2 years, 3 years, 4 years, 5 years. By the time you come to 8 years and all, it's a very small group of people who stay in remission without an extra effort. But the important point here is the complications. Now here are people who never were retaining the remission, went into remission, stayed in remission, that's blue, relapse, and never went into remission. So the gray is the no remission. Compared to the no remission, even if you went into remission for a short period of time, your complications came down tremendously. And that's what this says. So look at the difference between the bars. Of course, if you stayed in remission, your complication risk came down. But even if you relapsed, if you went into remission even for a small period of time, your complication risk went down. So what about body weight and remission? These are the people who went into remission and stayed there. So they lost 11 kilos in weight, and over a 6-7 year period, they regained only 2 kg. So they lost weight and didn't regain so much. Whereas others who went into relapse, they lost like 7 kg and regained 5. So if you regain that weight, it pushes you towards your increase in diabetes risk again. And these are the guys who never went into remission at all. So clearly that weight relationship is also being shown. So that's about the spontaneous remission. Shruti, I'll call you.
That was a very interesting data, 0.1% going for remission, but it's very hard to maintain the remission. I think this is something that we see in our practice as well, very, very related. But if we could incorporate the DSN formula, how does it manage? Do we have data for how does DSN formula aid in managing the blood sugar levels? Basically, it's just being on calorie deficit. If you're on a calorie deficit, you will lose weight. And you will also sort of reverse your metabolic. And we have seen this not just from diabetic perspective, this is true in PCOS, improvement in ovulation, fertility, MAFLD, same concept, right? Be on a calorie deficit, eat less, move more, and sort of have good balanced protein and fiber and cut down your carbohydrates. That is a simple mantra that we sort of, have to aim for. Cut down your carbs by 20 to 25%. If you could do that, a lot of our patients, even personal level from us as well, physicians and doctors, and we can also do that, right? So the DSN formula, what the evidence from DSN helps here is sort of when people are put on one diabetic specific nutrition as a meal replacement. Anjana showed how these formulas can be used as a meal replacement or as a snacking. You can do 6 scoops and give this as a meal replacement in the morning. That would be your breakfast. So if you could do that or any specific meal, it sort of helps reduce. You're basically on a calorie deficit, right? You're having good fiber, carbs that are essential. So she talked about the myo-inositol and all the essential fibrosol. So you're basically having a calorie deficit here that sort of helps reduce the HbA1c as shown in this study here, and also a reduction in the fasting blood glucose in patients with overweight. So basically being on calorie deficit with a diabetic specific nutrition as a meal replacement therapy in patients with overweight and obesity, in sort of helping with diabetes and fasting blood sugar. This paper is again from Dr. Mohan Sir's group, showing in terms of reduction in the mean amplitude glucose excursion in patients. If you see this, the data from the CGM, with patients who were on the intervention arm to the control arm, were put on diabetic specific nutrition as a meal replacement to control the intake of food, showed a significant reduction in the mean amplitude of glucose excursion. The question is, does this also reduce the cardiometabolic risk? And that is exactly what we are talking. I think the entire debate is about, obesity, weight loss, cutting down the cardiovascular risk. So once you sort of achieve this, once you are able to reduce your waist circumference, balance your weight, you not only see an improvement in your blood glucose level, but you're also going to have this improvement in the cardiometabolic risk in terms of blood pressure, an improvement in triglycerides, and an improvement in HDL cholesterol. And this overall would sort of translate to a better cardiometabolic risk factor reduction. And in terms of what we have in terms of evidence with the diabetic specific nutritional formulas, in terms of better glucose management and lipid metabolism, is you not only have an improvement in the postprandial blood glucose reduction because of the constituent that is given as DSN. It also shows a decrease in glucose variability, improvement in the blood glucose data, and also a reduction in the triglycerides and improvement in the HDL cholesterol, sort of translating to a cardiovascular benefits. So is this, she already showed you how myo-inositol works. Myo-inositol has also been, a lot of times we also debate about myo-inositol in the setting of PCOS in sort of insulin resistance to improve the ovulation. It's routinely used by gynecologists. They have a strong data with myo-inositol improving the insulin resistance in polycystic, especially in the perspects to fertility. I have very few women doing well, even from the hyperandrogenism part of it, even though the data is not very clear with myo-inositol in sort of in that setting. But here, if you have a DSN that also has the myo-inositol that Dr. Anjana already showed in her initial presentation, not only it just shows that there is a reduction in, if you look here, the DSN formula now has been, upgraded. The newer formulas that we have, the DSN, as also as myo-inositol up to about 2 grams, had significant lower insulin positive over the area under the curve. So it's sort of showing that there's an improvement in the insulin sensitivity and also an improvement in the beta cell function with formulas that are specifically added with myo-inositol. So with this, I will summarize this case by saying that it can be a standard of care in patients like this. The whole idea is to be on a calorie deficit. How you do it depends on your patient and the interaction that you have with your patients. If you could do it, certainly you can, help your patients or have them remission, but it's very important for them to sort of maintain that. I think that's the most important thing. How long can somebody be on this? How do we use this in practice? What are the real life experience? We have a lot of time. After Dr. Usha presents, we can probably have your experience on how do you use it. How long is long, we don't know, but if we could do that, can we reduce the complications for our patients by sort of helping them with remission, and importantly, sort of helping our patients maintain the remission, not just lose track, but also sort of maintain what they have achieved. With this, I'm going to hand over the session to Dr. Usha.
Thank you, Shruti. So let me start by first asking you, how many of you have used any kind of diabetes-specific nutrition or meal replacement in your clinical practice to date? Show of hands. Okay, I think 3 people. And I'm going to just make this a little bit more interactive. We do have enough time. I mean, we have another 25, 26 minutes. So if anybody would like to come up to the mic, what sort of a patient would you select diabetes-specific nutrition? I mean, 3 people raised your hand, so any one of you. Come up, madam. Yes, I can see you're getting up. Come. Nice. Come up, introduce yourself, and look, we are all here to learn from each other, and I would rather make this case interactive than just throw didactic data at you. So, yes.
Yeah, good morning.
Can we just lower that a little so that I can hear it?
Good morning. Yeah, I'm Dr. Manju from Bangalore.
Yes.
Yeah. So, using DSN's nutrition in my diabetic patients.
Whom do you use it in?
So, particularly in those people, one is who are struggling to bring down their HbA1c.
Okay, so where sugar control is bad, glycemic
bad.
Control, okay.
And also, who also have a problem of obesity.
So weight and glucose. Anything else?
And definitely where the muscle protein intake is less.
Okay, so I think all valid good reasons. Anything different from? No, okay. Thank you so much. Thank you, Dr. Manjula. So we have a case here and I'll go through this, but I think this isn't an exceptional case. This is like most of us most days. 7-year history of diabetes, hypertension for the last 3 years, desk job, sedentary, which describes every single one of this in this room. We are all desk bound, obese and has been on semaglutide for 3 months, experiencing some side effects as you can see, loss of appetite, nausea, fatigue. Blood pressure, I would say suboptimally controlled at 135/92. Overweight with a BMI of 26.3, and you can see submaximal dose of semaglutide, okay with the DAPA, metformin and telmisartan. So in this kind of patient, what are our treatment goals? Throw it out. What do I want to do in this patient? What do you want to improve? This is like the examiner taking the question paper. No, examiners don't get to participate in the question paper. No Abbott team and no panelists, please, everybody else. No Abbott medical and no panelists, everybody else. Come on, guys. Otherwise, I can just deliver the lecture and it will be boring. Yes, so his A1C needs to improve. What else? Exactly, he needs to exercise. Those are, and yes, what else? I see some big number there that nobody is talking to me about. Yes, go on, shout it out. Absolutely. But you also said, doctor said, postprandial sugars, 240. Now, sometimes addressing that A1C, the PPG becomes our worst enemy. It can be really difficult to get those down. 3 meals, 3 times 250s, and it's so difficult to get that down. And as you said, weight management. So in this patient, we need to improve their blood pressure, their weight, their glycemia, and especially with the focus on their PPG. So for somebody like this, and yes, nutritional deficiencies, if any, we need to address, but we've got everything. But we want to do this without any negative effects, including no sarcopenia, because we know that as Asians, we start with sarcopenia, we don't have enough muscle mass, and then when you lose weight, unless you're strength training, for every kilo that you lose, 40% of what you lose can be muscle. And then when you regain, you put on pure fat. So every subsequent attempt really makes it more sarcopenic and more difficult to lose weight. So in this kind of a situation, would a diabetic specific formula help? So we said improvement in weight. Well, you can see that when you use a diabetes specific formula, you do get some improvement in weight, maybe about a 6% change in weight, which you do regain a little, but most of the lost weight is sustained. Similarly, you can see an absolute change in A1C by month 6, and again there may be a little loss of control, but most of the benefits are sustained compared to people who are not on. So this is usual care, this is diabetes specific nutrition, right? So you do get a benefit in 2 out of the 4 things we discussed, both in weight and in glycemic control. But more importantly, you can see that the visceral adipose tissue actually comes down. So your waist circumference and your obesity levels do come down with the diabetes specific formula. How many of you are familiar with the Look Ahead trial? We've discussed it in every single forum. Yeah? What was the intervention used in Look Ahead? Look Ahead was a meal replacement plan. It was a diabetes-specific nutrition, and we know that they lost around 11% weight and that they went into remission in terms of the newly diagnosed diabetes, right? So it can work. But then we know that people who have any kind of a nutritional intervention, the diet becomes restrictive, and when the diet becomes restrictive, you do get deficiencies. Most commonly in our population, vitamin D, vitamin B12, especially if they're also on metformin, and iron. These are common in our population apart from all the other trace elements. So if you have something that can add in those nutritional micronutrients, that then to some degree mitigates the nutritional loss. We also know that anything we can do to prevent muscle loss is good, but let me tell you, no DSN is better than strength training. Every single, how many of you strength train? Again, excuse me, you set the exam paper and you give the answers, you're excluded. Okay, don't look at them, look here. Okay, I'm not getting any hands. No, okay, 1, 2, 3, 4, 5 out of maybe 70 odd people. Can we just say, physician, heal thyself, practice what you preach, every single one of you go do some strength training. So we know that there is a proportion of lean body mass muscle that is lost, 40% at the minimum, potentially more. So if we can use a meal replacement plan that will mitigate loss, that is then good. Now, you have meal replacements, diabetes-specific nutritions that can actually be used in combination. So we said our patient is on a semaglutide. Does that exclude a meal replacement? No, because we can quite easily combine a meal replacement, and where we are putting in a meal replacement, if you have an insulin or a sulfonylurea, we can actually reduce those. But you can safely combine this with any given diabetes-specific drug, including insulin. And the combined therapy, you just adjust everything else to mitigate the side effects. You can use it during the weight loss phase, you can use it during the weight maintenance phase, you can also continue the meal replacement therapy after you discontinue other weight loss drugs like GLP-1 receptor agonists, right? So at any stage, you can use these. If we look at sarcopenia, one of the ways of measuring sarcopenia is frailty. Now, the frailty can be measured by various scores. One of the scores I'm going to show you is called the FAST score. We know that elderly have frailty partly due to sarcopenia. Along with the sarcopenia, you then get core instability, which leads to gait disturbances. They fall, and then their bones are already frail, they break. And we know that, for example, mortality from hip fractures remains high. So in this kind of a situation, can we again do anything to mitigate it? So if you look at frailty, proportion of subjects who are frail is quite high. You can see the percentages, male, female, and overall. The scores are down there. 0 to 4 is robust, pre-frail is 5 to 6, and 7 to 14 is frail. And it measures across 10 domains using 14 simple questions, takes a few minutes to complete. And you have a high proportion, a quarter, nearly 20% to a quarter of our men and women who are frail or pre-frail, thus putting them at much higher risk of falls and comorbidity associated with that. Again, if you use hand grip to measure, you can see that the frailty is more than 50% in both men and women, and if you combine frailty and pre-frail, that's nearly 100% across the spectrum. So in this kind of a situation, you really want to mitigate the amount of muscle loss, and you can see the higher your A1C, the worse your frailty scores by hand grip score. So this diabetes-specific formula can actually preferentially preserve fat-free mass, so as a surrogate, if you will, for improving muscle mass, but nothing will improve it without strength training. Please do not think that I'm telling you that if you give this, that's okay, they will preserve their muscle mass. You still need to advise them to strength train. There is no substitute for that. So as you can see, with the formula versus the controls, there is a change in fat-free mass and a preservation of your lean mass. So if I'm going to summarize, I'm going to say that as we started at the beginning, it will improve your glycemic control. It can actually help quite nicely with postprandial control. It reduces the risk of nutritional deficiencies. It does help with the weight loss. I'm going to put a question mark. I know this is an Abbott-sponsored talk and the slides are Abbott-sponsored, but I'm not going to say preserve muscle mass. I'm going to say it gives you a chance to mitigate the muscle loss, and it gives you a chance to counsel them properly to actually preserve the muscle mass. Now, I'm going to stop on this last slide. Dr. Anjana will summarize, and then we're going to throw it open. We have at least another 12-15 minutes to the audience to then interact and ask us questions. All yours.
Okay, so I think we have made some specific points about DSN in the last, 30 minutes-ish. So DSN is part of the medical nutrition therapy considered as integral. So we said diet and physical activity, 50% of diabetes and glycemic control. So we're talking about DSN being a part of that MNT. The advanced formula that we have today takes care of the recommendations for diabetes specific nutrition. So what is the recommendation? Carbs should stay at 50%. It's got a good blend of slow releasing carbs, right? It's got myoinositol, which will help in the GLUT4 translocation. What about fiber? Fiber needs doubling. An easy way to do a good kind of fiber that does not produce any GI upset. We said protein needs to go up. It's got a good blend of protein, gives you 9 grams of protein per serve. And fat, it doesn't decrease the saturated fat, but if you increase your good fats, the ratio of your saturated fat will also come down. So that combination is a winning one. It helps to improve glycemic control. It helps in weight loss, and that's what everybody was talking about, using it for both of these, the diabetes and thus the risk of all the cardiometabolic complications, and everybody showed you that. Now, how much do you give? Again, it depends on the patient, 1 to 2 servings per day, depending on the requirement, what you're using it for, whether it's calorie deficit, whether it's protein intake, etc. And in patients with newly diagnosed diabetes, we can use it for remission, because we did show what are the elements that are needed for remission, and all of them are present basically in the DSN formula. So remission is very important, because even a little time in remission helps you with the micro and macrovascular complications. Today is the era of GLP-1. So one of the main problems that we have with the GLP-1 is sarcopenia. This helps to reduce the nutritional deficiency and helps in the muscle mass preservation. So all in all, it's a 360 kind of nutrition that can be easily used for your patient with diabetes.
Thank you very much, Dr. Anjana. So the floor is open. We have another 10-12 minutes. Please come up, interact, ask us questions, tell us your experience, practical points, anything you want to ask us.
In the 3 meals per day, breakfast becomes an important one. But we see most of the people, they don't take the breakfast. Even diabetics, they go directly for the brunch thing or something like that. So in those people, I think so this meal replacement can be a very good choice, because nowadays, I think breakfast has been skipped by.
Can I come in, Dr. Anjana? I want to challenge a point once he finishes. Go on.
Yeah. So I think so in that case, this thing, diabetic specific formulas will be a very helpful thing tool in managing.
Dr. Selva, we are very good friends, so he won't mind me challenging him.
Yeah.
Why do you say breakfast is very important? Where is the data to say that breakfast is the most important meal of the day?
See, after you finish your dinner by 9 o'clock or something in the dinner, so you nearly fast for nearly 10 to 12 hours you fast, and immediately after getting up, within 2 hours, your body requires something from the gut. That's not been.
No, it doesn't. This is the first fallacy. I want to address this. Breakfast is not compulsory. Breakfast is not a necessity for you to live. Please, can we talk science and not impressions? When we say breakfast is the most important meal of the day, I want you to back it up with data. I'm not going to stand here and then say, intermittent fasting has been shown to improve longevity. Longer overnight is better. You want to finish your dinner before 8 o'clock, but there is absolutely nothing, no data to support the fact that you need to eat by 8 or 9. Most people do. I support that if that's what my patients choose to do. But if a patient chooses to fast and skip breakfast, I will never tell them it's an unhealthy thing to do.
But still, their lunch goes very long, after 2 or 3 o'clock
Intermittent
in night.
fasting. That is a valid point.
what.
Then if you're going to fast and you want to skip breakfast, then lunch needs to be brought up a little bit. But there is absolutely no medical data to say that breakfast is the most important meal of the day and nobody should skip breakfast. Sorry, back to you, Dr. Anjana. Sorry, let's finish this question, then we'll come to you,
I
sir.
also, sir, Dr. Selva probably would agree with Dr. Usha here, because you just eat
Now
your
I've
hunger
said the-
cues. That's the major thing. You listen to your body, listen to your hunger, and then you have a good.
But
source of
hunger
protein.
is a learned cue, Shruti.
It's a learned cue.
Hunger is
And-
something that we can learn and unlearn.
Right.
Right?
So there is, yeah.
Sorry, I've now set
In
it
a
off.
diabetic, I think so. This breakfast becomes a very important thing. Otherwise, they
No,
go
again,
for-
I can. You
No,
want to skip breakfast? I'll give you a regime that suits you.
Point probably.
Otherwise, they are going to go into hypos.
No, they
That's the
won't.
thing,
I kind of
practically.
agree and disagree. I think for someone with diabetes, we're going to give them BD sulfonylurea, BD something else, in which case I think a breakfast is needed. If someone is doing intermittent fasting, now you can do it any way you like, and it depends on the number of hours. If you choose breakfast as a meal, then one has to be careful, not only about the drugs, but as Dr. Selva said, very much about the lunch. And having said that, Dr. Selva, I think the point maybe he was making was about the fact that people generally get active at that time in the morning and kind of slow down by evening. So if you're not loading the calories by evening, maybe you could shift it towards the day. Maybe that's what he was trying to say, which is also a valid point. So I think that's great. And sir, in my talk, I did show that breakfast was of course, it is completely individualized, because even today we know that even biological clocks are variable. It doesn't mean that you sleep in the night and there are people who stay up all night and sleep. Dr. Jyoti Dev is here. Okay, so Dr. Jyoti never attends a meeting before 12 noon, right? And there's nothing wrong with that his clock is like that. So there are people like that. There's variability, that's a lot. I think the point here was that whichever meal you could is your meal to go, you could probably, and your point about people being busy, going to work, having, and it's easier than sitting and making a meal is very well taken.
And in
But
the night
your point,
shifters,
it works for a lot of people who are having breakfast, especially kanji and all. Because kanji has been a very staple diet for a lot of people.
It's a meal replacement by any other name.
Right, yes.
Right?
Yeah,
A
yeah,
kanji
yeah.
is a meal replacement by any other name.
So in that way, if you have somebody like that and if you want to do this, yeah, I completely agree.
And in the night shifters, I think DSN formula will be a very good thing.
Yes.
Yeah, because
Instead of snacking.
Yeah.
Instead of snacking. That's a good point.
That is a
Exactly.
very valid point.
Very good point.
Sir, you had a question.
I usually use it as a partial replacement, mostly not a full replacement. I usually ask them to take it 30 minutes before a meal so that they cut down the carbs. So I usually ask them, 2 to 3 scoops. I know some people do 6 scoops in the breakfast. Your point is also valid. But I generally, most of my patients I'm okay if my patients skip breakfast, like Usha. So I usually ask them to take 2 or 3 scoops 30 minutes before their food so that they cut down the carbs.
Okay.
So the number of
Yes.
idlis
Is it
puri comes
advisable
down.
to
So-
cut down the breakfast? Because already, as he told, we fast on more than 10 hours. People who are on OHA or insulin, if they are not taking breakfast, they will go for hyperglycemia.
Sir,
And sometimes,
yeah.
sometimes if they skip the breakfast, they will overeat in the
Yeah, yeah,
afternoon
that's also
diet.
true.
That's-
How you are going to advise and manage this?
Yeah, that is, your point is also, sir, that's where you play around your,
Sir, I think right now we have enough agents for diabetes that will allow us to manage. Do we not manage Ramadan? Do we not manage religious fasting? So managing fasting, managing intermittent fasting is absolutely not an issue. We have enough agents, even if it is SUs, we have short-acting SUs that can be given at mealtime, and we can manage every single variation of whatever meal patterns our patients put in front of us. So I would never say that diabetes is a reason for a patient not to be able to fast in any way, shape or form, whether religious or lifestyle related.
1 second, Doctor.
Exactly. And as far as intermittent fasting is concerned, that is not a license for excess calorie intake. Intermittent fasting needs to be, any kind of an eating plan needs to be combined with calorie restriction first and foremost to be able to achieve that weight loss.
So if I may add one more point, Dr. Gauri, I know you're standing behind. This will just take only 2
I'm
minutes.
feeding.
I won't take more than 2 minutes, I promise. The other way where I use is the place that I practice. We also, it's a transplant unit. We have certain medications and you have to be fasting, like especially with tacrolimus. A lot of fasting window is required. That 5 to 6 o'clock in the evening is a very vulnerable time to eat a very calorie dense food. I think that's again you can consider some partial replacement to sort of keep you full, not overeat the next meal, and also have this balance during this fasting period for the medications like tacrolimus in the setting of post-renal or kidney transplant. So you can play around it. There is no hard and fast rule. I mean, all of us would do it in a way that is feasible for our practice.
I completely agree. So I was going to say before she said, even no transplant, no nothing. People maximum you find they default in that evening after work space. That 6 p.m., 5 p.m., 6 p.m. is the space where they crave all the wrong kinds of things. So that's an ideal time to load with protein so that they end up not overeating and then overeating for dinner as well.
Mostly partial replacement is something that you can consider. I think Gauri is just going to get us down the stage.
Thank you, madam. Thank you, Usha, madam. Thank you, Dr. Shruti. Thank you, Dr. Anjana. Now we will move on to the obesity symposia. For the first talk, may I request Dr. Matthew John to take over the stage, please.
Thank you for this opportunity. I'd like to thank Dr. Krishna and members of Debate family for this invitation. We will be speaking about Ozempic. I think we are all familiar with this molecule, and this talk will be a revision to the use of Ozempic in clinical practice. So these are my conflicts of interest, and I've been contracted by Novo Nordisk for this session. Now, I think we were just discussing outside that we should see diabetes not as a single disease of glucose, but rather as a part of an entire cardiometabolic risk spectrum, which is driven by body fat, which includes insulin resistance, diabetes, hypertension, cardiovascular disease, and MASLD, if not adding a sleep apnea or HFpEF to the entire spectrum of diseases that we see. And disease management is no more targeted at reducing the HbA1cs to normal levels, but at a very holistic, multifactorial, person-centric approach to diabetes. We know from data like this is the UKPDS data, this is the UKPDS legacy data. What it is trying to tell is that if you see patients, or rather get patients early in the course of their type 2 diabetes, and you aggressively manage their glycemic control, the advantages of intensive management of glycemic control will persist for years even after the control goes off. That means managing a disease from the very early stage will change the natural history of the disease to a certain extent that you will end up producing benefits in terms of microvascular and macrovascular complications years later. Now, what happens with weight loss is that it modifies the disease. We know that in diseases like rheumatology, we use things like drugs which would modify the disease course, and we call it disease-modifying agents. Similarly, GLP-1 RAs in people with type 2 diabetes or obesity will act as disease-modifying agents, which brings down the body fat, the hepatic fat, which disrupts the underlying pathophysiology of the cardiometabolic problem. It translates into improved glycemic control, it translates into improved cardiovascular risk factors, and importantly, it reverses or rather slows down the disease progression. That's the reason why when we look at current studies, we look at composite endpoints which include HbA1c, the weight. So these are the two outcomes which we are looking at when we look at these agents. And this ultimately leads on to preventing micro and macrovascular complication. Now, if you look at type 2 diabetes or cardiometabolic spectrum as a issue, there are various factors in that. One is the decreased insulin secretion from beta cells, increased hepatic glucose output, increased fat breakdown or lipolysis, impaired appetite regulation, increased glucagon secretion by the alpha cells, decreased incretin effect, and decreased glucose uptake into the muscle. If you look at a molecule like semaglutide, this deals with most of these problems which you see as a sort of pathophysiology in people with diabetes. And now, these drugs, the GLP-1 RAs, are being positioned as the early therapies or even considered as the first-line therapies. What is the reason for looking at these therapies as first-line therapies? One is their proven efficacy and safety in terms of evidence. Efficacy in terms of glycemic lowering, in terms of weight benefits, and the safety in terms of long duration of use. These molecules have been practiced since 2017, although we got it in India sometime late. They have got clear established benefits, not only in glycemic control, also in cardiovascular disease like HFpEF and obesity. Effective in a majority of target population. If you look at these trials, the number of patients who would have brought down their A1Cs or weight are substantially higher than compared to other molecules that we use. Patient convenience in terms of once weekly dosing. And now with the recent price reduction, it provides good value for money. And if you look at all the guidelines now, I'll come to one of those later, are recommended by guidelines. So these are the things I told you about. Now coming to the molecule as such, I think we have been using semaglutide in the oral form for a long time now, and I think most of you would be regularly using that in clinical practice. Ozempic is semaglutide, the human GLP-1 analog, and it has got similarity to human GLP-1, very similar to human GLP-1. The amino acid structure is very close. Half-life of 7 days, which makes it once weekly dosing, and you have a lot of data to support the use. Now, if you look at worldwide release of this molecule, as I told you in 2017, large number of patients, close to 7.5 million people worldwide are on Ozempic, and it is approved in 75 countries, and the number still continues to be the number one prescribed GLP-RA in the world. And as I told you, it is in India now and at a reduced cost. Now, if you go through the clinical development program of Ozempic, it is a sustained program, which includes a series of studies where it has been studied against most of the drugs that we use in clinical practice, like the DPP-4 inhibitors, against SGLT2 inhibitors, against other GLP-1 RAs like dulaglutide, against liraglutide, etc. And you now have a cardiovascular outcome trials, and even we now have a renal outcome trial, which showed a reduction in renal outcomes with the use of injectable semaglutide. So that makes it a very cardiovascular protective drug and a renal protective drug. Now, this is the data where again I showed you GLP-1, insulin, DPP-4 across various comparator agents. And if you look at the A1C reduction at max doses, it's something close to 2.8%, and with 4 out of 5 patients who are using this reaching a target of less than 7%. The average weight loss in people with diabetes is around 8 kg, and around 2 out of 3 patients achieved clinically significant weight loss and reduced waist circumference. Now, if you look at where exactly this molecule placed in the ADA guidelines, so there are certain areas in the ADA guidelines where you need to use specific certain drugs, like when you have a heart failure, an SGLT inhibitor is mandatory. When you have a elevated urinary albumin excretion, you need to do use an SGLT inhibitor. When you have a atherosclerotic vascular disease or a high risk of atherosclerotic vascular disease, you should be using a GLP-1 RA. And you should also be using a GLP-1 RA when your predominant need is for weight loss or high glycemic lowering. So these are the very specific areas where Ozempic or semaglutide should be used. And it is considered as a very high efficacy drug in terms of both glucose lowering and weight loss. Now, where is it approved? Which are the patients you can use it? As an adjunct to diet and exercise to improve glycemic control, you can use it as the first pharmacological agent. And additionally, irrespective of your other agents that you use to control your diabetes, you should consider using it in people with established CVD. That means you have a patient in your OPD who has already suffered a myocardial infarction and he's on a DPP-4 inhibitor or an SGLT inhibitor or an metformin and he's well controlled. Even in that group of patients, irrespective of your HbA1c, now semaglutide is indicated to prevent cardiovascular events. When it comes to CKD, again the same thing hold. You will have a variety of drugs that you would use in a patient with CKD and diabetes, which includes a RAS inhibitor, which includes SGLT inhibitor, and finerenone. And even after this, you have again one more drug, that is the use of semaglutide in these patients. Again, let me tell you, in both these indications, both CVD and in patients with CKD, the use is irrespective of the HbA1c level. Even if you have an A1c level of less than 7 or 7, you can still continue to use semaglutide for cardiovascular and renal protection. Now, which stage should you use it in other patients? You can consider using it in any stage. You can use it as the first drug, but most of the time you would realize that our patients would prefer an oral drug at initiation, which could be a metformin or a metformin SGLT inhibitor combination. You could consider using this as a second drug if the patient does not achieve glycemic control, or as a third drug, or as the first injectable space. This is most common place where you would use it when you exhaust your oral hypoglycemic agents and the patient needs to move on to an injectable. That's a place where you could start a discussion on whether you would like to use insulin versus a GLP-1, and that is one of the most common areas that I would use it in clinical practice. Now coming to the safety profile. This is one area where you need to have a patient counseling because all the GLP-1 receptor agonists are associated with gastrointestinal issues. So you need to discuss the actual gastrointestinal problems with your patients ahead of starting in terms of their dietary modifications, in terms of the quality and quantity of food that they consume. And also you need to educate them on how to tackle these sort of adverse effects. So most of the adverse effects in clinical trials are mild to moderate, and most of this happen during initiation and when you up-titrate the dose. So usually we ask patients to be cautious during the first 2 weeks of up-titration, after which most of the patients will tolerate it. If you would like to explain it to the patient in terms of a discontinuation of the drug because of gastric adverse effects, you can confidently say that around 5 to 8% of patients may not tolerate the drug, and we could always look at that scenario differently. Now, how do you start? How do you titrate the drug? You start at 0.25 milligram weekly for 4 weeks. I think all of you would have used liraglutide in the past, the Victoza. So similarly, it's a increasing dose as the days go by. Here, for the first month, it is 0.25 milligram weekly for 4 weeks. After 4 injections, you update it to 0.5 milligram weekly for 4 weeks. A significant number of patients, I should say around 20 to 30% of patients at 0.5 milligram will achieve reasonable glycemic control, but some patients will definitely require up to 1 milligram of dose. If you look at the cardiovascular and the renal outcome studies, most of the cardiovascular and renal outcome data is, almost all the data is with 1 milligram. So there should be an attempt on your part, despite the glycemic control, to up-titrate doses to 1 milligram to achieve the full glycemic and get the full cardiovascular and renal benefit for your patients. And these are sort of data which you can talk to the patients because in terms of A1C lowering on an average, compared to DPP-4 additional, with DPP-4 additional, you can get a 1.6% lowering and 1.5% extra lowering of A1Cs with this, along with organ protection, conveniently once weekly dosing and weight loss. So thank you very much. I stop my talk here. So we'll have discussion now or at the end of 2 talks.
Anyone here? Oh, I have to handle him myself? Okay. Oh, somebody is handling. Yeah, please, thank you. Good afternoon. Thank you, organizer, again. So, right now you are listening to the Ozempic session. Can I have my slides, please? Right. Semaglutide, all known to you. Beauty is that semaglutide is available in 3 preparations. My friend John talked about, Ozempic. Now, why Ozempic? Why Ozempic becomes such a popular drug? There has to be something behind that it becomes basically a celebrity drug. You know the story where from the Ozempic started. Nearly everyone in Hollywood, they don't have diabetes. They started as a off-label weight reducing agent. Several celebrities in India, I don't want to name them, you just put it in a Google, the celebrity who took Ozempic, and you will find the name which you would be astonished to know why they did basically take it. And they reduce body weight, Ozempic become a off-label anti-obesity drug. Remember, this is licensed for diabetes, not for obesity. Ozempic means semaglutide 1 milligram is licensed for diabetes and diabetes with obesity, not obesity without diabetes. So there has to be certain reason why Ozempic becomes such a popular drug. As you can see in heading, I made it very short, one molecule but multiple wins. It has never lost, and I will tell you the story. This is an over-sponsored symposium. The reason is very simple. If you look at the Ozempic clinical development program, John showed you this slide. I purposefully put it to show you again to re-emphasize. You can see there are total 13 sustained trials in front of you. This drug was launched after conducting a 13 randomized controlled trial involving 20,000 patients, and then if you add the cardiovascular, renal, it becomes a total 17 trials conducted with injectable semaglutide 1 milligram, of which you can see around 1200 plus patients were from India. And this is a GLP-1 which has been highest tested in India, 1246. Now, if you closely look at these trials, there are 7 trials in front of you which has been highlighted. This is a head-to-head active comparator trial. So, semaglutide fought with all the active comparator available till date, which you every day prescribe in people with type 2 diabetes. So, make the long story short in front of you, I made this slide for you. These are the 7 head-to-head active comparator trial. So semaglutide fought with GLP-1, their own brothers. As you can see, they fought with exenatide LAR, which is not available in India, but available in other parts of the world. They fought head-to-head with dulaglutide. They fought with their own brother liraglutide. This was a European trial, so this was a liraglutide 1.2 milligram. In Europe, liraglutide is only approved up to 1.2 milligram, not the 1.8 milligram which we use. So they fought with the 4 GLP-1, 3 GLP-1, as you can see, exenatide LAR, dula and lira. Semaglutide 1 milligram also fought with other class of drug. As you can see, there are 3 head-to-head trials done with sitagliptin. Semaglutide 1 milligram fought with canagliflozin 300 milligram, you know, one of the most powerful SGLT2 inhibitor with a highest HbA1c and body weight reduction. No longer available in India, we use left, right and center. Cana 300 milligram. And interestingly, semaglutide fought with insulin. Now, they not only fight with insulin glargine, which is a basal insulin once daily, they fought with the SPART insulin. So 3 injection of SPART versus 1 injection of 1 milligram semaglutide once weekly. 3 injection of SPART every day for 7 days versus 1 milligram of Ozempic once in a week. And needless to say, you can see the purple colored winner. So one molecule, multiple means wins, means they outrightly beat all the active comparator, not only in terms of HbA1c control, but also in terms of weight loss. And what was most astonishing to me, that a once weekly drug beats their own counterpart, faster acting SPART, thrice daily for 7 days, unlimited dose with a fixed dose of 1 milligram semaglutide. This is amazing. For insulin, you can use the dose of insulin at infinity. For the GLP-1, you have got a fixed dose. Yet, semaglutide beats insulin SPART, 3 injections per day, 7 days versus once week, 1 milligram semaglutide. There is no debate, no discussion, and this is the reason why the Ozempic become the most popular drug for the treatment of diabetes. Now coming back from efficacy to now protecting heart and kidney. As I discussed in Hall A just a couple of minutes back, treating diabetes is no longer a game of number. Your patient might be doing absolutely fine with a very tight fasting PP and HbA1c control, yet he dies of a heart attack. There's no point of treating diabetes. So today we are no longer glucose-centric focused, but we are a complication-centric focus. Your patient may have a haywire blood glucose, but if they are on a protective tools which can prevent heart attack and kidney disease in future, that's the way of treating diabetes. Needless to say that we need to control blood glucose to reduce microvascular complications. In this regard, semaglutide 1 milligram also undergone a dedicated cardiovascular outcome trial, as you all know, named SUSTAIN-6 trial, and a dedicated renal outcome trial. And ladies and gentlemen, let me tell you, the semaglutide is the only GLP-1 that has undergone a dedicated renal outcome trial with a hard renal endpoint in a patients with a chronic kidney disease, defined as eGFR less than 60. There is no other GLP-1 which has undergone any renal outcome trial. So when you utter this word that GLP-1 protects kidney, the credit goes to semaglutide 1 milligram only. There is no trial which has been done with any other GLP-1 in patients with CKD. Now many people will show you data with other trials in terms of kidney outcome. These were exploratory outcome. It was never tested as a primary outcome. Second important point, that all the previous GLP-1 trial conducted in patients with diabetes with kidney disease as an exploratory outcome, for example in LEADER, in REWIND, they all included microalbuminuria as one of the outcome. But now US FDA says that if you are conducting a CKD outcome trial, you cannot include albuminuria as the outcome. Because remember, advanced trial, there was a reduction in albuminuria, no benefit any endpoint. Only albuminuria drive a positive renal outcome trial. Simply reducing albuminuria do not translate into a hard renal endpoint benefit. There are many drugs that reduces albumin but do not protect kidney. And there are many drugs who do not reduce albuminuria yet protect kidney. Can anyone tell me which drug is this? Tolvaptan. Remember, tolvaptan was undergone a dedicated renal outcome trial in patients with a polycystic kidney disease. There was no reduction in albuminuria, but it reduces the hard renal endpoint, which is doubling of creatinine patients requiring renal transplant. And therefore, the US FDA has now mandated that you cannot include albuminuria as one of the endpoint in the renal endpoint. And FLOW was only exceptional trial conducted with semaglutide 1 milligram that did not include albuminuria as one of the endpoint in their hard renal composite. And yet, it did reduce the renal endpoint. So let me quickly take you through what happened in this 2 CB renal outcome trial. This is in nutshell. So there was a 26% reduction in the composite of 3P-MES, which is MI, stroke, and CB death in the SUSTAIN-6 trial, primarily because of reduction in a stroke by 39%. The first hard data to suggest, also one point I would like to tell you, which many of you might not be aware, that semaglutide SUSTAIN-6 trial was a non-inferiority trial. There is very nuances behind this. For the first time, US FDA made an exception to a trial where when you conduct a non-inferiority trial, we will not be given additional update. You need to conduct a superior outcome trial from day one. So before the match starts, you did a toss and you said, I will win the match. And second point is, you started the match, you played, and then you win the match. There is a difference between predicting that you will be superior before the match start and the continuing the match and then you win the game. There is a different award from the US FDA. The SUSTAIN-6 was exception to the entire CB outcome space, that it was a non-inferiority trial. But because of such a large quantum of benefit of 26% 3P-MES reduction, FDA bowed down to Novo Nordisk to give them an additional level update. Because you cannot deny a 26% reduction, which is a clinically meaningful, significant reduction. And this was primarily due to 39% reduction in stroke. Flow trial, 24% reduction in the composite of renal endpoint, primarily derived from reduction in doubling of serum creatinine renal transplantation patient undergoing dialysis, without albuminuria, as I said in very beginning. So let's quickly look at Sustain 6. This is just a reminder to what happened. Sustain 6 was conducted 10 years back in 2016. You can see 3297 patients were randomized to, and also Sustain 6 is one example. Many parents ask me, gentlemen, I am taking Ozempic 0.5 milligram. Can I have a cardiovascular benefit? I will not take 1 milligram. I am doing fine on 0.5 milligram. This is the only trial where 0.5 milligram was separately studied in terms of cardiovascular outcome. Only 2 trials prior to this included the dose response CB benefit. One was the IMPAREG outcome trial, you remember? They included 10 milligram and 25 milligram of empagliflozin. And if you remember, there was no difference between the dose response CV benefit. Indeed, if you look at the numerical benefit, the 3P-MES benefit was better with 10 milligram than 25 milligram in IMPAREG outcome trial. Similarly, in Canvas program, 2 dose was studied 100 milligram and 300 milligram. This is the only GLP-1 trial where 0.5 milligram was separately studied and along with the 1 milligram. Although the result is the pooled data of 0.5 and 1 milligram, but we do have evidence with the 2 different doses, and I will share you. So what did we find? As we discussed, 26% reduction in the composite of 3P-MES. And here is the data. This was primarily derived from reduction in non-fatal stroke by 39%. Now the $1 million question which is asked in every meeting, so I purposefully wanted to put this slide in front of you, which is there in the supplementary of New England Journal of Medicine. Nobody opens the supplementary. All information measure are actually in the supplementary appendix. Now look, this is a separate, data of 0.5 and 1 milligram. If you look at the left-hand side, primary outcome of 0.5 milligram and 1 milligram separately, what did you notice? That 0.5 milligram itself is giving you a cardiovascular benefit. But of course, this is more larger with 1 milligram. If you look at the Kaplan-Meier curve, you can find out that both the dose give you a cardiovascular benefit. Now, if you go back and look at the non-fatal stroke, which was the primary driver of the benefit, surprisingly, the 0.5 milligram people had a larger benefit than the 1 milligram. So this evidence suggests that dose doesn't matter. Once your patient is on a drug which is anti-inflammatory in nature, this will do the magic. So 0.5 milligram did reduce non-fatal MI even larger than the 1 milligram. This is the first evidence suggesting that even a smaller dose of 0.5 milligram is as good as a 1 milligram of semaglutide. I am not suggesting that you should not increase, but I am just asking you and informing you that even 0.5 milligram did confer cardiovascular benefit. The second question which people always ask that, okay, Sustain 6 has a primary patients with established cardiovascular disease. I am only obese, I don't have any established cardiovascular disease. Do I benefit with semaglutide in terms of cardiovascular benefit? So here is the evidence. Remember, 23% patient in Sustain 6 didn't have any cardiovascular disease. They had a cardiovascular risk factors like hypertension, dyslipidemia, obese, smokers, etc., etc. But they didn't have established cardiovascular disease. So 23% patient who didn't have established cardiovascular disease did benefit similarly. You look at the p-value of interaction, everybody had a similar benefit. So even patients with a primary prevention cohort who doesn't have established cardiovascular disease tends to get benefit in terms of cardiovascular endpoint with semaglutide. What happened with the kidney? This is a flow trial. As I said, this is the only dedicated trial done with any GLP-1 in patients with established CKD. As you can see, 1 milligram semaglutide compared to placebo. And here is the 24% reduction in composite of kidney endpoint, barring albuminuria. No other trial looked for the renal endpoint excluding albuminuria. So that's the point I would like to make, that how this flow was different. But then if you look at, that doesn't mean that they didn't look into the albuminuria outcome. They did separately look at the albuminuria outcome, not including in the hard renal endpoint. And you would be surprised to see 32% reduction in albuminuria, the largest ever albumin reduction with any GLP-1 receptor agonist. And if you look at the mortality outcome data and kidney function, You can see 65% of the people shows, slower loss of kidney function, and this translates into a 5-year additional protection in developing any kidney disease through the flow trial. If you look at the death outcome, you can see at the end of the day, we always look whether the drug has the ability to reduce death, be it a cardiovascular death or cause death due to any cause, means all-cause death. As you can see in the flow trial in patients with diabetic kidney disease, the semaglutide 1 milligram did lower cardiovascular death by 29% and caused death due to any cause by 20%. And I will tell you, this is the only cardiovascular renal outcome trial where both death was significant. In none of the previous 11 CB outcome trial, there was a both all-cause and CB death benefit. Either there was a CB death benefit or either it was a all-cause death benefit, but both benefit only happened in the flow trial. That's another exception. So what did we learn? Semaglutide has a wide range of, now dosing. You have got Ozempic, you have got oral semaglutide, Rybelsus, you have got Wegovy, the 3 formulation in different form, suitable to choice of the patients, suitable to the BMI of the patients with the blood glucose of the patients. Plenty of data, and you have a choice to make it which one to use. You can see that trials across the board with the semaglutide different preparations. Right. So this is in nutshell that includes oral, injectable, Ozempic, Wegovy put together. This suggests that one molecule wins nearly every race. I never saw anything failed with semaglutide as of now. So ladies and gentlemen, what is the current level update with semaglutide? As you can see, the Ozempic has got a level update, 2 level update. One for reducing MES through the SUSTAIN 6, one through the flow trial to reduce, composite renal endpoint reduction. If you look at the Rybelsus, oral semaglutide, through the SOUL trial, they have got the level update for the cardiovascular outcome. If you look at the semaglutide higher strength, Wegovy 2.4 milligram, they also has got a 2 level update. This is a reason why, everybody are willing to take semaglutide, regardless of which preparation you want to give, oral, injectable, smaller dose, Ozempic, Wegovy, wide range of choice to choose. No wonder, everybody prefers Ozempic today. Finally, before I finish my presentation, I thought to put it in front of a practicing clinician. If you look at the cost of this drug in Indian currencies, and you will not find anywhere this slide, to look at how the cost currently look like. Even a Wegovy 1 milligram is a little costlier than Ozempic 0.25 milligram. So not only Ozempic wins the race in terms of the data, also in terms of the cost. Now, choice is yours. If you feel that these medicines will work for your patient, do not hesitate to use. That's the message from my side. Thank you very much for your patience. It's 2 minutes more to left. So, John, can you please come and, please, Shruti, go ahead.
Sir, what a fantastic presentation. I always learn something from you every single time.
Thanks.
It's amazing. Anyone can take this question. So I always am surprised looking at the amount of data that we have with semaglutide. The robust data with the last slide was so impressive, and even the first slide with 17,000 patients. So in 2-3 months, we'll have a generic semaglutide would come, right? So it's going to be difficult. I know it's a very tough question. So when we use that, would you be conferring all these things that we had with the original innovator semaglutide, and would you tell the patient, because now if I have to put a patient on Ozempic, I strongly tell them that, if I were a diabetic or if my parents were diabetic, I would definitely consider GLP as even a first line therapy or a second line therapy. But if the generic comes, would you be comfortable with telling the same
I got your
to
question.
patient?
That's a very pertinent question.
With this data that we
All right.
have.
So I will answer your question. So, look, this is how we have time? Okay, fine. 20 minutes for discussion. Great. So please volunteer. So Shruti actually raised a very pertinent question. Of course, this question will be asked sooner or later once a generic semaglutide is bombarded in our part of the world. The Indian pharmaceutical industry, is very powerful if you compare anywhere in the world. We have got a R&D where we can develop any molecule. They would have brought a generic semaglutide far earlier. I know they all are ready and prepared, loaded in the box. But because of petitions in the court, Novo did not allow them to use it because of their patent protection. But sooner or later, patent will expire and Indian pharma company will bombard you with injectable semaglutide. So the question is, how comfortable we are in using generic semaglutide? Answer is, we should not be uncomfortable as long as they produce you the data. The simple answer that they need to show us data. Now, let me explain you little, wider way. Semaglutide is not a, chemical generics like a glimepiride tablet. We have a 200 generic glimepiride today after the discovery of glimepiride from the Sanofi, which is Amaryl. It doesn't make any difference if your bioavailability ranges between 80% to 120%. You can go 20% down, you can go 20% up. It doesn't make any difference for a chemical generics like glimepiride. But it does matter for a peptide. For example, insulin. Insulin and GLP-1. Now there is a difference between insulin and GLP-1. Insulin is a biosimilar product. GLP-1 is not a biosimilar product. It's a peptide product. So there is a difference between insulin and GLP-1. Now I will stick to discussion to the GLP-1 here. That even if you make a peptide copy, it has to undergo a tremendous, safety process. I am writing an article why we should make a robust GLP-1, which will you see very soon in public domain. What are the, do's and don'ts to make a GLP-1 generic in India? So, to answer your question very simply, because we are not in Indian part of the world or in many part of the world, our regulators are weak. They do not ask for a very stringent kind of studies to be conducted compared to US FDA or EMA. So in India, the DCGI says that if you want to make any new product, generic product, you have to conduct first a bioavailability trial in people with type 2 diabetes. You don't require even a phase 3 study for diabetes. But if you are making a generic semaglutide, which is for anti-obesity, you must conduct a phase 3 trial. So any pharma company, if they, and I can see many people standing here, if they come to us, I ask that show me your data. Now data doesn't mean a bioequivalence study. Data means that you have conducted a clinical trial in people, our Indian patient. Now what do you mean by clinical trial? I have given 50% generic semaglutide, 50% innovator semaglutide. After 1 month, I say glucose is similar, so that's why we launched. Answer is no. You conduct a trial of at least 6 month duration. This is what is the DCGI's requirement. And rather than showing efficacy, show me the safety first. That your generic semaglutide is exactly same. There is no impurity whatsoever that will produce any antibody later on. Remember, once your patient develop a GLP-1 antibody, then even innovator GLP-1 will not work. So be cautious that they conduct a immunity study. And you look at this data prior to the start of a study, at the end of a study, for 6 months, if you don't generate any profile, wrong immune profile, you are through. So first, see, if you look at the definition of clinical development program, starting from phase 1, phase 2, phase 3A, B, and phase 4, the primary focus is safety, not efficacy. Efficacy is a secondary factor. So first look at the safety of the drug. If the company will provide me that their molecule is safe, as well as now comes the efficacy, that it is same efficacious, you are absolutely welcome to use generic semaglutide. There is no harm about that. But provided that it is safe and efficacious, conducted a study for 6 months. This is the current DCGI's requirement. And I know that various pharmaceutical companies, those who are big name, has conducted a phase 3 trial, because this is not in public domain, that's why we are not aware. I have seen certain data with some pharma company, and it doesn't look bad. That I will confess despite being this is a novel symposium. So I don't mind if the Indian pharma company make a generic semaglutide, which is as safe as innovator semaglutide and as efficacious as innovator. Why not? We should. There's no reason that we should not prescribe it, as long as this is a cheaper. But if tomorrow you find that even an innovator semaglutide give you in a similar cost, then of course I would use the innovator one. They did not undergo a Sustain 6 program and flow trial. So that's also point, even 6 months is not enough. EMA doesn't allow 1 year trial, less than 1 year trial. Because many patients might not develop antibody even at 6 months. But Indian DCGI, because we live in a poor country, if the company do a trial for 1 year, then the cost will not be cheaper. That's their logic. So I think this is the small way to answer your question.
Sir, all weight loss obesity drugs have always had a very bad track record on one side. And every time there's a new molecule, unless the next molecule comes, we rarely talk about the real side effects. In the long term, how do you see this molecule as? Would we be some elephant in the room again at the end of the day, or like is it really good?
Well, see, the good, at least I can tell you about the semaglutide story. Semaglutide has come to India 3 months back, but it is there for past 10 years in United States. Sustain 6 was done in 2016. We are in 2026. Semaglutide, Ozempic is available in United States for past 10 years. People are using left, right and center. Had there been any safety issue, by this time FDA would have put a black box warning. So we have got the data with the semaglutide for 10 years. That's the data we have. Now with regard to the other newer drugs like Mounjaro, tirzepatide, they have also undergone a dedicated program, as you know, Surpass, Surmount, for at least 5 years we have got the safety data. There is no untoward signal whatsoever at this point of time. But having said that, I would not say that in future no signal, wrong signal will come. We have to wait. Rosiglitazone was used for 9 years for clinical practice and then banned. So we never know that any drug would produce something unknown, untoward at a later point of time. So that's we cannot predict. But at least with the 10 years use of Ozempic in United States or other part of world, we don't have any such wrong signals. So at least we are comfortable with the semaglutide at this point of time. Yes, that's a very pertinent question. So would you mind? I am taking all the questions on behalf of you as well. So share me all your quotas later on. Jokes apart. Sir, I will come back to you. Please stay back. I will come back to you. So yes, any drug which produces weight loss will also produces the lean muscle mass. The God has made our body in such a manner that you lose one compartment and you will not lose other compartment. That doesn't happen. So there is a clear-cut lean muscle mass loss as well, seen with any anti-obesity drug, not only with GLP-1 or dual GLP-GIP. But the good point is this lean muscle mass loss which is there is not that dramatic, 10%, 15%, and you can prevent it. So if somebody is on GLP-1, the first message I would give that if you don't want to lose lean mass loss, start a aerobic exercise from day one. You'd lose 0 lean muscle mass if you do aerobic exercise. Now, there is a study, as you know, that looked at whether this lean mass loss leads to a weakness in the muscle. And surprisingly, there is increase in muscle. There are now number of studies come out that yet patient lost little bit of lean mass, but their strength remains intact or rather become more from the baseline. So there are many studies that are suggesting that even if you lose little muscle mass, muscle function is never compromised. Rather, it gets activated. There is a catch in this, because we are not able to exactly deduct whether this lean mass loss is the fat in the mass or the genuine lean mass. That's we are not able to differentiate. The primary data suggests that we are losing fat from the muscle, and therefore the entire lean muscle mass goes down. But I do not believe in that. I do feel that there is a lean muscle mass loss. It is there and it will be there. It happened with bariatric surgery. It happened with all anti-obesity drug, that if you lose weight, you will lose 10, 15, 20% of lean muscle. The good news is that your muscle do not become weakened, and you can protect it by doing aerobic exercise. I hope I have answered your question, sir. You are busy on mobile. Anyhow.
So, any chance of
developing hypoglycemia because the half-life is 7 days.
So these drugs do not produce hypoglycemia, and that's why you are licensed to use on obesity. If you inject 5 injections of semaglutide, you will only vomit. You will not develop hypoglycemia. So this drug do not causes hypoglycemia.
What's your advice to prescribe this drug, diabetes with the myopathies?
With myopathies, I don't know, nobody has studied it, which myopathy. Now this bring a broader questions, which myopathy are you suffering from, a congenital myopathy or acquired myopathy or inflammatory myopathy or neoplastic myopathy. I would not use it knowing that somebody has already lost their muscle mass because of myopathy. Why in this planet I would use this molecule to that particular patient? So my answer is no, better not to use it. Rest 99.9% patients sitting in front of you who do not have myopathy, please do use, they will get benefited. NION, okay. So there were concerns with, non-arthritic ischemic optic neuropathy. I wrote editorial in second last issue of JAPI. We exactly don't know whether GLP-1 is associated with NION. There are multiple papers, published where some suggested increase in NION, others suggested reduction in NION. Where to go about it? The problem with the real world study is the confounding bias. So exactly we don't know. This is a causal association of GLP-1 with NION. WHO looked at all this data. They suggested that this is extremely rare event. If at all it happens, the prevalence of NION is 1 in 10,000. You do not stop even. The WHO recommended that if your patient develop a NION on GLP-1, don't stop the GLP-1. Had this been the issue, people have instructed that it happens, NION happens. There is no black box or a caution warning on any GLP-1 that it causes a NION. The good news is that semaglutide is undergoing a dedicated trial to looking at NION. This is called FOCUS trial being done with semaglutide. The trial is already in process for past 5 years. It has started way back in 2020. So the trial is currently on with semaglutide looking at NION and other retinal complications. Had there been any signal, the Data Safety Monitoring Board, who is independent, sitting with the FDA, would have stopped the trial. So I believe that there is no such signal. Had the signal been there, they would not have continued the trial for the past 5 years. So we don't know the exact answer. We have to wait for the FOCUS trial result, which will come, somehow in the early quarter of next year. We will be able to make a full stop marks whether it is associated with NION or not. Until then, be cautious. If your patient has got any suggestion of NION, no hurry to use GLP-1. See, I am a very, usable scientist. Why in this planet I should take any risk when we don't know? So if my patient is a known NION, I would not prescribe GLP-1. As I said, rest people are eligible for GLP-1, please prescribe there. No, don't go to the rare cases where perhaps you will never find it that NION has happened. No, Dr. John, you take. I'm sorry to bore you. Yeah.
Sir, once we start the Ozempic, suppose we attain our HbA1c, should we again escalate the dose for getting adequate weight reduction and cardiovascular safety, or can we de-escalate?
Second part, no, not to de-escalate. So the traditional guideline recommendation is that you will have a sort of target for the patient, either in terms of your A1Cs and which if you can achieve lower A1Cs with no hypoglycemia, that means obviously you will need to down titrate your insulin or SUs, whichever you are using for that. So if you're able to achieve an A1C of less than 6.5 and you have that is the HbA1c target you are envisaging for that patient, you could possibly stop there. But you would also envisage a sort of BMI target for that patient or a cardiovascular benefit for that patient, which you do for all your patients. So which I would actually like to uptitrate it to the max possible dose of 1 milligram for most of my patients. So down titrating will be only with adverse effects, which could be either gastrointestinal adverse effects or in a certain segment of patients like a server was asking, like suppose muscle loss is a significant concern. Say someone who is elderly, someone who is already having poor muscle mass and some functional abnormality, there I would consider down titrating. Otherwise, I wouldn't down titrate which is already increased to a certain level. AK, you would like to?
I will just give you one tips to use semaglutide in current clinical practice or even Monjaro. The rule remains same. The trick of using these anti-obesity medications is to start slow, no hurry. The textbook guidelines suggest that you increase dose every monthly. There is no such law that if you don't up titrate the dose after 1 month, you will be pulled into the court. It's completely customized and in your way fitting to your patient. So say for example, I have started 0.25 milligram of Ozempic. Patient developed after the 4th injection, patient is complaining of a persistent nausea and vomiting. Don't switch on to 0.5. You say you continue with the 0.25 milligram. Or you skip 1 dose, then take after next week. There's no issues. If you stop the drug, see, somebody forgets to take after 7 days. You have a boundary of plus minus 3 days. That means that the drug might be working for 7 days, but their effect remains still 3 days after the 7 days. So you can inject the drug even after 10 days. This is off-label way of using the drug. This patient will suit more. When you know that your upper level limit is 2.4 milligram, it's like a test match. You know how many over left, how many runs to go. You have got a 5 pence to use in your entire life. Why to worry? I will use the 5th 2.4 milligram injection after 10 months. Is there any hurry? Is losing body weight is an emergency? Answer is no. It's a chronic disease. There is no hurry to go up to the largest dose within 5 months as per the law. You go every 0.25 milligram, 0.5, 1, 1.7, 2.4, and then patient vomited and stopped the drug. You failed in your mission. So my trick of starting GLP-1 is to go very, very slow. Let the patient tolerate it. You can continue with 0.5 milligram or 1 milligram for 6 months. There is no problem. As long as patient is losing weight, why there is a hurry to increase the dose? Once you have reached to plateau, then you increase the dose. By that time, patient will develop tolerance to these GI side effects. Remember, these GI side effects will not going to remain for entire life. So if you are in a slower dose, you are going very slow way, this GI side effect disappears over a time. And you can up titrate the dose accordingly as per your requirement. So that's the trick of practicing.
Yeah, so the question is like if you take the dose up to a certain level and you stop it, will the weight and HbA1c rebound? That is the question that you have been asking. Yes, you could actually see just most of the patients would ask this question. So we tell them your body is your body, your physiology doesn't change. A drug works only as long as you take it. So you take it for an X period of time, you achieve a certain thing, then you stop it or you withdraw it, definitely you may put on a weight and your A1Cs will again go up. So I think there's no reason why you should stop it. The only condition which you would stop it is that if you're using someone with obesity and PCOD and that person is planning a fertility treatment or something where you would like to withhold the drug for a while when the patient plans for an infertility procedure or something, yes, you would. But again that will for a short time, like something like 1 to 2 months between your stopping the drug and planning your procedures. Otherwise, you would be continuing it. And just like AK told, you could also dose at various other schedules which are not there in the textbook. Because if you remember with Victoza, even though it is written 0.6 milligram, 1.2, 1.8 milligram, we always used to dose it at someone, start at 0.3 and then up titrate to 0.6. Or like that, even with lesser than 0.25, you could start and titrate for a patient who has got some gastrointestinal issues. There's no hurry to go up on the dosing. And surprisingly for glucose control, you would achieve it at much lower levels if you see. For someone on high dose of insulin, if you're putting on a Ozempic, you will 0.25, 0.5 itself, you don't need to even go before that you will see the insulin requirements coming around.
Sir, I have one practical question. Even with a 1 mg pen, you can start 0.25 by the dial technique. So, but the labeling doesn't permit it. You have to use the medicine within 6 weeks or so once you are opened. So, do you recommend it? Do you use in your patients? Or should it be essentially be used only for 6 weeks? So, what is your take on this?
Well, so see, there is no harm in doing it. We are not doing any crime. We are saving patients money. The entire purpose is to save money. Your intention is good. So even court of law will reward you rather than punish you. As long as your patient is happy by doing whatever means, you could reduce the cost by, this is typical Indian jugaad we used to do. We always keep on doing good work. That's why whole world is tensed about us. How you guys manage all your patient with this much.
So actually, sir, the trick is even company knows it. At 0.5 mg, if you dial, there is a change in the color of it. So they have made it for 0.5 mg. It is not that they have kept it only for 1 mg. So I feel they also have an intention that you can use this 1 mg and take 0.5 mg.
This is not an Indian jugaad. I recently had a patient who came from the US.
True.
They also do this in the United States as well. So I had a patient who was on 0.125 of Ozempic. I've never seen the dose. I even told him, how is it even working? Actually, he showed me the CGM data that 0.125 is working perfectly fine for him in terms of this. And then he's comfortable taking half of 0.25 with the same click method. So it's just not Indian jugaad. I think all over the world, I think what works for, as you said, what works for the patient is what should work for us.
Correct.
I think there is no...
So he must be Indian. So he's ultimately Indian living in USA. So
Probably, he says it's
yes. So
US, probably. That's
that
what he
doesn't defies the Indian jugaad criteria. No American will do that. So regardless of where you go, whether you are living in USA or you live in Greenland, the Indian will remain Indian. So that's remain the Indian jugaad.
The doctor is not an Indian, so he's a US doctor, but it still works.
Anyone who is paying from their pocket will do it, I think.
Yes.
But that was insurance driven, but it's still insurance driven and he was still doing it.
So thank you very much. Thank you. Thanks a lot for a good interaction.
Thank you, sir. That was a very, very nice session. Now we will move on to the next session. I invite Dr. Selvapandian, sir, to take over for the dyslipidemia conference. I request the panelist, Dr. S.N. Narasingan, sir, Dr. Kumaravel, sir, Dr. D. Prabhakar, sir, and Dr. Shira Mahadevan, sir, over to the stage. Over to you, sir.
So good afternoon once again. I would like to thank our organizers for giving me an excellent opportunity, and I welcome the panelists. And dyslipidemia conundrum. The problem with the first-line healthcare providers are they write the anti-diabetic, anti-hypertensive, but anti-lipid many a time it is missed or it is not given. And if you ask the patient also, I am writing a anti-lipid drug, immediately they will say, I am not taking any non-veg and I don't use oil, other things and all. And they never think that this is very important, like your anti-diabetic or anti-hypertensive drugs. So in that scenario, and the dosage also we see, they use a dosage which does not meet the target. That many times we say that we have to meet the target like HbA1c, like for lipids also for a person with comorbidity like hypertension or any other CVD comorbidities, there is a target for lipids, but we never meet the targets. So in that scenario, we'll go on with the case discussion. First for Dr. Kumaravel. Mr. Y, age 24 years. He weighs nearly 119 kilograms. He is dyslipidemic, euglycemic, euthyroid, normotensive, otherwise normal. Just 24 years old. His cholesterol is 236, triglyceride 419, and HDL is 37, non-HDL is 199, and cholesterol by HDL is 6.3. So I want to know what are the targets here and how you are going to treat it and follow up.
So I think in this patient, his weight is 119. We don't have a height, but basically 119 for Indian standards. We presume he should be obese, and he's obese, dyslipidemic patient, but other parameters seems to be normal. And we have his total cholesterol which is high, and triglyceride which is high. HDL is 37, and non-HDL, I think this is very important parameters, because the advantage of using non-HDL cholesterol is it can be done even in non-fasting state. It includes all atherogenic cholesterol apart from your HDL. It includes LDL, it includes your IDL, and it includes your lipoprotein A also. So it correlates better with most of your atherogenesis. And the advantage, the target for non-HDL cholesterol should be less than 130. And generally it again depends on the risk of the patient. If suppose the patient is high risk, you try to reduce the non-HDL cholesterol range. So in this patient, we know his lipids are definitely abnormal. But first thing what I would do is I would not jump and treat his lipids initially. Because he's obese, we have to rule out any secondary causes of dyslipidemia in this patient. And we should know if the patient is on any drug the patient has been taking. And we should know the patient thyroid status and other things has to be done. And once when we rule out, then only we can go in and treat this lipid abnormality.
So any comments from the other panelists, sir?
So basically when you start looking at a, am I audible? Yeah, okay. So basically when you start looking at a lipid profile, how do you approach a lipid profile? Simple. First thing that I do is look at triglycerides. Because if the triglycerides are more than 500, there is an absolute risk of pancreatitis. So that has to be treated first. So that's how you start looking at a lipid profile. Next, everything else comes. So total cholesterol today is not much of relevance, non-HDL. So what is strikingly missing is the LDL cholesterol. Why is LDL cholesterol not there? Probably they did a calculated LDL, and which is going to be abnormally wrong in the present Friedwald equation is wrong when there is going to be a high triglycerides. And the other conditions that you have to look at, how to approach the patient other than that, once you've ruled out that the triglycerides are low, I think he has been very clear. But one thing about triglycerides, when you have a 419 triglycerides, your patient is going to pester you and tell you my triglycerides are high, what are you going to do? He will not wait for treatment. At least you tell him one thing, 50% of the triglycerides can be brought down by lifestyle modification. That will also save him time, and tell him you're trying to avoid medication. That he will accept.
So, yes, sir.
In addition, I think I fully agree with both of them. 24 vayassu alcohol, smoking. The overall, see, ultimately the aim of approaching this, whatever discussion we are going to have in the next half an hour, is heart problem, serious consequences of the metabolic syndrome. In today we are focusing on lipids. So addressing all his thing is holistic management. I think all our senior physicians here, that has to be, that cannot be overemphasized. And the strong basic irundadhan ba mela discussion correct. Illena what drug when 24 high risks or adala varadam porudhu part the discussion. That's my, so I will be more focusing on what are all the other wrong things in the sense that quote unquote wrong in the sense lifestyle related.
Thank you very much, Chairperson Dr. Serlo Pandian. I think the moment you projected, I was just pointing out that the LDL is missing here. Because the total cholesterol is 236, I presume that it should also be high. Not only by calculated method, because calculated method is useless now, because you are not supposed to do it. You should go for only direct LDL measurement. In case this patient has got a total cholesterol of 236, I probably predict that his LDL cholesterol should be on the higher side, maybe crossing 160 to 190. If that is so, I would probably be very careful in analyzing the history, whether he has got a family history of premature coronary artery disease or a death in the family. Because familial hypercholesterolemia is such a common problem which is always neglected by the physicians or the healthcare provider. That's number one. In case the patient has got higher levels of LDL cholesterol, not only the primary hypercholesterolemia has to be entertained, but in addition he also has the TGL of 419. Maybe that this fellow is having a familial combined hyperlipidemia, which need to be entertained at that stage. Because this is the one again neglected, underdiagnosed, undertreated. Because many people, they don't look at all these uncommon problems, which we think always uncommon. It is not uncommon, it is always common. Because that's the one, 35% of the patients who have familial combined hyperlipidemia, indicating that the LDL cholesterol is high, the triglycerides are high, the HDL is low, and those patients are likely to jump into complications of ASCVD, particularly the coronary artery disease and death. So we need to be very careful, elicit the family history, and look at the parameters like LDL and look at LPA also, because most of the patients who have familial combined hyperlipidemia also have a concomitant increase in the levels of LPA. If that is the combination which is going to be encountered in this patient, I will always be aggressive in treating him, even at the stage when he is only 24 years old.
So thank you, sir. So the next case to Sriram Mahadevan, Mr. X, age 38 years, female, known hypothyroid, euglycemic, normotensive and dyslipidemia. Her TSH is normal, 3.95, total cholesterol is 261, triglyceride 196, HDL 22, LDL 165, non-HDL 239 and cholesterol by HDL 11.86.
Thank you, and I have come to learn more from this case from my seniors here. Let me be first. I think you have put the other common secondary causes. Thyroid also is there, but TSH is nearly bang normal. So I presume that's not the cause. She is not on OC pills by any chance. Is my second. Always we have to look at that. And if this is part of a master health checkup, I'm sure urine proteins and other things will be there. So always those things run in my mind, and 38-year-old I will be asked directly that she consumes alcohol, etc. So today it's not at all rare. So if all these secondary things are not in my mind, then as sir was pointing out, the risk scoring, again, the aim of seeing these numbers is to see what is the chances, the CV risk reduction is what we all as physicians understand. However, I am told by many of my cardiology colleagues also, and whatever literature we are going through, the so-called risk score assessment not very robust for Indians, and there are no that kind of a score which will directly tell me that if you put this for South Indians, yes, you are at the higher risk. That is, and of course, you hear also BMI and other things. You have not put obesity, other things. Though obesity is probably contributing here, you have to agree that. So lifestyle will be my first choice, and will buy time to take the fact sink that there are some abnormalities here which are in the future both your risk for metabolic complications and ultimately CV, CEV, whatever the atherosclerotic vascular disease risk factors. We will, so the first one visit at least I will take time to make her understand. ChatGPT and Google definitely she would have gone through. So I will be in a defensive mode to explain to her the numbers. So, but definitely I will not prescribe drugs on the first one or 6. And even in the previous case, I would rather learn from sir and others. I have had this, and I tell our students also, whenever this family history is asked, I have a doubt. See, as an answer, as a categorical binary of yes or no, it is easy to ask that question. Do you have a family history? They'll say, my noda Peripa, and he died of heart problem. I'm sorry, most of us understand Tamil here except the few. Yeah, so that Peripa would have died at the age of suppose 55, which is by definition will come in. But he would have been a heavy smoker. He would have been a heavy alcohol consumer. But this fellow will not be. He will be 42 sitting in front of me with this history. How to, those things are not actually inbuilt in the risk score and other things. So family history, obesity, diabetes, these traditional risk factors can be easily put a checklist. Today we have risk enhancing factors they are talking of. The risk kudukara mari also we are looking at. So it boils down to how a family physician will see this. I will be definitely taking time to explain to her, and if she is obese, I am as a physician interested in all other complications. Menopause tomorrow will be an added risk factor to her. So adala solitu, at least I will wait for some more time.
But usually in
Statin
hypothyroid
is the easiest, which I will be hesitating and I will try to explain because it will be committing for a long-term treatment, and it will boil down to like treating a number, which I don't want to.
because she is already a hypothyroid, and thyroid cholesterol will be a little more.
The normal values.
That's what.
Otherwise, I would have blamed that for some time at least.
Sir, if I am ChatGPT, I will be more worried about the HDL of 22. What's your comment on that?
HDL 22, luckily, no, drug
80% of the Indian, I think 80% of the Indian population, like vitamin D, HDL is also very low, less than 20.
So, konjam alcohol eduthuka sollilama. That definitely we will not be able to say. I am sure all the lectures by all the senior experts here in so many places we listen to. The most difficult thing to answer, exercise and other things is what we say, how much exercise, etc. HDL airway eradu. And
Weight loss.
most of the Indians in ICM or in-dive study also, I think Dr. Mohan sir used to lecture everywhere. The HDL was abysmally low in most of the places in India.
Weight loss and exercise, they say, but
So I assume that if I think sir is here, so I can boldly make mistakes and learn from him. If HDL, the correction of HDL in animal studies and even infusion of HDL, NAGM, Germany paper and all I have read, where the atherosclerosis will be totally regressing, but nothing has turned out to be outcome benefits in the form of hard endpoints are not there. So at the end of the day, focusing on her TGL, reducing, if she is obese, reducing the TGL, which has some modest effect on HDL, and overall risk factor assessment is what I will do. And knowing fully that none of the risk scores which are currently available are fully applicable in this patient. Specifically, I talked to my cardiology friend in my institute and came here for this this discussion. There has been a nice Indian study, I think sir will know, the PCAR study. I have to specifically mention precision cardiac risk assessment scoring, mainly for Indians. 14,000 Indians have been studied. The paper has been apparently published to NAGM. In the next 6 months, it may come out in the paper. All India Institute, Mohan sir's institute, and my institute, Sri Ramchandra, are all part of this, and they have done. So we are in the near future going to have this question will be answered differently in next debate. I will use that risk score and say whether that number is more than this. Maybe I will put her on some drug, etc.
So having said that, I will add some more points to this. So one is the low HDL is a major risk factor. HDL modification is not going to alter, like what he says. All the drugs that have increased HDL cholesterol have not shown benefits. Because it only increases the HDL level, but not the functionality of HDL. What it means is reverse cholesterol transport. It does not pull back the cholesterol or the lipid from the plaque back to the liver. That does not happen when the HDL rises. On the contrary, what it actually did, most of the newer drugs, in fact, their obesity is coming in as a HDL lowering drug. Because what it did was, in between it was transferring the cholesterol from the LDL into the HDL. It was not doing reverse cholesterol transport. So it is actually taking a different picture. But having said all this, increasing HDL cholesterol physiologically with exercise and probably a little bit of these walnuts and dry fruits, those are really beneficial. Wine, yes, to some extent, but I don't think you can recommend it medically because it's now proven as a carcinogen. There is also a J curve in the HDL cholesterol, which we must remember. The sweet spot is between 40 and 70. If it goes more than 70, in fact, the European Society of Cardiology says more than 90, when the HDL cholesterol goes up, it can actually be harmful. Because it produces what is called as dysfunctional HDL, and it works as bad as the LDL cholesterol. So HDL is a very, very tricky thing. So when a patient tells him, tell him we are more worried about LDL cholesterol, I think it's better to get the HDL cholesterol by physiological method. That I think should be the moral. In this particular patient, in a female patient, what I'll be worried are the other women-specific risk factors. One he mentioned is menopause, early menopause. Early menarche is another problem. All pregnancy-related complications, pregnancy-induced diabetes, pregnancy-induced related hypertensive disorders, any fetal loss, recurrent abortions, all these are common soil and they are more prone for coronary artery disease. Probably if all those are there, I will be more inclined to start early statins for these therapy. The last point about this is an LDL cholesterol of more than 160 in India. The current recommendation, we say that start looking at familial hypercholesterolemia. Generally is 190. But in India, I think at 160, we should start looking at familial hypercholesterolemia. I think the LAI chairperson, vice chair is here. I think he should probably mention about the risk scoring that we are doing for the Lipid Association of India, which is also coming up. We are validating it right now with 2 prospective trials. One is the primary prevention group and second is the ACS patients. It will probably be published in the next 3 or 4 months.
So if at all you are treating, what will be the dosage and what will be the target, sir?
It is like our dutiful endocrinologist dealing with these kind of patients. He will repeat once more. The lab in the discussion lab. We assume that the labs are the best and you have done the best, and it's and conventionally I have been seeing only at fasting lipid profile. And though there are a lot of papers I read on non-fasting and anything, recently I also spoke. I had to review that small literature. I am personally of the opinion that conventionally it is working well for us, so I will heavily rely on a fasting lipid profile. And secondly, in a different lab, And there are variations in the methods they use sometimes. So repeated values are showing this, and after lifestyle modification, then
A very strong point on this is that if it's a calculated LDL Fried-Wald equation, you can do that. If it's a direct LDL, very rarely the difference is there. So direct LDL. In fact, past 12 years, I have not been doing a fasting lipid profile. All my patients, I do only a non-fasting sample. I've stopped it long ago.
I slightly differ from what he is saying is because I do fasting blood glucose along with other things. So I have to do a fasting thyroid profile many times. So as part of a single prick, I do this. That's the answer I give for all practitioners also.
I think we should come to consensus now because both the endocrinologists and the cardiologists are now trying to tell different stories about the lipid profile. So no, there are certain situations which definitely warrants you to send the patients lipid profile in a fasting state, particularly in those patients in whom you have high triglyceride and you are going to have a good follow-up of these patients, you require only a fasting sample, number one. Familial hypertriglyceridemia, it warrants only fasting lipid profile. Number two, in cases where you are going to send the patient for a fasting sugar value or a fasting the thyroid profile values, I think it is mandatory that you should be sent only in the fasting state. Otherwise, there are a good number of studies which had gone to prove that fasting is not required. In Denmark, they started long back and they are not doing it at all. Non-fasting sample is as good as the fasting sample as far as the LDL is concerned. Only problem is that 26 milligrams of triglyceride will go up in case there is going to be a non-fasting state lipid profile testing. Otherwise, all the parameters remain the same. So whether the patient comes at 4 o'clock in the evening or 5 o'clock in the evening, you send him for a lipid profile also, doesn't matter. In case the triglycerides are higher, you ask the patient to come on the next visit for the higher triglyceride to be evaluated. If it is grossly raised, for example, 1,000, 2,000, definitely it is fasting is required.
So we are going to the next case. Yeah.
As a cardiologist, I do a direct LDL. The specific reason, I have published a paper with about 30,000 patients between comparing Fried-Wald equation and the directly assayed LDL or the calorimetric method. The difference is there's a nearly 40% lower value of LDL when you use the Fried-Wald equation when LDL is less than 70. All the diabetics target is 70. So for all your diabetics, if you're going to achieve target and do a Fried-Wald equation, which most of the labs are doing, most of the bigger labs in Chennai are doing, it's all wrong. I think you have to select your lab where they're going to do a direct LDL. Fried-Wald, I think, is not accepted. There are other formulas like the Samson equation, slightly better, but still direct LDL is better.
I think we were also, I think one paper we had also published, and sir's paper, your PG or somebody was in the ethics committee, I was there, Sundara Medical. Yeah. So that's a wonderful point what sir is making is,
Really?
but thankfully all the commercial labs in Chennai and wherever corporate hospitals we are all working most often, they do direct LDL. So calculated LDL is out of vogue at least in Chennai. Just like free T4 is the only vogue in maybe. But they mentioned whether it
Yes, it's calculated or not. Yeah.
It is direct. It is direct. Yes. Ella direct. Ella direct.
Anderson,
Ella
no,
direct.
lister
I
is
can call now
calculated.
to all the corporates. Sorry.
So Lal's is direct. Lal's is
Sorry, you
direct.
can recheck.
I do a study with
The
Lal's.
first study I
Anderson
did-
is direct.
The first study I did this, which was quoted in sir's paper also, is because they started doing direct LDL only, we compared with calculated versus direct. We will have a debate.
Yes, sir.
on
We'll
this.
go. So
But
the next question for Dr. Prabhakar.
இல்ல அதுல
Mr.
தெரிஞ்சுக்கணும் அந்த பாயிண்ட்
ஆமாம்.
அது என்ன இன்ட்ரெஸ்டிங் பாயிண்ட்னா சார் சொன்னது
No, one question, sir. What will be the difference, sir, for fasting LDL and PP?
The only difference is cutoff for the triglycerides. Triglycerides 150 for your fasting sample, 175 for non-fasting. That's all. Otherwise, you don't have to. I'll take this case. 56-year-old diabetic, hypertensive, dyslipidemia. Father had an MI at 52 years, atorvastatin 20 milligrams. So basically, more than 40 years, my threshold for starting statin is very low. Because I think 40 plus, I think Indians are more prone for coronary heart disease, I start them. So if you're going to be a diabetic and if you're going to be hypertensive, I think this case is better suited for Dr. Narsingan sir to answer because it's a diabetic dyslipidemia. I probably pass it on later to him. In a diabetic, very simple, the goal LDL cholesterol is 70 milligrams per deciliter. But if you have multiple risk factors like a strong family history, hypertension, if your patient is having any kind of like stress test or something is abnormal, you can still go further down. And 20 milligram atorvastatin is not doing the trick. For this, all his patients have very high LDL. I don't know why. I think he's got bad set of cases that are discussed. 131 LDL is no longer, I think you have to change your doctor, that's all. Get it down to 70.
Sorry to interrupt, you can please comment, sir. Many times our diabetic patients in the they are already having LDL of 80 and 70. With the mild coefficient of variation in the lab, would you be still adding a higher statin to lower? When you go by the number of small touch, the number of functional and the
Functional, we can't check now. So 70 is what I target. So if it is going to be less than 70, you're probably justified not in starting statins. So whenever somebody is more than 50 and I don't want to start a statin, I do a coronary artery calcium score.
This patient, sir, he he takes the statin weekly once.
I think.
Is it statin or Ozempic, sir?
Yeah, the problem here is the patient is a diabetic, number one. He's 56 years old, number two. Number three is also an hypertensive. I think probably would have been having a silent subclinical atherosclerotic cardiovascular disease, definite. In that individual, if you are having a parameter like this, which are abnormal, typical Asian Indian phenotype, where you have higher triglycerides and a low HDL, with the increased proportion of small dense LDL cholesterol, maybe. So these are the things which definitely attract our attention. We need to put the patient on a higher dose statin, not the usual low dose or a moderate dose statin. It is not going to work here, because you need to assess, because the patient also gives a history that his father died at the age of, not died, he had a myocardial infarction at the age of 52 years. That means a premature coronary artery disease in the family. So you need to evaluate the patient's atherosclerotic cardiovascular disease, and at the same time you should give him an aggressive management of lipids, concentrating mainly on LDL lowering drugs first. Later, if the triglycerides are also not responding to the treatment, in spite of a good lifestyle modification, in spite of a good diabetes control, if the triglycerides are still elevated, till you have reached the LDL cholesterol level of 70 milligrams, in that individual, probably I will not hesitate to put him on icosapentaethyl ester, 2 grams in the morning, 2 grams in the evening, to concentrate on the triglyceride reduction.
So next case.
Another question for this. This is for Dr. Sriram. That patient comes and tells you, I'm taking atorvastatin, you're giving me a statin, higher dose of statin. Will it not worsen my diabetes? What is your comment?
Again, thanks to
Somebody has to ask him questions. He's enjoying himself here.
sir,
உங்களுக்கு அடுத்து ஒருத்தர் இருக்கார், அவர் மறந்துட்டேன்.
No, the first case, the Prabhakar, in the first case, that's a young individual, 24 years. There, if you start a statin also, diabetes is a problem.
Yeah, it is now well proven in prospective studies also that statins induce diabetes. Having said this statement, it has to be balanced against Dr. Prabhakar's cases. The prevention of CAD by statins is overwhelmingly so good that you have to weigh the risk. And in general, rosuvastatin has a slightly more adverse effect on this than this. So practically what I follow, it may not be slightly fully evidence-backed, but whenever we have this doubt, we give atorvastatin. If I start rosuvastatin, the chances that the patient will go into diabetes, especially pre-diabetes to diabetes, we are seeing in our health checkup, follow-up and all. But worsening of diabetes, in the patient, no question. It will worsen diabetes. We say in pre-diabetic obese who are on, started on statin, they are getting converted. HbA1c gradually climbs up from 6.1 to 6.4, 6.8. We see that commonly. Adhika statin if they are high risk.
The statin-induced nuanced diabetes is dose-dependent. At 20 milligrams, there's a 13% chance, but those are for patients who already have a tendency towards diabetes. Obese patients, pre-diabetes, borderline, impaired fasting glucose, slightly elevated HbA1c. Those are the patients who go in for, not the other people. Those patients, you do lifestyle modification and still give the statin. Because the risk-benefit has been calculated, the benefit is 50 times more than the risk of getting diabetes. So don't hesitate.
So
and
next-
at 10 milligram rosuvastatin, it doesn't create a problem. The hazard ratio is 1.02, hardly anything.
So for Sriram Agadevan, Mr. B, age 29 years, known Addison's disease. Since the age of 15 years, he is on Visolon 5 milligram BD and fluorocortisone 0.1 half OD. He is euglycemic still now, but normotensive. These are his lipid parameters.
Male patient with Addison, that means primary adrenal insufficiency usually is not associated with severe hypercholesterolemia. It's the other way around. We all know that steroid excess causes hypercholesterolemia, but you have given a very
No, real patient's data, sir. This is a real
this man, this
boy.
young fellow, 15 years he is on this. That means he may be either on the autoimmune or type 1,
Yes, sir.
polyglandular, etc. We will not go into the endocrine part of it. But the interesting, important part regarding dyslipidemia is, first of all, the association is slightly odd. Secondly, he is on prednisolone at a very supraphysiological dose. We don't usually replace Addisons with this dose. We usually give only
7.5.
hydrocortisone is easily available, so we give only hydrocortisone of only 15 milligram per day. That means 10 and 5. Compared to that, he is taking 20 to 25 milligram per day. So that itself is a risk factor for metabolic things. And fluorocortisone, fair enough. We will not change that. So from that side, we have to reduce for that. So there is a secondary cause here. And I hope he is not a type 1 diabetic. Or
No, not it.
Then it comes to the same question of, this is a very high LDL is an independent risk factor. Sir has already stressed the importance of how we miss familial causes of hypercholesterolemia, which is seemingly genetically, they are two different disorders to my biological understanding, but there is something wrong here. The LDL is very high. Primary type 2 kind of some dyslipidemia, inherited dyslipidemia, I will seriously consider. I request our patients to always get their family members at least screened. But Vanda, you will get the answer immediately.
He is from
Today
the
we have
fisherman's
genomic
family, sir.
studies also quickly.
Nobody in his family is diabetic or any other thing.
So
He is coming from a fisherman's family.
This is definitely going towards that, and I will definitely take the help of Prabhakar sir and others to, a young age, you have to screen for other things. This LDL is very alarming to me.
So definitely you have to rule out familial labor. And in fact, if it goes more than 225 or 250, you'll have to be looking at homozygous type. Family screening, cascade screening. All the brothers, sisters, father, mother screen, you'll land up with multiple people with dyslipidemia. So it's going to be a challenge to treat it. If you're going to discuss dyslipidemia management and familial, there also the goal is 100. So whatever age you start to 100, otherwise you're very prone for problems. I have patients who have died at less than 10 years, at 20 years undergoing CABG, and they don't respond. Some of these patients who have an LDL receptor problem, they don't respond to statins, they don't respond to ezetimibe, they don't respond to the bempedoic acid, they don't respond to the PCSK9 also. Everything acts through LDL receptors. So you'll have to go for other drugs like evinacumab, which are not available in India as yet. It's going to come in shortly next year, that's what I heard. But it's a little bit of a challenge treating these patients.
So next for Kumaravel, Mr.
Now you want to ask a question, go ahead. You can ask a question. You want to ask a question. You can break in between.
In hyperlipidemia and diabetes, the statins, which statins will be more ideal, either rosuvastatin or atorvastatin?
Sir, I have totally moved to rosuvastatin because the more powerful statin, one. And the second question which I would have more appreciated is, can you give a combination with ezetimibe or rosuvastatin? Today, there are multiple studies which have shown the level of LDL is more important than the agent you give. Achieve 70 milligram LDL. Whether you want to give 10 milligram rosuvastatin with ezetimibe or 20 milligram atorvastatin with ezetimibe or a rosuvastatin 40 milligram, everywhere achieve the goal, that is more important.
The side effect wise,
Nothing happens, sir. Sir, I have hordes of
We'll
patients
talk, sir.
on triple. I have nearly about 1,000 patients on triple drug therapy. I have the data. I have not published it yet. I'm just collecting it. So I just have to collect the lipid profiles and publish it. Nothing happens.
So Kumaravel,
One small renal point, if renal is slightly on the lower side, atorvastatin may be
That data was there, but now the guidelines, even the KDIGO has kind of said any of the statins.
What about
can be-
statin-induced,
it's kind of okay now.
statin-induced myositis?
sir, we will talk, sir. We are having statin intolerance, yeah. Last case, yeah.
I think he's got a case of statin intolerance. We'll
Yeah,
talk on that.
we'll talk. So, Kumaril, Mr. A, age 45 years, diabetic, youth era, normotensive, dyslipidemia, and is on rosuvastatin 10 mg. And these parameters again here, you can see the LDL is not calculated. So, his triglycerides are very high.
I think this case becomes very obvious. The numbers are too high to really even think of anything else. We have to definitely treat this patient because any such a high triglyceride, the chance of pancreatitis or pancreatic pathology is very high. And especially even diabetes patients per se, they have increased incidence of pancreatic pathology also. So this patient already on rosuvastatin, I think adding a phenofibrate, omega-3 fatty acid would be the ideal for this patient.
But before that, please control his diabetes well. 50% of triglycerides can come down.
This is the second reading, sir. First reading was like that. Again, he came with this thing.
7.5 thyroid and diabetes should be definitely controlled, and if he has nephropathy, that has to be all these are easily correctable secondary causes of dyslipidemia in many of our diabetic patients.
Sriram is a bad student. He finds fault with the examiner.
Second slide. Next slide.
Another point about all these triglycerides is that you must remember, whenever the triglycerides are high, the HDL is always low. Why is it so? Simply what happens, the HDL particles also contain triglycerides. So they occupy a predominant portion of the HDL molecule, and there is not much of cholesterol inside. That's the main reason. So you get the triglycerides down, actually the HDL will start going up. I think in this particular case, my opinion will be slightly different. I would have put this patient on saroglitazar. Because vis-a-vis phenofibrate and saroglitazar both have no outcome studies for the heart. And when the triglycerides are more than 500, you're only trying to avoid pancreatitis, it's not coronary artery disease. So when you want to avoid pancreatitis, you have to get the triglycerides down. I will put them on saroglitazar, which is more powerful in reducing triglycerides than anything. But like I said, the most important thing from the beginning I've been saying in triglycerides, 50% lifestyle modification.
Okay. Can I come
I have a question.
Yeah, no problem, sir.
Sir, I have a question, sir. Sir, for myself, I did. Sir, myself, I did a post-meal 2 hours lipid profile after consuming 2 eggs, egg yolk. The triglyceride
With
was
how many drinks?
2 eggs.
How many drinks?
Sir, no.
Questions upper
TGL was 490. Next day morning, TGL was 130 fasting.
So this is postprandial hypertriglyceridemia. That is an independent risk factor for coronary artery disease. I've spoiled your party.
Yeah.
Next time Arul will never come here.
I think I have got only about 5 minutes to discuss one important case. In fact, I must congratulate Dr. Krishna Sheshadri for the wonderful conference which he has arranged. And he has sent a message in the WhatsApp group that we should come in the traditional dress. And he put photographs. That's why now I came with his dhoti and all. Surprisingly, all the other 3 people are in the usual dress. And I am the person, odd man, sitting there on the other side.
He didn't include me in the group, sir.
Anyhow, I think it is not only the debate had given us an opportunity to come in a traditional dress, and Dr. Krishna Sheshadri was very much happy to see me like this because he had not seen me in dhoti. So nice. I would like to project only one case. Mrs. M is a 47-year-old with hypertension, dyslipidemia in a postmenopausal state. She had poorly controlled hypertension for a number of years. Her BP was 185 by 110. The pulse was 92 per minute. Both her parents and the siblings were severe hypertensives. Echocardiography revealed left atrial enlargement and significant left ventricular hypertrophy, and estimated EF is about 60%. ECG confirms the left ventricular hypertrophy, spiking QRS complexes anteriorly, but she does not have any arrhythmia, nor is there any evidence of ischemia. Fasting blood sugar 96, base circumference 84, renal indices normal, physical examination unremarkable, except for the presence of S3 gallop. Our rate of urinary albumin excretion is about 21 milligrams. Lipid profile shows total cholesterol 274, LDL 195, triglycerides 120, non-HDL 219, HDL is 55. Mrs. M is in the range of high-risk category because the cholesterol is high, the LDL is high, she is a hypertensive, strong family history of hypertension, and she had some problems in the ECG also, and left ventricular hypertrophy, EF is about 60, all those parameters had been taken into consideration and she is put in the highest category. Given the severity of her hypertension and her lipid goals are said to be more stringent to the target levels of less than 70 milligrams. She started on aggressive antihypertensive management on combination therapy. Simvastatin, that was the time. In 2001, I encountered this patient. So we put only on simvastatin during that time. So simvastatin 40 milligram was started at that time. After 1 month of therapy, her blood pressure was 150/90, pulse 78. Serum creatinine was stable at 0.8. At 6 weeks of simvastatin therapy, the LDL came down to 112. LFT remained normal. Our simvastatin was increased to 80 milligram dose. That was the time when usually you give about 40 milligram, the patient is not responding or not reaching the goal. You are supposed to increase the dose, like what you do for 20 milligram of Rosuva, then increase it to 40, or 40 milligram of Atarva, increase it to 80 milligram. The same way we were doing it during the time when the simvastatin was available. So 112, it has to be brought down to levels of less than 70 milligrams, so I increased it to 80 milligram OD. She was advised to return to the clinic to follow up of 6 weeks. At that time, her BP was 138/85 with a stable serum creatinine. When she came back, TC was about 175, LDL was 96. She had not touched the goal. Triglyceride 90, non-HDL 116, HDL 59. She was advised to remain on all our medications and follow up at the width of 6 months with the repeat lipid parameters as liver parameters. After 6 months of therapy, the patient profile was stable and at target levels. However, the serum ALT and the serum ASP levels increased to 1276, 1050 international units respectively. So 1276 OT and then the SGPT is about 1050. She felt well and was not experiencing any myalgia. So what do you suspect as a cause of abnormal LFT? Can anyone tell now? Quick. Can you permit me another 5 minutes? No problem? You are the one who is managing the entire show.
கௌரியை பயன்படுத்திட்டீங்க சார். பயந்து பேசுறாரு சார் அவர். மிரட்டுறீங்க சார் ரொம்ப.
What do you suspect as a cause of abnormal LFT?
Sir, we have to suspect statins are not being a lipid session. We have to suspect.
Yeah.
I would rather definitely suspect statins, and though there is a risk factor for CAD and all, my question to you and sir also is, see, withdrawing for 2 weeks, 4 weeks just on a trial basis and see whether the LFT improves will add a lot of value to a clinician. No?
You are perfectly correct. That is the best approach, okay? Now, she was asked if she had been started on any new medication by another physician because she had some problems. In the ECG, the QRS complex was not there, was spiked QRS complexes, LVH, and suddenly she had some atrial fibrillation for which she had consulted a cardiologist, and 3 months back, and she was admitted to the hospital by a cardiologist for treating atrial fibrillation. She notes that she underwent successful cardioversion and was started on a new medication for heart rhythm disturbances, Prabhakar. She was placed on amiodarone 200 milligram BID. I don't want Prabhakar to tell the answer now because Prabhakar knows about it. Amiodarone 200 milligram BID. So what do you think is the problem now? Prabhakar.
Sriram is willing, sir.
No, one of my guesses is amiodarone per se can cause liver dysfunction, but usually whatever few things we have seen is it's in the long term. I don't know it will cause in the short term. Or amiodarone would definitely cause thyroid dysfunction, which can be both short term and long term.
Okay.
So hypothyroidism can also contribute to this. The OTPT will not go so high in hypothyroidism also.
It is
so
well
amiodarone
documented.
induced issue is also a possibility.
It is very well documented that in patients with amiodarone or verapamil, any calcium channel blocker like
long-acting one like verapamil or diltiazem, the dose of simvastatin should not exceed 20 milligram. So what we did was 40 milligram, went to 80 milligram. So that is why there's a problem has started. Simvastatin was discontinued and our LFT was monitored every 2 weeks. Transaminase is steadily improved with the decreasing ALT and AST values. Within 2 months, her LFTs were back within normal range. Will you restart statin for her? If so, what statin? That's the question now. Can you restart statin now for this patient? Other statin, not simvastatin. So you mean to say that hydrophilic statins probably will help her? Okay. So she was treated with rosuvastatin 20 milligram with no subsequent toxicity and the lipid targets were achieved. At that time of initiating the amiodarone, our cardiologist should have switched over to another statin such as rosuva or atarva, which are not known to interact with amiodarone. See, these are the drugs which can react or interact with the amiodarone. So it's one of the important conditions which need to be remembered, apart from the usual components of statin intolerance. The moment you start thinking about statin intolerance, like myalgia, myositis, and all those things, number one. Number two, liver function abnormalities. Number three, the cognitive abnormalities. Number four is the new onset diabetes. These are the things which need to be kept in mind as far as the statin intolerance is concerned. Generally, number of academic bodies have come out with different figures with respect to the statin intolerance, but overall it is about 9.1%. If you look at this particular diagram, you will remember it forever. If you look just this only meta-analysis, which had given us a lot of information, what are the things that can probably be increasing the patients to get into problems of statin intolerance, starting from Asian race, the females, or the patients with diabetes, or the patients who have chronic kidney disease, or chronic liver disease, all those things will increase. That's most important. We, in fact, 2020 Lipid Association of India came out with this recommendation how to manage statin intolerance. I think myself, Dr. Prabhakar, Dr. Raman Puri, and all those people in Lipid Association were discussing a lot of times, and finally we came out with this sort of algorithm. So this algorithm gives you an important information how to manage statin intolerance. If the patient comes with a myalgia or so-called muscle pain, try to think about other problems first. Rule out other problems, including the congenital problems involving the muscles, and look at the problem whether the patient has got a proximal muscle involvement, bilateral involvement. That's the most common thing, which can be encountered after starting statin 4 to 6 weeks maximum. If that is encountered and if you are doing it, please ask for CK. If the CK values are less than 4, you need not stop statin. You try to encourage the patient to continue the drugs and keep a watch on this patient. If it is between 0.4 times to the upper limit of normal and up to 10 times to the upper limit of normal, stop the statin and try to give the patient a benefit of restarting the statin, de-escalate the dose or switch over to another statin, give it an alternate days or give it bi-weekly, and then go on assessing the CK. And if the patient is comfortable, continue to give that. If the patient has got more than 10, you need to stop. You need to stop the statin and then get the consultation with the nephrologist. You should restart some other drug other than statin, maybe bempedoic acid, maybe the inclisiran or the PCSK9 inhibitors, or including ezetimibe can be considered in such situations when there is more than 10 times the upper limit of normal values of the CK. That's how the message is given clearly here in this algorithm, how to manage the statin intolerance in patients in whom you have a severe myalgia or myositis or so-called rhabdomyolysis. The other thing is the new onset diabetes, I think has already highlighted that. Liver enzyme abnormalities, which we have told. And I think cognitive impairment, the neurologist, he got himself introduced to me when I was walking here. He was the first person to say that your costume is good. So I need to give importance to the neurologist. He told me, I think the cognitive disturbances which you are all worried is not there in high dose statin also. it has been disproved.
I want to add 1 or 2 points to this particular image. We worked out on this picture. What is most important is what you see on top. All these joint pains, muscle pains are not statin related. It happens within the first 3 months of starting a statin or dose escalation, and it has bilateral, symmetrical, usually involving proximal thighs. There's a scoring system for this, but it's usually up lower limb, proximal muscle, bilateral, symmetrical involvement. All these kind of vague joint pains, knee pains, and ankle pains, which the orthopedicians keep telling it's because of statin and stopping statin. Please don't justify and don't encourage. And in all these things, the idea is to restart the statin. So you wait for every 2 weeks. Once you stop a statin, which sir had explained, every 2 weeks you recheck and restart the statin. You can either start a different statin, same statin at a lower dose, or a combination therapy which is acceptable. Or if you don't want this, bempedoic acid does not have these muscle side effects because it does not get metabolized in the muscle. The last resort is what pitavastatin is. At pitavastatin, the incidence is much lesser. It acts through different mechanisms. So pitavastatin also can be an alternative which can be tried. The one condition where you don't give the statin again is, if you have an elevated renal parameters, don't restart statins. That I think we should remember. Which I've seen it happen and patient come back with acute kidney injury despite all this. So you don't give it in that condition. That's the only thing you have to remember. But I think by and large it's very, very less. It's about 6 to 7%. I can still count and tell you which of my patients have developed rhabdomyolysis and gone for dialysis. It's hardly anything.
So thank you for the excellent discussion, sir. Thank you once again. And if at all any questions are there, you can discuss during the dinner time. Now it is time. You can, I think lunch time. Sorry. Thank you, sir.
Thanks, Dr. Selva.
Thank you, sir. We will now break for the lunch, and we will be reassembling exactly at 2:15. And there is a small change in the program, like the obesity masterclass, which is scheduled at 4 o'clock, has been preponed to 3:40. Obesity masterclass is preponed to 3:40.
Good afternoon, friends. It's a great pleasure to welcome you all after the wonderful lunch. So now we have the interesting sessions, therapeutic session 6. It's a great pleasure and honor to invite our mentor, Professor Murthy sir, as a chairperson. Welcome, sir.
Good afternoon, friends. Am I audible? Welcome to Therapy Symposia 6. You have 3 talks by very eminent and erudite speakers. To get the ball rolling, the first talk will be by Dr. Periyandavar, and the topic is the novel duo with a special focus on empagliflozin and linagliptin. And Dr. Periyandavar is Senior Consultant Diabetologist in Apollo Proton Clinic.
Most respected chairperson, respected senior colleagues, my dear junior colleagues, it's my great pleasure in sharing some of my views on this topic, novel duo with a special focus on EMPA and Lina. And these two, basically Lina and EMPA, we have been talked much about in the past 1 decade or 1.5 decades. So today I will be sharing some of the basic history of development of diabetes management for the juniors and PG's shake, and there is no financial disclosure, though it's supported by micro labs. And pre-test question MCQ, which of the following is a unique pharmacokinetic advantage of linagliptin compared with other DPP-4 inhibitors? A, requires dose reduction in hepatic impairment, predominantly excreted unchanged in urine. C is no dose adjustment required in renal impairment. D is higher risk of hypoglycemia as monotherapy. Coming to the answers, we will discuss at the end. MCQ 2, which of the following best explains the clinical rationale for combining linagliptin with empagliflozin in type 2 diabetes management? A, both drugs act by stimulating insulin secretion. B, complementary insulin dependent and insulin independent mechanism. C, no risk of genital infections with the combination therapy. D, combination eliminates need for metformin. So today my talk, the first portion will be introduction, then few minutes for linagliptin I will allot, and a few minutes for empagliflozin. Then I will little concentrate on CRM, the cardiorenal metabolic syndrome, and concluding remarks. So changed concepts in the treatment, we all agree with me. Yesteryears, 3 decades back, the concept of diabetes treatment was just symptomatic. As symptom comes, we treated. Then came glucocentric. We had a target, fasting sugar 120, 130, postprandial 180, 170, 180, 200, and HbA1c 7, 7.5, 6.5, like that. And now, in this modern era, much more sophisticated, beyond glycemic levels, targeting complications, comorbidities, which are guideline based, and almost all the guidelines are based on randomized control trials. So the modern diabetology, the seed for modern diabetology has been sown by Revens, who postulated Revens syndrome, metabolic syndrome, with insulin resistance, which plays a pivotal role, and hypertension, diabetes, dyslipidemia, obesity, ultimately leading on to atherosclerosis. It has been extrapolated to mitochondrial dysfunction, ATP, and other RAS, AGE, and inflammatory markers, ultimately leading on to CV death and deaths. For decades, we have been concentrated on this hyperglycemia, which produces the major havocs like advanced glycation end products, and this protein kinase C pathway, polyol pathway, there are so many other pathways. And PKC pathway is worst in producing the inflammatory markers and all the vascular havocs. So this is the glycemic triad which have been treating for decades, and it has been after the era of DPP-4 inhibitors that glycemic variability was added. And in the year 2009, D. Franco, in his prestigious Banting lecture in ADA, he has postulated ominous octet. There is 8 pathophysiological factors for diabetes, and now treatment is based on this, all addressing all the factors. And all the conventional medications, they have some or other side effects. For example, glibenclamide insulin has weight gain and hypoglycemia, and pioglitazone having edema, and carbos having GI side effects, and the long-term glycemic control is not good with the conventional molecules. And one thing, we all should keep it in our mind before prescribing any medicine. What the Hippocrates told was, primum non nocere. That's a Greek terminology, which means first do no harm. We should not harm our patient with our medication. So now I will go to individually highlight about linagliptin. This is the rationale for linagliptin. The first one is improved glycemic control and reduces glucose toxicity. Hemodynamic effect diminishes intraglomerular pressure. It has anti-inflammatory action, TNF-alpha, IL-6, MCP1, anti-fibrotic effects, and reduced oxidative stress, and natriuretic tubular effects, and improved renal perfusion. To highlight this, so improves renal endothelial function. Second is reduces kidney fibrosis. Third is microalbumin independent of glucose and BP control. This has only CVOT outcome trial to have renal endpoint. The CVOT outcome trial is Carmelina. I need not go about this. Across all spectrum of CKD, whether it's a stage 1 mild CKD or moderate CKD or severe CKD, the glycemic control is appreciated, 0.7%. And of course, new onset diabetes after the transplant, they are much benefited, which HbA1c reduction of 0.6. And diabetes in renal transplant bed, type 2 diabetes going for renal transplant, there the efficacy is much, much better. And top of ACE inhibitors in ARB, linagliptin has additional benefit on albumin reduction. And this effort study shows it's a vascular protection, endothelial function improvement. And now coming to the empagliflozin. So empagliflozin, it has many pleiotropic benefits. So linagliptin has 1 or 2 pleiotropic benefits, but EMPA has many, many. So the main mechanism is tubuloglomerular feedback restoration. So we all know while blocking the proximal convoluted tubules, that SGLT2 receptors, more sodium enters into distal convoluted tubule. So the tubuloglomerular feedback, so the afferent arteriolar vasoconstriction, thereby intraglomerular hypertension will be reduced, thereby the albuminuria reduction is much appreciated. And improved myocardial energetics, that is increased ketone utilization and mitochondrial efficacy in the heart. And reduced oxidative stress has been appreciated, and anti-fibrotic effect and metabolic effects have been well documented. And the landmark, the CVOT outcome trial for the empagliflozin is EMPA-REG outcome trial, which has given us 3 major outcomes. So one is CV benefits. So benefits from CV death is phenomenal, 38% CV reduction, CV death reduction. Second thing is hospitalization for heart failure rate is much, much reduced. So even starting after few days to few weeks, the gap we can appreciate. So it's a very useful in patients with heart failure. And the third important thing is good glycemic control, HbA1c reduction. Thereby we get good glycemic control. And of course, other trials, Emperor reduced, Emperor preserved trial, and other thing, based on these clinical trials, FDA has approved empagliflozin for heart failure, regardless of ejection fraction, whether it's reduced or preserved or mildly reduced. And the mechanism of weight reduction we should appreciate. So originally we thought the weight reduction is due to only glycosuria and negative energy balance. And apart from that, other factors like this action on regulation of adiponectin and leptin, that is adipose tissue specific adipokines. And other pleiotropic benefits like increased erythropoietin secretion, thereby increased erythrogenesis, increased circulating progenitor cells, diminished inflammatory markers, and beneficial effect for heart, increased oxygen delivery, diminished left ventricular mass. So these many, many pleiotropic benefits we have with the SGLT2 inhibitors. Next, coming to the third part of my talk, the CRM or CKM, cardio, renal, metabolic syndrome. So metabolic component I have discussed early regarding pertaining to Revance syndrome. So high insulin resistance increases cardiovascular risk by 2.5-fold. So insulin resistance produces fatty acid metabolism derangement, increased free fatty acid, more free fatty acid oxidation produces all the oxidative stress and increased inflammatory markers that produces. That is one component of CRM, that is metabolic component. Second thing is the cardiorenal component. So look at this, one organ getting damaged, it damages other organs subsequently. So one is macrovascular, one is microvascular, both the macrovascular combination it's a deadly duo. Okay, so look at this cardiac remodeling, ventricular dysfunction, heart failure, leading on to low cardiac output and chronic hypoperfusion, subclinical inflammation, leading on to tubulointerstitial fibrosis, glomerulosclerosis, EGFR decline, and progressive CKD. The CKD produces sodium and water retention, hypertension, RAS overactivation, anemia, uremic toxin, again aggravating atherosclerosis. This is a cardiorenal syndrome. The basic thing is diabetes, comorbidities like hypertension, dyslipidemia, producing oxidative stress, inflammation, endothelial dysfunction, everything, glucose and lipose toxicity. There are many, many articles pouring in for the past 5 years, starting from 2021, when American Heart Association formed one consensus group consisting of endocrinologists, physicians, diabetologists, cardiologists. And they all sat together and coined the name CKM, cardio kidney disease. And all the three departments, cardiology, endocrinology, and nephrology, the lot of journals are posting in. Then coming to the management aspect. So, usual conventional treatment is step care therapy. Start with monotherapy, if not failing, add 2 drugs, then add 3 drugs, like this step care therapy. But what do guidelines says? Let us go through the guidelines. So, conventionally, all the guidelines says, they also voted for step care therapy. Start with monotherapy, if not under control, dual therapy, if not under control, triple therapy, like that. Until 2017, ACP also has gone through the same thing. Only in 2018 or 19, ADA and EASD, they sat together. They produced a consensus report. That is, instead of the glucocentric approach, go with the atherosclerotic CVD or CKD based on these comorbidities. If these two are there, either disease is there or risk factors are there. So if it is yes, so they have either SGLT2 inhibitors or GLP-1 receptor agonist. If there is no CKD or atherosclerotic CVD, and go with the other pathways. So 2023 AACE consensus statement also, 2 categories. One category is glucocentric algorithm based on overweight, based on hypoglycemia risk, based on cost for middle and low income countries, and severe hyperglycemia. Like that, they have various group. And another group is this complication-centric algorithm. So when there is atherosclerotic CVD, choose GLP-1 receptor agonist or SGLT2. If there is heart failure, choose SGLT2 inhibitors. So like that, it's organ-centric. Then this ESC, European Society of Cardiology, it also highlighted about the importance of adding SGLT2 inhibitors with all the patients with heart failure. And coming to the renal nephrologist, so KDIGO 24 guidelines, this also highlighted about the including of SGLT2 inhibitors in all the patients, whether it's stage 1, stage 2, stage 3 CKD patients. Our Indian guideline, RSSDA guideline also has approved. The guidelines recommend SGLT2 inhibitors plus DPP4 inhibitors for treatment of type 2 diabetes for patients with high risk for atherosclerotic CVD, heart failure, and DKD. Then now, what should be our approach? Gradual intensification or tight control? Obviously, tight control. So, original conventional step we should avoid. Okay, so from the start, we should aim at tight control. For this, the evidences for initial tight control having beneficial effect in long run is 2-3 studies. One is UKPDS, second is DCCT. Their follow-up study. After the completion of trial, 10 years that all the patients have been followed. So initial intensive treatment, so they had less complication when compared to the original unconventional treatment patient. So of course, this is one latest study, diabetes and aging study, which highlighted about those who achieve HbA1c level of less than 6.5 within first year of diagnosis prevents risk of complication. So we have to strike it early. So not with monotherapy, with dual therapy, or with metformin combination triple therapy. So fixed dose combination of EMPA and LINA has several benefits. So several landmark clinical studies have proved efficacy of LINA and EMPA. Both EMPA and LINA are being prescribed by Indian doctors in their routine clinical practice. Both EMPA and LINA demonstrates comparable pharmacokinetic characteristics and are given once daily. And the fixed dose combination, lot of studies are coming across with the beneficial effect of fixed dose combination, EMPA, LINA combination. Japanese, Bangladesh, US, many studies. So with this, the SGLT2 and DPP4, they have unique synergistic action on blood glucose control. SGLT2 has increased glucosuria, weight loss, reduces glucose toxicity. DPP4 increases GLP, increases GAP, weight neutrality, diminishes hyperglycemia and other pleiotropic benefits. So to conclude, tight glycemic control should be targeted right from the start. Linagliptin-empagliflozin combination offers significant long-term glycemic control. Attributes of Lina and Empa are maintained in combination 2, increased adherence and cardiorenal benefits. Both Lina and Empa confers renal protection through metabolic, hemodynamic, anti-inflammatory, anti-fibrotic, and antioxidant pathways beyond glucose lowering. Thank you for patient listening. Now let us come for the MCQs. So the first question, which of the following is unique pharmacokinetics advantage? Obviously, so even before you all agree with me, no dosage adjustment required in renal impairment. So any stage, same 5 mg linagliptin can be continued. Stage 1, stage 2, stage 3, even end stage, even on patients on hemodialysis, it can be given. So coming to the second question, clinical rationale for combining. Both have complementary insulin dependent and insulin independent. So linagliptin, insulin, it's an insulin secretagogue, and this empagliflozin is insulin independent. It does act through the glycosuria. So I think discussion at the end.
Thank you so much, Dr. Periyandavar, for
Thank you, sir.
Please do join me here. We'll have the discussion after the 3 talks. The next talk is on aggressive control with novel triple therapy, glimepiride, metformin, and sitagliptin. And the speaker is Dr. Vijayabhaskar Reddy, consultant endocrinologist, Vijay Diabetes, Thyroid and Endocrine Clinic, Puducherry.
Thank you, Chairperson Sir, Dr. Murthy Sir. Thank Microlab for having given the opportunity to talk on this topic. So there will be some overlap with the previous talk. I think all of us are discussing drug combinations, but I'm going to talk about a different combination. So we have been using combination therapy for the last few years for diabetes management. I think Sir has already highlighted the benefits of better compliance, reduced pill burden, and reduced cost also. So the combination I am going to talk about is on aggressive glucose control in type 2 diabetes with novel triple therapy, glimepiride, metformin, and sitagliptin. So before going on to the topic as such, I want to highlight that when we are talking about management of type 2 diabetes, we should not focus only on the glucose levels. So all the studies have shown that we have moved away from a glucose-centric approach to a holistic approach. So when you're looking at a diabetes patient, you have to focus on hyperglycemia, which is a central problem, but all other factors also you should give equal importance. You should control their hypertension, should control the dyslipidemia, smoking cessation should be told to the patients, aspirin, body weight maintenance, and diagnosis and management of complications. So we should not lose track of all these aspects, but for today's purpose, we are going to talk only about hyperglycemia. So current hyperglycemia treatment in diabetes, although we are talking about drugs, but we should still remember that the foundation of diabetes management includes diabetic diet and exercise and lifestyle. Then we have anti-diabetic drugs. Traditionally we had oral anti-diabetic drugs. Now we have injectable anti-diabetic drugs also, which is not insulin like GLP-1 analogs. And then we have insulin. But today we are going to focus only on the oral anti-diabetic drugs. So how much we understand, we develop drugs according to that. So for a long time, the traditional concept of diabetes is there is reduced insulin secretion, there is insulin resistance, and there is increased hepatic glucose output. So for many years, we had only 2 drugs for this. One is acting on the pancreas to enhance the insulin secretion. They're called the insulin secretagogues or sulfonylureas. Then we have drugs acting on the insulin resistance, which is metformin, which is an insulin sensitizer. This slide, Dr. Periyandavar sir also showed. So once our understanding of diabetes increased, multiple pathophysiologic defects have been discovered. So we have drugs now acting not only on the pancreas and on the insulin resistance with metformin. We have this action on the incretin system, which Sir has already shown. The incretin effect is blunted in patients with type 2 diabetes. So by blocking the DPP-4 enzyme, we can enhance the incretin effect in diabetes patients, which leads to increased insulin secretion. So then we have this DPP-4 inhibitor is also acting on the glucagon and sulfonylureas causing insulin secretion. I think SGLT inhibitors, Sir has already shown in detail. Bromocriptine is no longer available. Glitazones also are insulin sensitive. So we have our option of drugs is quite vast, and this makes us to choose the right combination. We need, although a lot of newer agents have come, we cannot still forget our old agents. So that is why old is gold. There is a proverb. Just because new drugs have come, we should not put our old drugs in the dustbin. So now we know that a lot of new agents are there, but still we can see that sulfonylurea and metformin still remain the most powerful agents for diabetes management. We see that DPP-4 inhibitors, SGLT inhibitors, still they are not as powerful as the older agents. In the Western populations, the diabetes they are detecting at an early stage, which is mild diabetes. For them, milder agents are okay. But Indian patients are coming only when they are symptomatic with 400, 500 blood glucose levels. At this range, we need a powerful agents for diabetes management. That's why sulfonylurea metformin still plays an important cornerstone in diabetes management in the Indian setting because they still remain the most powerful agents. More powerful will be insulin, but straight away at the start, even if the blood glucose levels are high, patient's view is that I'm just starting with diabetes, I don't want to go to injection straight away. So give me tablets. So we need powerful agents for our patients. This slide, Dr. Periyandavar sir has already shown. So traditionally what we were doing, we detected diabetes, then we do diet and exercise. Then after 3-4 months or maybe 1 year, they go on one drug, then next drug, up titration. Here itself, by the time they go to combination therapy, it may take 5 to 10 years. So they are not controlled, not even once they reach the HbA1c of 7%. So we lose a lot of time, and we also know this concept of glycemic legacy, where the initial few years of diabetes is important, it leads on to the complications. So now what is recommended is an earlier approach. The combination, instead of here at 5 years, we start combination therapy right at the start. So the conventional stepwise approach is no longer valid. We need an earlier, more aggressive intervention approach at the early stage of diabetes itself. So the changing paradigm treatment in type 2 diabetes is we are moving away to early combination therapy, individualized approach, not reactive stepwise treatment, and we have to match to the individual. So we should be aggressive, not at a later stage when the complications have set in. We have to strike very early. So early combination therapy. What are the potential advantages of early combination therapy? So by using a early combination therapy, you are going to achieve the therapeutic goals and you are going to overcome the clinical inertia. There is potential reduction in the risk of side effects. You're going from metformin 500 milligram, 1000, 2000, 3000, you're going to get only gastritis. So keep the drug at a lower dose and keep on adding the other drugs. So if you combine drugs at lower doses, rather than uptitrating a single drug, your side effects will be lesser. There is opportunity to combine drugs acting on different pathophysiologic mechanisms. So you have drugs acting on complementary modes of action. And thereby some of the drugs like DPP-4 inhibitors also shown to delay the disease progression. From the patient side, you're giving a single FDC with 3 drugs, so better patient compliance. They feel that they're taking only 1 tablet per day. And when you combine this, the cost also comes down. If you see any tablets, if you see 3 drugs, you see the cost, and you see a single FDC, the cost of a single FDC will be much lesser. So we have been using double OAD combinations for type 2 diabetes. All combinations are available. Glimepiride, we had initially glibenclamide metformin, now we use the modern sulfonylureas. So glimepiride metformin, gliptins metformin, acarbose metformin, oglibose metformin. So you can see that metformin is always there. So metformin, why it is always there? It's because it is considered the number one drug for type 2 diabetes management, especially for obese type 2 diabetes. So all the other drugs were added on to metformin, glitazone, metformin, dapagliflozin, metformin. Now we also have triple OADs in the diabetes management. Initially we had glimepiride metformin with pioglitazone. In between, pioglitazone had some controversy and people replaced it with oglibose. So glimepiride metformin with oglibose. Then glimepiride itself was replaced. Gliptin, SGLT inhibitor and metformins were the last group of triple combination therapy, and more combinations are now coming. So in this context, I introduced this novel triple drug combination, glimepiride, metformin, sitagliptin. Glimepiride is insulin secretagogue, metformin is insulin sensitizer, and gliptin acts on the incretin system. In addition to insulin secretagogue action, it can also block the glucagon, which is an additional effect. So glimepiride metformin is a good combination. That's why we've been using it for a long time. It's got a complementary mechanism of action. Modern sulfonylurea like glimepiride improves the beta cell function, and metformin has insulin sensitizing action. Both the drugs reduce the hepatic glucose output. So it's a win-win combination. That's why it stood the test of time. So for many years, initially we were using glibenclamide metformin. Now you have glimepiride metformin. So what is sitagliptin? Already it's a group of DPP-4 inhibitor. Dr. Periyandavar sir has shown how it acts. So we know that when we eat food, the intestines secrete this peptides called the GLP-1, which stimulates the insulin secretion, suppresses the glucagon action. The problem with GLP-1 is it's got a very short half-life. It gets very quickly degraded by this enzyme DPP-4. So you cannot use GLP-1 directly for the patients because quickly it will be degraded. So by blocking this DPP-4 enzyme, we enhance the action of the GLP-1, enhances the insulin secretion, suppresses the glucagon secretion. So the rationale of the triple drug combination, glimepiride, metformin, and sitagliptin, is complementary mechanism of action, good glycemic improvement, well tolerated. We know that sitagliptin almost has got a placebo-like side effect profile. And overall in clinical trials, it showed that most of our patients can achieve the target HbA1c goal of 7%. So what is the trial evidence for this combination? So this study was sitagliptin added on to metformin. It's a dual drug combination where sitagliptin can give additional 0.7% when patients are not controlled on metformin monotherapy. Addition of sitagliptin, we know that this has got modest glycemic efficacy. It can give 0.7% HbA1c reduction. So this is another slide on sitagliptin, metformin. Initial combination, straight away you give two drugs. Sitagliptin can give 0.8%. Metformin even 2000 milligram up to, it can give 1.3. But you combine sitagliptin with metformin, you get additional HbA1c reduction up to 2%. So that's why most often this combination is recommended. So this is, in patients not controlled on metformin, you're adding sitagliptin and glimepiride, you get almost similar glycemic efficacy. So both the drugs are good when added on to metformin. So coming to this combination, patients on failing on glimepiride metformin, what happens if you add DPP-4 inhibitor? Here you can see that this triple drug combination, sitagliptin, glimepiride, metformin, shown the black color circle, versus placebo added on to glimepiride, metformin, you can get 8.5 to nearly 7.3%, 7.5%. So 0.8% additional HbA1c reduction. So when patient is failing on glimepiride, metformin, addition of sitagliptin definitely helps in reduction of the HbA1c. So this is sitagliptin plus glimepiride and sitagliptin, glimepiride, metformin. The dotted line, we can see the triple drug combination is more effective than the double drug combination. So 3 drugs, more glycemic efficacy. There's another study where sitagliptin was added on to metformin plus sulfonylurea combination therapy, and they could reach from 7.6%, it could give the patient less than 7% reduction for more than a year. So durability is there. So the authors concluded that addition of sitagliptin is an effective and well-tolerated option in patients with type 2 diabetes who are not controlled on sulfonylurea metformin combination. This is another trial, combination of sulfonylurea metformin adding sitagliptin with type 2 diabetes and inadequate glucose control. So here again they found that it can give up to 0.7% HbA1c reduction. And the fasting glucose reduction in these patients was up to 20 milligram per deciliter. So that is why the guidelines already Dr. Periyandavar sir has shown detail. We have complication-centric approach and glycemic control approach. So at a HbA1c of more than 7.5% itself, you are looking straight away at starting 2 drugs, and more than 8.5%, we can start triple drug therapy. So to conclude, triple OAD combination, the novel agents which I showed, glimepiride, metformin and sitagliptin, is adding sitagliptin to combination of glimepiride, metformin results in a numerically greater improvement in HbA1c than double OAD combination. So this is a good combination, sulfonylurea, metformin and DPP-4 inhibitor, targets multiple sites of action, insulin secretion, glucagon action, insulin sensitizer. So you are covering almost many pathophysiological defects of the ominous outcome. Thank you.
Thank you very much, Dr. Vijay Bhaskar Reddy, for that wonderful presentation on aggressive control with novel triple therapy. You could join me. Dr. Periyandavar, you could also join. And the third talk is by Dr. N.K. Narayanan, and he is going to talk on EMPA-SITA combination, benefits beyond glycemic control. Dr. N.K. Narayanan is consultant in endocrinology, diabetes and metabolism, Apollo Hospital, Creams Road, adjunct professor in the Tamil Nadu, Dr. MGR Medical University. Dr. N.K. Narayanan.
Good afternoon, all the delegates. Thank you for the kind invite. So I'm going to pick up from where my first speaker left regarding the CRM syndrome, the cardiorenal metabolic syndrome. Both my previous speakers have given a very strong base, especially the first speaker given about the physiology of the management of type 2 diabetes, the pharmacokinetics of the different agents, the novel therapies, and my second speaker alluded to the utility of combining 2-3 molecules together so that we can address multiple pathophysiological defects simultaneously. So on that note, what is the role of modern OADs in cardiorenal protection in type 2 diabetes? That's my talk. I don't have to dwell upon this. The diabetes in India is increasing. Obviously, one of the key role for the physicians today is to prevent the deaths which is happening due to the NCDs. And the Asian Indian phenotype is different. We all know that we tend to develop diabetes at a much younger age compared to the Caucasians, and the complications also occur much earlier. We wouldn't go into the reasons why it is. It can be a separate talk on its own because of the thrifty gene phenotype. So the cardiorenal metabolic syndrome, the risk reduction, how do we do this? What is CRM? The first speaker alluded to that in type 2 diabetes, the major killers are cardiovascular diseases and your renal diseases. And it's not insignificant. If you look at the morbidity and mortality because of type 2 diabetes, about 1/3 of the people with type 2 diabetes develop CVD, cardiovascular disease. When I say cardiovascular disease, it is not just obstructive coronary artery disease, but it also includes people who have got heart failure. And about 1/3 of the Indian people also develop some degree of CKD. Excuse me. Also they develop CKD. So 1 out of 10 Indian people with type 2 diabetes have rapid EGFR decline. So we all know that, So we all know that in type 2 diabetes, the typical progress of a patient with renal failure is that it's a gradual progression. There is a sub-proportion of people who develop as rapid, sudden decline EGFR. And that is also not insignificant because ESKD is very high in this particular group of population. And the combination of this, the obstructive coronary artery disease, your heart failure, your CKD, all these lead to premature CV death in type 2 diabetes, and it increases by about 3 to 4 times. Now, it's not that every patient with this syndrome comes with symptoms. About 68% of type 2 diabetes may have a subclinical heart failure, which is detectable maybe by a resting echocardiography, where the earliest sign is obviously a EA reversal or EE dash reversal, which tends to happen. At this stage, the patient does not have any symptoms of heart failure clinically. Now, not just the echo, now we realize that even this is late, because the biochemical markers, especially your NT-proBNP, and these biomarkers tend to start going up even before when you start seeing changes on the echocardiography. So even before the echocardiography, the biochemical marker starts going up. All these are signs that the person is developing a subclinical heart failure. By the time they develop a clinical heart failure with symptoms, probably that is too late. What about CKD? Again, this is not insignificant. Depending on how we grade, classify CKD and what we take into account to classify them as CKD, whether it is only EGFR or whether this is also including your proteinuria and microalbuminuria, we now know that the earlier sign is microalbuminuria, and the different gradations of microalbuminuria to macroalbuminuria to proteinuria indicates a significant progression in a patient CKD pathway. So again, as the proteinuria increases, people get into CKD stage 1, 2, 3, and it progresses. So our role as physicians and clinicians is to prevent this progression. And how do we do this? Early glycemic control cannot be reiterated. I think both the speakers have emphasized that. Organ protection targeted therapy. So in SIS, we used agents which can control the glycemia. Now we choose agents which can also control your complications. Sustainable. The therapies that you use should be sustainable, and it should be affordable in the long run, meaning they should have durability and affordability. So the early glycemic control, I think Dr. Vijay Bhaskar also touched upon. There is ample evidence from UKPDS, DCCT, all the studies have indicated earlier you control it, better to prevent the long-term complications. And how early? I mean, obviously you can prevent it very early with the modern agents as we see now. The empagliflozin rapidly clears a glucometabolic toxicity. We know that people, when they get type 2 diabetes, when they get diagnosed with very high glucose level, the high glucose level in itself will have an inhibitory effect on the pancreatic insulin secretion. This inhibitory effect on the pancreatic insulin secretion can be eliminated very quickly with agents like empagliflozin. We can see the data as early as by day 14, your insulin resistance starts coming down. The beta cell function starts improving. This is all based on the mechanistic aspects of the drug that is being used. It's just not that. The modern metrics that we use, not just the fasting postprandial HbA1c, we want the glucose levels to be under control all the time, 24/7. With the availability of CGMS and things, now we are able to do studies with the CGMS, with these agents, and we can see the TIR, which is the time in range. That is how many hours in a day a patient spends the glycemia within the target range of 70 to 180, which is the TIR. We can see from baseline to day 1 to day 28, there is a rapid improvement in the green coat, which is the time in range, the time which the patient spends within the target time period. So it's the rapidity with which you can improve the insulin resistance, improve the beta cell dysfunction, decrease the glucotoxicity on the pancreas, and therefore, obviously, logically, it's to say that it will also translate to benefits, the organ protection. This is one of the studies my first speaker, Dr. Periandavars, has showed that both in overall study population as well as in the Asian subgroup population that we saw, there is a remarkable improvement in the CV death in patients with ASCVD, that obstructive coronary artery disease. And this tends to happen very, very early on. We can see that the curve starts dissociating as early as 6 weeks in time duration. We can't expect anything better. And if you look at the composite endpoint, CV death or hospitalization of heart failure, again, this shows a significant benefit where empagliflozin showed that there is a reduction of CV death and heart failure outcomes as early as at the end of 27 days. Now, this is the EMPAREG outcome trial, which was looking at the composite endpoint, which is a CV outcome and death in patients with type 2 diabetes at high risk for CV events. They are already at a high risk of CV events. What happens when they get started on this molecule? There is about a 38% relative risk reduction of CV death, reduction in heart failure, and combined, both put together, there is a 30%, approximately 1/3 relative risk reduction of all the parameters that is being studied, including the composite endpoints. Emperor preserved trial, this was done in people with heart failure with preserved ejection fraction, what we call as the, we got the two categories now, with preserved ejection fraction and with reduced ejection fraction. And even in this group of population with preserved ejection fraction, it showed that there is a 22% reduction in the CV death and the hospitalization of heart failure. Interestingly, this was also studied in people with type 2 diabetes. We all know now that cardiologists prefer this agent whenever a patient with type 2 diabetes has got even subtle symptoms of heart failure, because it's almost like a diuretic. It's better than a diuretic nowadays because it gives multiple other benefits. So obviously, one of the prescriptions that we need to see when a cardiologist is prescribed, and you are also going to prescribe a medicine for type 2 diabetes, whether they are on SGLT2 inhibitors. So this was studied in people without type 2 diabetes. Even there it reduced the risk of CV death and hospitalization by about 20%, which is very significant. And EMPA CKD trial showed that there is a reduction of various parameters of nephropathy. The incident nephropathy decreased by about 39%. Worsening of a pre-existing nephropathy decreased by about 50%, 56%. Initiation of renal replacement therapy got delayed by in about 50%, and progression from micro to macroalbuminemia also got delayed by 38%. The trial also looked at the composite endpoints, put everything together. EMPA elderly study, obviously the question arises whether this is safe enough for the elderly. Obviously you need to be a bit more careful when you're choosing the elderly. The mechanism of action, as I said, is like a diuretic. So the incidence of slightly more prevalence of the orthostatic hypotension, electrolyte imbalance is definitely slightly more compared to the younger individuals. Nevertheless, the study looked at whether this can be used in population who are elderly. The N is equal to only 129. So it's a smaller number, but it's more like a pilot study in the elderly to show that it does work. The concerns would be whether they will be having a reduced muscle mass. The study went on only for 52 weeks. So these are the caveats of this study, but nevertheless it works in this group of population also. And how about when it is used as a monotherapy? It provides a tolerable and efficacious strategy to reduce HbA1c. The pleiotropic benefits, reduction in blood pressure and body weight also. The last bit, when it's a combined therapy along with your SGLT2 and a DPP4 inhibitor, it has got many potential advantages, which includes it simultaneously targets multiple pathophysiological defects. It addresses multiple goals and individual priorities. So as we can see, it's just not the glycemic control, the added benefits of offering a CV protection, offering a CKD protection. When you address these both things together, obviously improve the mortality. I think we touched upon this, that the combination of these molecules, the SGLT2 inhibitor, DPP4 and metformin 3 together will address all the 8 known ominous octet that we know for the pathophysiology of type 2 diabetes. Additional advantages discussed already: less pill burden, less risk of genital fungal infections. We know that SGLT2 inhibitors can cause mycotic genital infections, which can be reduced by providing appropriate advice, adequate water intake, genital hygiene, starting on the appropriate person. So all these will matter how you reduce it. The one more strategy is to adding it with another agents like linagliptin or sitagliptin. So studies have also shown that this combination works very well. This is a study which looked at the combination of Sita and EMPA, which gave a very good glycemic control at the end of 24 months without severe hypoglycemia. The incidence of hypoglycemia is much lesser compared to a combination, let's say, of a sulfonylurea with another agent because of the mechanism of action. And because of that, there is an improvement in the metabolic function, decrease in microalbuminuria also. So just to reiterate that the studies also replicated what we anticipated. Therefore, the FDC of EMPA and Sita resulted in both fasting, postprandial, plasma glucose, HbA1c, body weight, systolic blood pressure from the study baseline up until 16th week. So to conclude, the CRM syndrome is a big problem. This is something which we need to address right from the beginning when the person gets diagnosed with type 2 diabetes. It needs proactive recognition by biomarkers. As I said, we don't wait for the clinical signs of heart failure. You look through other things like your NT-pro, BNP, etc. Importance also needs to be given the practicality and the ease of use, the pill burden, whether the FDC will be better in a given person, especially if they're elderly, when they've got to take multiple medications, and which combination of medication you are going to use. The modern agents which can offer not only glycemic reduction, but also address the cardiometabolic risk and the renal risk. Thank you.
Thank you very much. I have time for one burning question, but if there's no burning question, we don't have time for anything. Up to what age, up to what level will you do tight control?
So it's very individual dependent. Young person sitting in front of you with less risk of hypoglycemia, you can go as low as 6.5 or less. Elderly who does not have any complications at the time of diagnosis, let's say a 70-year-old, definitely not for tight control. You would be happy with the HbA1c of even 8.
More than the age, I think we should start looking at something called frailty. If somebody is a young 70, you could go down. On the other hand, it's a frail 70. You really want to be very careful of not causing harm. With that, I thank all the three speakers. Thank you. Please give them a big hand.
Thank you, guys.
And we move on to the next session. Thank you very much. Nane chair, Nane speaker. Okay. Bhavamum Nane, no? Good evening, everyone. Thank you for such a fantastic response for debate. Just the presence of so many of you gives us the happiness and the motivation to continue to do it every year, making it as relevant to you as possible. And importantly, this is a very big endorsement for us, and we hope we meet up to your expectations. I understand that the food was nice, and unfortunately, such kind of food also makes you want to sleep. So, but without any further ado, I have me and Dr. Vijay Kumar will talk about some things. This is a sponsored symposia, and we have conflicts of interest. Now, I don't believe in this diabetes capital of the world. We have a large number of diabetics. Irrespective of how many number of diabetics we have, every patient is ours. Each of them are unique. Each of them required a tailored solution. Each of them require therapy that is individualized to their problem. That will, and I will tell you my current approach being, if they have diabetes, can I reverse this? Can I help prevent further complications? Can I reduce the progression of existing complications? And can I make sure that my therapies have very little side effects that when I give them? And I think this is a broad approach that has served many of us well. And therefore, while we talk about newer and newer formulations, we need to start looking at how older existing formulations help become tailored into the newer way of doing things. To understand that, what are the unmet needs? And especially when we go on to insulin, what are the whole thing? One is, should I start on basal insulin? Good question. The second question is, okay, basal insulin is great if you want to follow the Monnier formula. The Monnier formula says the higher the fasting glucose, that patients have high fasting glucoses at the higher end, and at the lower end. And can you turn that off, please? And greater postprandial control at the higher end. The light off, my cataract doesn't allow me to do it. The second part is the same data when applied to Asians and especially Indians is completely different. People showed that even at the lower end or at the higher end, there is a significant postprandial contribution. Okay? So we are a little different. Then the third is to say, okay, then should Indians get started on basal insulin? Should I add a prandial insulin? When I start with a basal plus prandial insulin, something very interesting happens. Excuse me. A basal plus prandial insulin, something interesting happens. Now, if you see all these studies that every company talks about, you will find a lower incidence of hypoglycemia and a lower incidence of nocturnal hypoglycemia. Why is that? It's because of only one thing, that the action of the basal insulin has become longer. If your basal insulin acts at 24 hours or longer, the incidence of hypoglycemia comes down. This is called the dog wagging the tail or the tail wagging the dog. The tail wagging the dog is what is happening. That's why you get hypoglycemia. Okay? The moment you add a prandial component, immediately risk of hypoglycemia goes up, the risk of weight gain goes up. And this becomes a challenge in most of our patients. How can you sort it out? One, use a longer acting basal insulin and then maybe combine it with a single day prandial. This is one way. But along the way, we have discovered that when you add a GLP-1 RA to insulin, and I'm even going back 20 years to UNIAC's first study, you realize certain things happen. One, that the amount of insulin required comes down from 3 to 2, 2 to 1. Many people even don't require insulin. The second that happens is that so the dose comes down, the number of injections come down. Third, the weight gain is not as much. You actually you may lose weight, but certainly no weight gain. And more importantly, the presence of a GLP-1 RA further reduces the risk of hypoglycemia. So when you bring this, and lastly, while basal insulin is a fantastic way to bring down fasting glucose, short-acting GLP-1 RAs seem to be ideal in bringing down prandial insulin. Now let's put this together. You want a basal insulin, and instead of your prandial insulin, substitute it with a GLP-1 RA. What do you get? Glargine plus lixisenatide. Why lixisenatide? Simply because lixisenatide is short-acting. You don't have to give it once a week. It can mix in the same vial with the cartridge. Therefore, what happens? You have prandial control and you have a basal control. And you don't have the added weight loss, weight gain. You don't have the added hypoglycemia. In fact, that's really all my talk. But now let me put the data together quickly for you. So, this is all what I talked about. This is an interesting slide. It tells you that it takes care of this thing. But I just want you to come here. What does the GLP-1 RA do? Remember, it works through. Its predominant action is still in the pancreas. We talk about all the off-target effects, but it works in the pancreas. It's very, very important in glucose-stimulated insulin secretion. And it works in a particular receptor called EPAC. Normally, the sulfonylurea receptor in which all the sulfonylureas work are time dependent. That is why after 10 years, your sulfonylureas start coming down. But the GLP-1 RAs, because they work through an alternate pathway, they continue to work especially in people with longer duration of diabetes. In fact, it's very, very well shown that the incretins work better when there is beta cell dysfunction. The second is that there are two effects that at very low dose, at a dose when the glucose comes down, they push up the glucagon. And in addition, there is decreased gastric emptying. So clearly, if you go to any hypomelanotic society's recommendations, you will find that they all advocate that insulin and GLP-1 RAs are made for each other. The third part is to tell you, okay, I've given you a rationale. Does this work? I said that basal insulin should be there. That brings your fasting down. The prandial, and you must use a longer acting basal insulin that doesn't cause hyperglycemia. I also said if you add a prandial GLP-1 RA, that reduces GLP-1, the postprandial glucose, it will bring your glucose down, get your A1C down, not increase your weight, and reduce hypoglycemia. So let's see if there's an evidence for this. This is the gold standard in a fixed dose combination today is IDEG-ASP, which all of you know as Rhizodeg. Why? It's a co-formulation, long-acting degludec, along with a short-acting aspart. Today, and remember, I don't know how many of you remember that IDEG-ASP twice a day has data that shows it's superior to basal bolus insulin. And that's really, so we're really comparing to this with a gold standard of care at this point of time. So I won't get into all of this data. You can read it up, but what I'm going to show you is that the primary endpoint of this comparison, which was showed, that is 24-week to see if there's a non-inferiority. And these are the people who were involved, they were evenly matched, they had About half of them had metformin or SGLT2 inhibitors. And see what you see at the end of it. That there was a greater LS reduction in A1C when a GLP-1 RA worked along with a basal insulin. This is the first part. It had non-inferiority, and importantly, because generally we talk about 0.2%, there was superiority also. So clearly, in this particular study, and I'm sure Novo will come up with another study which says something else, but in this particular study, this is what it says. The second thing it showed is that there was a modest weight reduction with lixisenatide. And as I said, anytime you add a prandial insulin, there is weight gain. There's about 1.2 kilograms weight gain with prandial insulin, offset by lixisenatide, which means there is no weight gain over a period of time. Interesting? Then, the third thing I said when I started is that the amount of insulin required comes down. Exactly. 34 in this group, 28 in this group. Lastly, I said hypoglycemia is lower. Any hypoglycemia is lower. Event rate is lower. Level 1 and level 2 hypoglycemia lower. So the simple answer is I gave you 4 propositions, and each of these seem to be met in the clinical evidence provided in the study. The second thing is, okay, what about, fine, but what about if you do once a day Iglar Lixi and twice a day basal insulin with aspart, right? This is by asp, twice a day, which is your regular formula, and then compared to Iglar Lixi. Again, 26 weeks randomized, 180 patients from India out of 887. What happened? Week 26, numerical improvement in the, remember this is once a day Iglar Lixi versus twice a day insulin. My modest improvement, right? Weight somewhat lower, insulin dose significantly reduced. That is the beauty of GLP-1 RA. In patients on insulin, adding a GLP-1 RA makes a huge difference to them. That is the big story in this. Lower risk of hypoglycemia at any time, at any day, and therefore this is interesting. So here is the big picture, right? This is the pen, this is how you, and I helped the first study that looked at titration of basal insulin. Use the same titration. Start on 12 to 14 units. I tell the patient every 2 days check the sugar or 3 days check the sugar. More than fasting is more than 120, go up by 2 units. Slowly up titrate. Less than 90, bring it down by 2 units. Plus 2, minus 2. We used to have all these complex algorithms. Some of us got together and said, don't do this. Plus 2, minus 2. Plus 2, minus 2. So to sort of put this all together. One, the correct, if you require insulin or a patient already on insulin, the correct way to optimize insulin in today's day and age is instead of considering prandial insulin, to consider a GLP-1 RA. And GLP-1 RA and insulins are made for each other because they, one, work synergistically together, bring down A1C better than basal insulin plus prandial insulin, work better than basal insulin, mixed insulin twice a day, reduce hypoglycemia, do not cause weight gain, simple and easy to titrate, and I'm going to tell you the most important part of this, cost the same as any other basal insulin in market. So that is the beauty of fixed dose combination. Everybody will talk about, our basal bolus. I believe in one thing, never sacrifice the achievable in the altar of the ideal. And this is a simple, achievable, and today, Sanofi or anybody may not like it, I don't start anyone on basal insulin. My first insulin is a combination of basal plus GLP-1 RA. So this is all that I do. It can be used in the elderly, it can be used in renal impairment, do not use it in pregnancy, can be safely used in hepatic impairment. With this, I will stop. Thank you so much, and may I also invite Dr. G. Vijay Kumar. Thank you so much. Namaste.
Good afternoon. Thank you, Krishna, for giving this opportunity. It's quite obvious that your involvement and elegance is seen in that. But he was also telling about the diet. I think all of you appreciated the diet. The lunch was excellent. The problem is it is a very difficult session. Immediately after the lunch, you feel like sleeping. You are welcome to sleep, no problem, but only thing is on one condition, don't snore. You know why you should not snore? So that you not disturb the next person who is trying to sleep. Anyway, this is a sponsored program by Sanofi, and you must have heard about the lot of inputs from or the evidences from the so far basal insulin. This talk I am going to give some extra evidences which probably you could have not seen earlier. That's why it is called as the evidence continuum for the second generation basal insulin. Now, all of us know that the only basal insulin that we had was an NPH insulin, which is an intermediate acting insulin. The problem with that is, which you can see that it's got a peak. So whenever there is a peak, whenever we give an insulin, there will be variability. The perfection at which the absorption, the variable absorption on intraday and interday will be there. And whenever there is a peak, there is a possibility of increased incidence of hypoglycemia. So then came two insulins, better insulins than NPH, two basal insulins, that in the form of NPH, the Detimer, and as well as Glargine 100 IU. If you see that Detimer is slightly better than NPH, but not as good as Glargine 100. And 100, we have been using it for almost 20 years plus or so, with good results as well, with a minimal hypoglycemia. Now, whenever you are trying to have a basal insulin, the best basal insulin is that there is longer duration, longest duration, beyond 24 hours. That is number one. Number two is that it should not have any peaking. Whenever there is no peak, the hypoglycemic episodes also will come down. Any insulin will give hypoglycemia, that's a different issue. But if there is no peaking, there will be least hypoglycemia. That is number two. Number three is that when you have a stable absorption, whenever you got a long duration of the pharmacokinetics of any insulin, what happens is that means there is a predictability of absorption. Same way it will absorb every day, interday, throughout the time that they are taking. So you can see that compared to that, then came the second generation insulins, which absolutely fit into the best basal insulin that we can think about. You could see there that the third one, you can see that compared to the U100 of Glargine, we can see that there is a small peaking, not as bad as Detimer or as bad as NPH, but you can see that the Degludec and as well as Glargine 300 IU, you can see there's a flatness. So once you have a flatness, when you have a prolonged duration with no peaking and the flat profile that you have, they'll be having less variability, and so that you got predictability of action. That's most important, predictability of action. So that means, suppose you give 10 units, it brings down the 80 or 90. The same thing happened for the next 1 week also. No, same type. That's what the variability is not there. No, because why? Because the best basal insulin which has got no peak and it's beyond 24 hours, we can see that we can have especially there are the U300 is the one. U300 is nothing but it's more concentrated insulin, the same Glargine, which is safer especially during titration. I'll come back to you why I'm talking about so much about safer during titration. Whenever there is least hypoglycemia, there is one thing what is called as defensive snacking, and so that when the variability is less dosage will also be there, so that your weight gain also will come down. So flexible dosing, so sometimes we have to be able to have at least 2 to 3 hours this way, that way, where the window period will be having about 5 to 6 hours. And it's a stable, prolonged more than 24 hours, so that there is less glycemic variability and sustained effective glycemic control over the time and low hypoglycemic episodes. Now, what is different from U100 and U300 about glargine is that nothing but the same amount of insulin is given and is a small amount. Okay? So whenever we give a glargine into the subcutaneous plane, it gets deposited there. It precipitates there. So what happens is that when you have a lesser, the circumference of the droplet that is being there into the subcutaneous tissue, the surface area, what we call surface area, the more the surface area, faster will be the absorption. Small surface area, longer the absorption. This small amount will be taking into circulation, and it takes for a long time. Very, very simple phenomena, which is brilliant, I felt actually. Compared to U100, U300, the same insulin, just because increasing the concentration, the pharmacokinetics have changed, because the surface area is changed. Now, there are so many studies which have come, RCTs, real world data, and I'm going to tell you some of them. One of the best things is that one of the bold initiatives that Sanofi is taken is that comparing two best insulins. Okay? That is, one is Degludec, one is U300 of glargine. So now, what is this is actually age criteria is more than 18 years, duration of more than 1 year, HbA1c should be more than 7.5, less than 10.5. Either they can use GLP receptor analog or not, and oral drugs, one or more oral drugs are also there, and all are insulin naive patients. Now, we can see that about 466 patients on U300 and 463 patients on 100 units of Degludec. Now, the prescribing information is that whenever you are using U300, start with 0.2 units per kg body weight, whereas Degludec you start with 10 units, and then titrate. First 3 months is going to be active titration, and the next 3 months, the total duration is 6 months, and then you can see that late maintenance titration. There is not much of a titration will be there. Now, what is it we get? Because the first 3 months is more than sufficient for you to fix the dose. And you do fasting blood glucose once in a week, and then you titrate the dose and you can get the results. So what has happened in these two studies? They have the same HbA fasting blood glucose reduction, and then same HbA1c reduction is there. And then if you can see that the difference is that when you have same HbA1c reduction equally for both, the difference here is that the hypoglycemic episodes, it is less than 70 or less than 54 or nocturnal hypoglycemia. You can see that everything is reduced to a great extent when you are using U300, especially in the titration period. The reason why we need to have is that during the titration period, if you can reduce hypoglycemic episodes, the confidence in the patient will be very, very high. So discontinuation of the prescription will not be there, and continuation of the prescription, adherence to the prescription also will be very good, and they'll be very happy, and the quality of life also will improve over the time. Now, this is safeguard study. This is the aim of the study is basically because they wanted to look into Indian specific data, Indian specific safety data. You can see that this is about 220 patients they have taken. This is actually a multi-center phase 4 interventional single-arm open label 6-month study. It's an open label. Everyone knows what they are taking. Now, they've taken about 220 patients. Similarly, whatever we have seen in BRIGHT study, the same inclusion criteria. Endpoints are hypoglycemic events and other events as well, adverse events. Now, you can see that the glycemic efficacy, HbA1c came down from 8.8 to 7.7 in 6 months, and then the fasting blood glucose comes down, and the percentage of the people who gained fasting blood glucose between 80 to 100, that's what we usually aim, is that from 3 months to 38 to 50%. And then the number of people who have achieved HbA1c less than 7 has also improved. The most important thing is that the adverse events are minimal when you are using U300, even in our patients. There is no change in body weight. And then the most important thing is that when you do a scoring system for the quality of life, there is an improvement in quality of life significantly. So the safeguard study, which is done in the subpopulation of India, has clearly said that the very good satisfaction, 99% of the 220 patients who completed the study, and then this is an insulin-naive Indian patients with low hypoglycemic episodes with a very good glycemic control. Now, if you look into the special population, special population or what we call as vulnerable population, that is older people, where increasing age, insulin secretion deficiencies and increases in insulin resistance contribute an increased, because you up titrate the dose of insulin, we can also get increased risk of hypoglycemia in adults. And of course, we know that fasting state, especially Ramadan, there is a possibility of increased hypoglycemia. And kidney impairment, you could see that there is increased risk of hypoglycemia because the decreased neoglucogenesis and also the pharmacokinetics will also alter in renal failure, pharmacokinetics. Now, this is one study which is called as addition. This is basically the initial studies are done on U300, and it's a post hoc study where they have taken the addition 2 and 3 studies together. And then you can see that in the older people, just look into those people who are more than 65 compared to less than 65, comparing U100 to 300. What you could see that the similar HbA1c reduction, whether you use it 100 or U300, in all groups less than 65, more than 65, U100 and 300, same HbA1c reduction. But the difference you can see is that the amount of hypoglycemia, 30% reduction in nocturnal hypoglycemia with U300 compared to U100, again because of predictability of action. Again, coming back to the BRIDE study, where the subgroup of aged people, when they looked into that, just look at the left side of the slide, more than 65, more than 70, you could see that the same HbA1c reduction compared to degludec. But thing is that what you could see is that the amount of both more than 65 and more than 70 years old, you could see that when the more older the age, you could see that compared to U300 and U100, you could see that there is no increased hypoglycemic episodes. In fact, in the more than 70 years old, there is a slight reduction in hypoglycemic episodes in elderly population. Now, looking into Ramadan, the Orient study, that is pre-Ramadan, during Ramadan and post-Ramadan, 1 month, what they have done is that at least they would have taken 28 days for during Ramadan period. And then they have taken into consideration what they could see is that compared to South Asians are comparable to the global, where you can see that in India there are 73 patients were there out of 493 patients in this Orient study. What they could see is that there is a reduction in HbA1c, there is a reduction in fasting blood glucose, but thing is that the compliance has been very much improved because the GLA 300 as basal insulin for people with type 2 diabetes who intend to fast during Ramadan has been safer and very assuring to take, so that you don't need to change the insulin during Ramadan. Looking into the renal impairment people, what you could see that compared to the less than 60 and more than 60, comparing 100 and 300 in addition trial, and then renal function regarding, you can see that HbA1c reduction in all groups, all types of EGFR, the same HbA1c reduction. But when you use 300, look into these people, both less than 60 and more than 60, there is a considerable reduction in nocturnal hypoglycemia in 300 compared to U100. So the safety is assured. Again, coming back to BRIDE study, where renal insufficiency studied between degludec and as well as the thing, there is a reduction in HbA1c of 0.7. But the thing is that the hypoglycemic episodes are also quite low, even in age groups compared to degludec. This is a real world data, really European data, that is pooled data analysis, about 1,712 patients. And whatever the EGFR may be, you could see that the incidence of hypoglycemia is overall low across the subgroups. XSTAR study is again one study which has been again the 4,620 patients, insulin naive, as well as already exposed to insulin, and various EGFR groups you can take that the result was similar to HbA1c levels below or 8 Hb without any increase in hypoglycemic episodes. And as far as the pregnancy is concerned, this is not actually, this is nothing but no difference between U100 and U300. So there are about cases collected from countries from 49 countries, and about 546 pregnant women who are exposed to U300. U100 has been used for many people, but there is no difference in fetal morbidity or any other problems during pregnancy by going for U300 compared to U100. It's as good as that. And this is a special pen in a green in color, and then there will be no cartridge holder. The advantage of this is that you cannot exchange the cartridges. You have to change the cartridge holder, as it comes as a unit of cartridge holder with cartridge, so that interchange of insulin should not be there. There's a safety, and then it's a softer use. The amount of force that you need to use to push the insulin is very low, so that any amount of effort that has been taken is reduced by the patient, the compliance will improve. The quality of life will improve. So friends, in summary, I could say that it's a longest duration of action, safe, least hypoglycemia, same efficiency, even in vulnerable population, is the most important thing that you need to think about. Now you have an option of U300 insulin, take it. Thank you very much for your patient hearing.
Thank you, sir. Thank you. We have 5 minutes for questions. Is there any or comments? Dr. Vijay Kumar, so we have two things we talked about. One is we talked about a combination of insulin and exenatide, and then we talked about U300 basal. What would you choose when somebody requires insulin?
Okay, I'm always a basal man actually. I always start because the basal insulin. The reason is that the way I practice is that basal insulin. Basal insulin, people usually think that it reduces the fasting blood glucose effectively, but it may not be effective in postprandial blood glucose. That's what people think. But it is mistaken, because it reduces the hepatic glucose output. That is contributed to fasting blood glucose. It does not mean that there is no hepatic glucose output in prandial state. 40% of the postprandial blood glucose is contributed by the hepatic glucose output. That comes down nicely. So there is this sub class of people. So postprandial also will come down. But we are Indian diet that takes as a postprandial spikes are greater. And then this is one issue where you got finding it difficult to control the postprandial blood sugar only with basal insulin. Number 2 is that when the basal insulin, after some time, we need to go for intensification, where you need to go for 2 doses of premixed insulin, like what you have explained Novamix 30 insulin twice a day. So in these people, if you have that the lexasenatide with glargine, I think I'm very happy with that. Actually, we can avoid one injection. We can most often manage with instead of 2 injections, we can manage injection. That is, it is not exactly intensification, but changing the strategy of controlling it. So this is a very good way of looking into that.
GLP-1 RA before insulin or insulin before GLP-1 RA?
I think this is a separate set of people actually. We know that if you're more than 27 with comorbidity or more than 30 without comorbidity, we can go for GLP-1 receptor analog. But in most patients who are already on insulin, probably we can think about combination of lexasenatide and other things. Or, as you said, that if somebody is on basal insulin, you don't have more effect, you can also add GLP-1 receptor analog to that. And to start with, both have got an option. That is, both have got an option. Injectable. Either you can use basal insulin or GLP-1 receptor analog, or you can add GLP-1 receptor analog to basal insulin, or you can add basal insulin to GLP-1 receptor analog.
Krishna ji, my thing is, insulinized beta cells, they respond to stimulatory effect mediated by GLP nicely?
Okay, so two parts. I think one is to understand that the greater, it's interesting, you see this in DPP-4 data also. Very interesting data with the DPP-4 inhibitors. They work better in older people. They work better in the presence of renal dysfunction. They work better in East Asians where the beta cell dysfunction is higher. And it looks like that, and tomorrow I'm going to talk about that the muscle saving effects and others of GLP-1RA are better in older people. That there is a difference between older versus younger in GLP-1RA, and we shouldn't look at it. So the diseased beta cell seems to be a place where GLP-1RA actually works much better. So interestingly, while some of your drugs are very good at the earlier part of their life, the GLP-1RAs are good throughout the entire part of the diabetic life cycle. So in an insulinized this thing, there are dramatic effects of GLP-1RA. One is a dramatic reduction in hypoglycemia because suddenly the glucose-stimulated insulin secretion increases. The second is there is a significant reduction in insulin resistance simply because your hepatic fat comes down. Not necessarily because of weight reduction, but because of waste reduction. And the third, I think, is there are hypothalamic effects that, again, I was referring to it this morning about we are looking at GLP-1RA as something else, but I think the predominant effect of GLP-1RA is the vagus. That there is a significant vagal effect that changes the whole thing. I hope that answered the question. With that, can we stop? Okay.
Last question. We'll finish on time, don't worry. You have given one statement stating that this GLP-1 receptor agonist will work better in insulinopenic people, that's what you said. Beta cell, less beta cell people, that's what you told.
First, don't use it in pure type 1. Although, there is some very fascinating data coming out in type 1 itself where, one, you can use it in patients who are gaining weight. Second, that it probably also works along with insulin in type 1. So that data is coming out. And while it may not work in someone who's completely apancreatic, that it may improve the beta cell function in patients with low insulin reserve by exactly the ways that I've talked about. So clearly this, again, I'm talking about some early studies going on, so don't immediately change your practice. We will maybe 2 debates later bring this in as a practice parameter. But for example, if I have a type 1 diabetic who's gaining weight, who's obese, who has evidence of insulin resistance, today I'm not worried about starting a GLP-1RA. In fact, I have a significant number of patients who are type 1 who are also on a GLP-1RA. So I think that question has come out fairly well. With that, please give a big hand to Dr. GVK. And again, Sanofi, thank you for this opportunity. We are on time, Gauri, and we will get to you. One of the reasons that I'm being very insistent today on the time is at 7, please for all of you, at 7:45 today, we have a fantastic lecture by one of the authorities on temple architecture. Her name is Dr. Chitra Madhavan. Please stay back because it's a fab. Every year we try to do one new lecture. Last year, how many of you were there when we did Iranganula by T.S. Krishnan? So every year, at the end of the day, we want you to relax with something very, very nice. And of course, I promise you the dinner will also be great. Please stay back. Thank you so much. So there'll be a slight shift in the halls in the sense that those who are wanting to continue with the drug symposia can move to Hall A, and those who want to attend the master class, that is That will be a 3-hour event or a 3.5-hour event, starting from now all the way up to 7:30. It will be while it is a Lilly event, there is no pharmaceutical conflict of interest in that entire presentation. So you can stay back for the master class, or you can go to that hall. But the MCs will be Lilly, but to let you know that this was designed to be a non-conflict of interest kind of thing. So thank you very much. So this will be, those who are staying here, this is a 4-hour session, and there we will continue with the other things. Thank you so much.
Without this disclosures, everything I have to read to show the disclosure. Yeah. Show this like that. Good afternoon, everyone. My name is Dr. Shrey Bhatia. I am full-time employee of Eli Lilly, and it is my pleasure to welcome you all on this Eli Lilly event, that is Obesity Masterclass. So about Eli Lilly, it's a global pharmaceutical company, and this year we are also marking 150 years of legacy. We have led our molecules over the decades. Like Lilly has developed their molecules with breakthrough therapies, and particularly in the cardiometabolic space. And this is an area where unmet clinical needs are continuing to grow, evolve rapidly. Alongside innovation in therapeutics, Lilly has consistently taken initiatives focused on disease state awareness as well, and scientific education as well. So Obesity Masterclass is one such attempt. What we have to do, so we are also very much honored to have this platform today in debate conference. So no other platform would have been better, because it's one of the most recognized medical educational events. So before we move forward, I would like to read out some disclaimers as well as some housekeeping rules as well. So as I mentioned, like this program is sponsored by Eli Lilly, and all the speakers who will be present here, they will be presenting on behalf of Eli Lilly and the company. We also want to remind you that during this meeting, the topics that will be covered will be exclusively within the scope of indications which is provided in the approved prescribing information in India. And the questions concerning the aspects that are outside the indication of approved prescribing label, that is in India, cannot be addressed or cannot be discussed during the plenary session, but you can have the discussion with the Eli Lilly medical team after the plenary session or your one-on-one interaction with the speakers, but kindly refrain from discussing anything off-label during the meeting. Also, I want to highlight that since this is a Lilly confidential information that we are going to discuss, we request that please do not take any photographs and videos during the entire meeting. Kindly do not take screenshots of the slide decks that are presented here. And please do not post anything on your social media platform related to the Lilly products that are discussed here. By the end of this meeting, at the end of Obesity Masterclass, we are expecting that the participants will be able to understand the pathophysiology of obesity, including its genetic, hormonal, behavior, as well as environmental factors. will also be able to understand and identify the obesity-related comorbidities in the clinical practice. We have a particular session where the real-world hypothetical cases will be discussed with the cross-specialty presence here as well. We'll also be having evidence-based strategies for the management of obesity that includes lifestyle intervention, pharmacotherapy, as well as surgical options will be discussed here. We'll also be employing the effective communication skills, communication techniques for the patient counseling that also involves motivational interviewing. We'll also be critically analyzing the real-world cases studies to improve the decision-making in obesity management. So today's program lead is Dr. Krishna Seshadri, a very well-known figure. He's a senior consultant at Chennai Diabetes and Endocrinology Clinic, Chennai and Apollo Hospitals in Chennai. Dr. Krishna Seshadri is currently not in this venue, so we'll be moving forward with the welcome address. Dr. Shamranga Velu is here. So, sir, is it okay, sir, if I welcome you for setting up the context and giving the welcome address for the audience? Yes, sir. So just a context setting regarding the obesity. So before I welcome Dr. Shamranga Velu on the stage, I would also like to read out the agenda of the meeting. We have renowned faculty members here, the clinical experts who will be walking us through the obesity pathophysiology as well as other aspects related to obesity, and we will also discuss about that how to have the effective communication with the patients as well. The entire agenda, we have one quiz. One will be the pre-CME quiz and other will be the post-CME quiz. These quiz are just to understand the theme of today's meeting. These are not to test your knowledge, but we'll be requesting you to use your mobile devices to take part in this quiz. So let's start with the pre-CME quiz. There is a QR code that is there on your on the screen. I request you to please scan this QR code. So once you scan this QR code, you will be able to land to a page. I hope everyone has been able to log in. If you have been able to log in, can I take a moment? Can you kindly remove the screen for once? Just a second. I'm just setting up one thing. Yeah. Okay, yeah, fine. I hope everyone can see the question number 1 on their mobile devices. Yeah, so I'm just going to read out the question number 1. How does the obesity drive or worsen type 2 diabetes? Click for the correct answers. These are the 5 options in front of you. Obesity, there is a promotion of insulin resistance. It reduces the insulin resistance. There are no limitations on the physical activity. It causes beta cell proliferation and also reduces the blood sugar available for metabolism. Let's move to the question number 2. Obesity affects the risk of cardiovascular events and life expectancy. Considering that people with normal BMI have an 80% chance of reaching the age of 70 years, what is the percentage of people with obesity and BMI between 40 and 50? So these are the 4 options in front of you: 70%, 60%, 50%, and 40%. Let's move to the question number 3. The 5 A's are recommended when communicating with the patient with obesity. Which of the following sentences describe one of these A's? Avoid stigma, adjust goals to the patient needs, ask permission, or advise medication. Now let's move to question number 4. What are the challenges with weight control in people with obesity? These are the 4 options. There is well-defined, simple pathophysiology. There is target expectation of more than or equal to 5%. It is easy to achieve with lifestyle and dietary measures. Now, option number 3, multiple approved therapies with limited adverse events are available. And option number 4, it is difficult to maintain weight loss over a period of time, and the phenomenon of rebound weight gain is there once any therapy is stopped. So, question number 5. A patient with obesity presents to discuss their options for starting an AOM. Which of the following options may be an appropriate way to counsel the patient? These are the 4 options in front of you. The AOMs modulating the hormone systems, which makes people feel hungry, requires adherence and persistence and avoidance of abrupt stopping. AOMs induce acute change in the hormone system that regulates appetite and tapered when stopped when a new set point is reached. AOMs modulate the dopamine or cannabinoid-based reward systems, requires adherence and persistence and avoiding abrupt stopping. And there is alteration of dopamine or cannabinoid-based reward systems and tapered and stopped when the desire to overeat is less. A minimum of 10% body weight loss is maintained for at least 12 months. So this is a simple case study. It is of Mr. XY. He is 58 years old and a supervisor at a renowned outlet with BMI of 36 and body weight of 102 kgs with height of 5 feet 6 inches. There is a medical history of recent diagnosis of prediabetes, hypertension, dyslipidemia, NAFLD and no sleep apnea is there. The patient has lost 5 kgs with intensive diet and exercise but regained within 6 months. With exercise, there is shortness of breath after flight of stairs about 7 to 8 steps, and there is a conscious, the patient is also conscious about his weight. So concerned about developing diabetes and deteriorating health during retirement. So what is the target body weight for this patient? These are the options in front of you. 5% weight loss from baseline in 6 months, 10%, 15%, 20%, or 25%. For the same patient with these treatment targets, what would you do for Mr. XY? Suggest Mr. XY have another stint in reducing body weight with diet and therapy, or we can prescribe pharmacotherapy. Anti-obesity medications are available now, so we can prescribe that to the patient, or we can directly refer to the patient for bariatric surgery in this condition. So now there is another question. What are the goals and benefits of effective obesity management? Options are achieve weight loss early and then stop treatment once target body weight is achieved, and patient will maintain the clinical benefits achieved through weight loss as long as they follow lifestyle interventions. Achieve weight loss, maintain weight loss and prevent regain, followed by clinically meaningful benefits in terms of reducing diabetes risk, improving markers of severe risk, reducing functional impairment and improving quality of life. Achieve early and aggressive weight loss for a year and then stop the therapy and then watch for regain of the body weight, because very few patients show a regain of the body weight anyways. And option 4, refer the patient for bariatric surgery if lifestyle interventions don't achieve target body weight after 3 months. Okay, so which question is there currently? Is this question being shown on your devices? Now it's showing? Okay. Okay, so let's discuss this case study. It's of Miss MN, and the question related to this case study is already there on your devices. I will just read out this case study. 45 years old female, recently told she has pre-diabetes, is worried about implication for her health. Mother has type 2 diabetes with previous MI, kidney failure, retinopathy. On examination, the BMI is of 34 kg per meter square with blood pressure of 144/92, and also there is central fat distribution with waist circumference of 108 centimeters. She is put on lifestyle intervention for a period of 3 months with diet and exercise. So for this patient itself, this was a question that you have already answered. What are the goals and benefits of effective obesity management? So the same question continues. Ms. Enman continues. After 4 months, she returns for a review and she is feeling a little better, and the step counter on her phone shows she is now averaging over 6,000 steps a day. She is disappointed when she steps on the scales and finds that her body weight has lost only by 2 kgs. And HbA1c also remains high with 6.2%, and she is still in pre-diabetic range. I believe because of the interruption in the connection, we are not able to update the questions on your devices. It's a very slow connection, so I really apologize for this. But I hope now this question is appearing on your screen. Can I read this question? It's not there? So I hope like we have understood that what we are going to cover. Unfortunately, because of the connection issues, we couldn't do the entire pre-CME quiz. But like we have the first, I will request Dr. Shimnigo to kindly be present on the stage and kindly introduce our first moderator, Dr. S. Venkatraman, and kindly also set the stage for obesity discussion. Thank you.
Respected moderator and my friend, close friend, Dr. Venkatraman, co-faculty members, senior doctors, my doctor friends, and team members of the LLE. First of all, I feel very much happy, honored, and most privileged to have been invited to give a short notes about the context testing for this particular program. So we know what is obesity. Obesity is a multifactorial disease with various types of phenotypes, clinical presentation, and treatment responses. The prevalence is on the rise, starting from childhood. Next is adolescence, adulthood, middle age, like that. If you look into the quality of life, that is the quality associated life expectancy, everything, dramatically altered with obesity. So obesity should be considered as a disease entity, just like what we manage patient with diabetes, hypertension, dyslipidemia. We follow the patients meticulously every 3 months, every 6 months, and we put the patient, we see the response, glycemic control, lipid lowering drugs, then modification of antihypertensive medications. Equally important, obesity should be given such priority. We have to make diagnosis much early. So the purpose of conducting this master class, second generation, sponsored by LLE, it's a very good initiative to create awareness, to improve our knowledge, to get our knowledge updated on the definition. Next is the management, including the complications of obesity and everything. I am sure all are aware of the fact that obesity is an independent risk factor for atherosclerotic cardiovascular disease, heart failure, CKD, and so many complications. Added to that, it is often associated with multiple comorbidities, including dyslipidemia, dysglycemia, hypertension, which are independent risk factors for atherosclerotic cardiovascular disease. So, obesity per se is associated with metabolic problem. Per se, it leads to mechanical problem like osteoarthritis, varicose vein, plantar fasciitis, and so on, obstructive sleep apnea. And it also results in long-term complications, including cancer incidents. So, we should thank Eli Lilly for for making this a master class. And in fact, I have been associated with them for conducting similar programs in most of the metros as well as our district headquarters in Tamil Nadu. So with these few words of introduction, let me take the pleasure of introducing my close friend, Dr. S. Venkatraman, Senior Consultant Diabetologist, Apollo Hospital and Surya Hospital, Chennai, to take over further proceedings. Over to you, Venki.
So good afternoon. Thanks, Eli Lilly, for this wonderful opportunity to cascade a science which is extremely relevant in the contemporary medical practice. I think the clinician's interest in science is always enhanced if there is availability of meaningful intervention, impactful intervention. The classical example was how we as clinicians, be endocrinologists, diabetologists, physicians, whatever category we are, I think our knowledge has enhanced with respect to the renal medicine after the introduction of the SGLT2 inhibitors. We have learned a lot. Of course, after the molecules have been introduced in this class, there have been a lot of mechanistic studies to support the various possible mechanisms, and all of us are updated. So when we talk about the SGLT2 inhibitors, so possibly the nephrologist might be able to give a point or two above what we have already updated ourselves, thanks to our evincing interest in the disease which is amenable for intervention in an impactful manner. Likewise, as Velu just now pointed out, obesity has always been regarded as a risk factor in the context of various diseases. Now, we have realized that instead of viewing obesity as yet another risk factor like your dyslipidemia or hypertension or dysglycemia, possibly treating it upstream, recognizing and categorizing it and then interfering with the various options as dictated by the guidelines has been recognized as a very, very viable option which is being practiced. Now, Eli Lilly, I must acknowledge, has recognized this aspect of the science, and as Krishna just now pointed out, this particular obesity masterclass, and I'm happy that I've been associated with a couple of, probably this is the third program that I'm doing, and thank you so much for asking me to moderate at least a couple of sessions in this wonderful forum. When we talk about obesity, I think, yes, there is a good paper which has talked about the evolution of the clinician's understanding of obesity, probably in the early part of the last century. But now we realize that previously, we always used to recognize obesity in the population, be it whether it's associated with dysglycemia or hypertension, but we used to adopt a tentative approach, if I can use the word. We'll say that cut down your intake of food, do some exercise, because beyond that, we couldn't offer much as a meaningful intervention. Now we know that we do have options, and these options have a lot of choices, backed up by huge, huge data, so that it becomes a compelling, what shall we say, an educational or learning exercise for the clinicians to deep dive into the nuances of obesity, which is very, very interesting, and then that's what we are going to do in the next 3 hours or so. We'll start the first topic about the obesity and its pattern of prevalence in our country. Now, when you talk about obesity, is it relevant in the context of the Indian population? We talk about so much of communicable diseases, the non-availability of food for probably all the population. There are national guidelines for enriching the nutrition, etc., etc. In this context, are we justified in dedicating ourselves to a 3-hour session on obesity? The answer is yes. Because previously, I just remember, I think when Velu and I took up to this specialty as a branch of medicine, close to about more than 4 decades back, we believed that probably 2/3 of the West Caucasian population are obese, whereas in the context of India, it's only 1/3. Now we realize, as we're going to see some of the compelling statistics, we need to revise our data. And a classical example that I always give is, early morning, I think many of us are used to going to our hospital or clinic early in the morning. You just go early in the morning or for a walk when you go. You have a lot of small vans carrying vegetables, and a lot of these women are seated either in the front of the vehicle or at the back of the vehicle. I can tell you that BMI should be somewhere around 30 to 35. I mean, we presume that they are in the lower middle class or middle class category. Maybe they'll be rich as well. So, looking at the prices of the vegetables. Anyway, that was in a lighter vein. What I am trying to say is, we cannot brush off obesity as a sole, shall we say, exclusive domain of a few practicing clinicians across the country. I think the physician, the practitioners have to be sensitized, and that is the purpose of this program. And then to do the first talk about the redefining obesity care in India, the guidelines, diagnosis and management, I invite Dr. Anand Kumar Annamalai. Anand, it's always a pleasure to do a program with you. His CV is here, and I can assure you the next 12 to 15 minutes, it is going to be science mixed with excellent language, the way he is known to present the topic. Anand, redefining obesity care in India.
Good evening, everyone, and thank you very much, Venkatraman sir, for your kind introduction. It's always a very humbling experience talking in front of my teachers. Dr. Venkatraman was my teacher during my immediate postgraduate years in diabetes. So value this and very, very thankful. So I'm the opening batsman. So I'm often called as an opening batsman in lots of units. So I'm expected to play in the power play and actually, just hit the nail to the context. So I've got another session in another 10, 15 minutes next door. So I will probably just punctuate the most essential aspects which need to be introduced for this topic. So redefining obesity care in India, and actually Dr. Venkatraman put it very well as to why it's being redefined. So we all know this obesity is a chronic, progressive, relapsing, but treatable disease. And this is characterized by abnormal or excessive body fat. It's not just about weight, and that impairs health, and that actually relapses, and that's important. We need to understand that it is not very simplistic of just energy balance, and this is being driven by the brain, gut, and the adipose signaling, and all of these are interlinked. You have a lot of genetic and epigenetic factors linking all of this. So if you were to start with the brain basically, regulates the appetite, the satiety. The hormones which actually regulate it come from the gut and the adipocytes, and all of these are linked. For example, if you look at the gut axis, the GLP-1s and the GLP-GIPs, which actually have come into vogue only because of this understanding. So this alters the signals in obesity. This is altered signaling from the GI tract going to the brain, which basically, alters basically the hormones. You have, appetite suppressant hormones and appetite stimulatory hormones. But the stimulatory hormone, the prime stimulatory hormone is ghrelin, which basically, increases the appetite. And then you have a decrease in the satiety hormones, which actually, all pushes this person into an obesogenic environment. And this is the reason why when people lose weight, they actually tend to regain. And this is the understanding of this, which is important. And then you have the adipocytes, which are basically dysfunctional. So there is dysbiosis of the fat. And this results in further impaired signaling, which goes to the brain. So you can see this is basically a vicious cycle. Now, I'd like to pause here, and this is a very, very important aspect which we'll need to understand. So obesity is actually a gut-driven metabolic disease with dysbiosis at the level of the gut. What we mean by that is there's alteration in the gut microbiome. Now, why is this important in a disease like obesity? Because if you were to prevent this from actually relapsing, this is an important concept to understand. So if you look at these four aspects, you have an inflammatory pathway, you basically have a barrier dysfunction at the level of the gut, you have short-chain fatty acids being altered, and you have a dysbiotic composition of the gut which is altered. So the gut microbiome actually has, alterations in obesity. What this means, you have two particular bacterial sets, the bacteroids and the faeculobacteria, which are very, very, prominent in a healthy individual who's not obese. Now, why is this important? This particular, organism would actually metabolize fiber. It metabolizes fiber and converts it to butyrate, which actually is a short-chain fatty acid. And this short-chain fatty acid is protective because it basically, alters the cell junctions in the gut. Now, you have intercellular junctions. If you remember the physiology is, you have claudin, which basically would interconnect the cells. It's like the cement. And that actually prevents the cells from breaking. Now, when this is dysfunctional and you don't have enough short-chain fatty acids being produced, this is broken. That means the bacteria escapes into the bloodstream. It basically has endotoxins and lipopolysaccharides. This actually, through the bloodstream, goes to all tissues. It alters the signaling in the immune regulatory systems. You have alteration at the immune systems causing tissue-level inflammation, alteration in the FIAF, which is a signal which would alter the adipocyte disposition. And this would increase the lipoprotein lipase activity, meaning the adipocyte gets loaded with fat. Now, this is a very complex way of interplaying it. To put it in simple terms, now, if you want the gut to function well, you need increased short-chain fatty acids. Now, how could you do it? You could do it by increasing fiber. You could do it by increasing vegetables. You could do it by increasing fruits. You could do it by eliminating the UPFs, the ultra-processed food. So before we talk about any therapeutics, it is important to understand this. And this is why when people start losing weight, and if they're not serious with their diet and lifestyle, you would find that the gut microbiome is still persistently altered. And if you don't alter that, with good, healthy, basic diet and lifestyle, it would persist, it would be chronic, and it would relapse. And that's the reason why I'm spending a lot of time on this particular slide. So this inflammation, basically, at the tissue level, activates TMAO. Now, TMAO is a surrogate marker for cardiovascular disease, subclinical atherosclerosis, and atherosclerotic progression. So you can see this cycle here. So simple. Keep your gut microbiome, keep your bacteroids, keep to the healthy lifestyle, and do whatever on top of it, you would be successful. So for a successful obesity, reduction, this is important. Moving on, we know that obesity basically is a growing health challenge across the globe and also particularly in India. Now, the worrying aspect is, in 2030, the portrayal is a BMI, basically a very high BMI with obesity levels would reach up to half the population, which is not an over-exaggeration. If you look at India, there's been a sequential increase throughout the population. As Sir mentioned, it's not just about urban, it's rural, semi-rural, and it's across basically the country. And this is particularly worrying too. These were the National Family Health Surveys, which were done in 2015 and 2016, and you can see across the states in India, this is a global concern. Now, we think we're different, but truly are we different? I think this is the reason why we need to define obesity in our population if we really think that we are doing the right thing. So we call this, the thin fat phenotype. We talk about, us having, lower muscle masses. We talk about us having sarcopenic obesity. We talk about us having ectopic fat at the level of the liver, the pancreas, which dysregulates the beta cells. We also talk about the different genetic and epigenetic factors. Now, all of this are important because basically, this means that we have more visceral fat for a lower BMI. And this is something which we'll need to understand. This compounded with the pandemic of the diabesogenic environment or the obesogenic environment compounds factors and alters genes and its expressions. So the evolving Indian diet is increasingly more UPF related. And these ultra-processed food, as I mentioned, goes back to the gut microbiome and actually is going to accelerate it. So whatever drugs you're going to throw on them, if this is not going to get altered, this is going to relapse and this is going to be chronic. So from the Indian subset, the Endocrine Society of India has redefined this. So this is not always about BMI. So you could have any of this. Now, if you look at this here, if you look at the body fat percentage, if a lady has greater than 30% of body fat distribution, she is obese. How would you measure it? The gold standard would be a DEXA scan, looking at fat composition. A lesser equivalent will be a bioimpedance, a body composition analysis. If a male has 25% or more fat distribution, he is classified as obese. The waist circumference, if it is greater than 90 in a male or greater than 80 in a female, that is classified as obese. And if you look at basically the waist-hip ratio for abdominal obesity, from an Indian perspective, it's 0.9 or high for a male and 0.8 or high for a woman. It's 0.85 for the WHO criteria. For the Indian criteria, it's 0.8. And you look at the BMI, we're not looking at BMI of 27 or greater. We are looking at BMI between 18 to 23 as being normal. So remember, this is a very important aspect here again. Someone may have a BMI of, like, say, 19 and still be obese if their percentage body fat is high. Someone may be obese if basically their waist circumference or the waist circumference is high. That means we're looking at more of ectopic fat and, abnormal fat at, places where it should not be expressed. So this is where the obesity guidance and actually the definitions are being, increasingly, progressing. So if you were to classify someone as obese, basically BMI of 23 or greater is classified as obese from an Indian standpoint. And this is what is important to understand. So grade 1 or overweight would be 23 to 24.9, grade 2 between 25 to 27.5, grade 3 between 27.6 to 32.4, and 32.5 or greater being, grade 4. If you look at the Western statistics, this is entirely different. So this is a very, very important aspect which we will need to understand. And if you look at the prevalence in general, this is, pretty prevalent in both male and female. Now, women basically have a different predisposition because, physiologically there are lots of alterations, especially, during pregnancy. They basically go through the perimenopause and menopause, alterations in the estrogen. And these actually, tend to help them in terms of protection from insulin resistance. Now, how would that basically relate to the distribution of fat in women? Now, as women basically progress towards menopause, and this is important, it is not like post-menopause. As they progress towards menopause, they have a decline of estrogen. So it's not the absolute estrogen deficiency which is important. So if you were to address obesity because of the change of hormones for an individual, especially a lady, you have to start early at the perimenopause. The estrogen would actually regulate how the fat is distributed inside the viscera. So the intravisceral fat accumulation is prevented by estrogen. And that is why women have more a gluteofemoral, adiposity. So the buttocks and the thigh distribution of fat is driven by the estrogen. Around perimenopause and postmenopause, when they start losing estrogen, they move towards a more central distribution, which becomes a problematic issue. And this is the reason why the cardiac risk factor increases as women move from perimenopause, menopause, and postmenopause. So this is a vital understanding which people have to realize. The other important aspect is the subcutaneous adipose tissue. Now, the subcutaneous adipose tissue, again, for a woman, it is better off at the gluteofemoral area. You do not want the subcutaneous adipose tissue to increase more centrally. The ectopic fat, fat at the wrong places, fat in the liver, fat in the pancreas, fat in the renal cortex, fat in the epicardium and the heart, all of this would alter how those organs respond in terms of, not just obesity, but in terms of tissue level inflammation, cardiovascular disease, and increased mortality. So this is basically, the entire picture of what's happening. And this is exactly what I was talking about in terms of, why these things have to be, looked into in people, especially as they age and as they progress. Again, with age, people lose muscle. And when they lose muscle, they add on fat in that muscle. That sarcopenic obesity becomes an even greater havoc. And that's the highest risk. So this so-called normal BMI of 19 is not truly normal. In fact, data from our country shows that this metabolic obesity, wherein people have a BMI of like 18 and even 19, they remain obese because of the fat distribution centrally, because of the ectopic fat, and also because of the total body percentage fat. Now, these are the highest risk people. And data now says that this is as high as 40%. So this is the Indian statistics. So if you're just looking at BMI, you missed the boat. So moving on towards therapeutics. So as I mentioned, it's important to understand this is the basics of obesity. So diet and lifestyle would remain the be-all and end-all of any therapy with relates to weight. Whatever pharmacotherapy we're going to give, whatever surgical aspects we're going to give, if that is not altered, remember the slide I was talking to you about gut microbiota. So for example, you have a lot of individuals who basically lose weight with medications. Yes, you may see certain inflammatory markers coming down, but recently data have shown you stop the medications, they go back again, and this yo-yoing or this fluctuation of weight is the biggest risk factor for cardiovascular disease. So if you're not going to tell them the basics, that you need to alter your gut microbiota, you need to make sure you need to reduce the tissue level inflammation, and you need to make sure that this inflammatory effect in the tissues have to go away, then we've missed the boat. So this is a very, very important aspect. But having said that, any amount of weight loss is going to be beneficial. And we're not talking about 0 to 5. In medical college years, we were taught that 5% body weight loss is very significant. We're looking at double-digit weight loss. So double-digit weight loss starting from 10% to 20%. Because we're not just looking at, reduce the weight for, making people look good, not aesthetically. We're looking at, preventing mortality, preventing cardiovascular disease and its progression. So you can see the varied types of percentage of weight loss and the benefits. And that is why still, we sometimes, weight-centric in terms of numbers. So I would probably pause there, and I hope that I've given you a decent introduction towards this topic. Thank you very much for the opportunity.
That was a very precise opening batsman's show in a T20. Now, I think Anand highlighted the relevant epidemiological data in the Indian context. And the anthropometric metrics which are used routinely to categorize and then interfere. I think two aspects of his presentation I want you to remember because it's very, very useful. I mean, it's very relevant in the context of what we are going to discuss subsequently. Number one, obesity is a chronic relapsing disease. I think that's a point it should be etched in our minds. Now, go back. Whether it is pharmacological or non-pharmacological intervention, once that gets diluted, either by the patient not complying with your instructions or abandoning the prescription, there is a rebound weight gain. Why? It is not the fault of the molecule, it's the nature of the disease. It's a chronic relapsing disease. So, the way it remits, you expect it to relapse as well. And classically, we have experienced that right from the time we have started with the lifestyle modification, of course, in the recent past with a lot of molecules. That's number one. And number two, obesity, overweight is not just the excess fatty tissue or the BMI or the body weight. It is the interplay of the three tissues, brain, gut, and the adipose tissue. So, it's a triangular insult which results in accumulation of fat, and that is that needs to be addressed. And of course, it was not at all a pessimistic presentation. At the end of the day, if you quantumize, as I told you earlier, initially you used to have a tentative attempt at weight reduction. Now we know that you should have a targeted weight reduction. And you saw the targets that Anand beautifully alluded to before he concluded. So I'm sure we are going to have a couple of more presentations and then we'll have the questions before we move on to the rapid fire presentation. Now in clinical practice, I'm sure senior clinicians are there, you will agree that when somebody comes with a diagnosis, with a parameter, say the fasting is 200, PP is 250, HbA1c 8.5, you say that he has got diabetes, quite often he is open to whatever intervention that you suggest. When he has hypertension, he has. When you talk about his body weight, for somebody who has got a body weight of 5 feet and 6 inches, he weighs 85 kgs, you say that, no, this has been going on for 15, 20 years, why do you want to interfere? I'm sure this sort of an attitude is there among the patients because when a disease entity like diabetes or dyslipidemia or hypertension is identified, the patients more often, they are willing to follow your advice. Some patients maybe they'll just say that I'll try to have some non-pharmaceutical intervention. Whatever it is, they accept the diagnosis as a abnormal or a disease entity. When it comes to obesity, the very fact that he has been living with this body weight, he or she, for such a long time, 1.5, 2 decades, don't touch it. Something like this message. So, in this scenario, it's always a cautious approach to be and a persistent approach to be adopted while confronting a patient. So, the pre-intervention phase, starting the conversation and initial assessment will be done by none other than Dr. Shanmuga Velu. And Velu, as you all know, he has been part of any scientific activity with diabetes or other aspects of metabolic medicine. Very, very knowledgeable, extremely knowledgeable. In fact, whenever I do a program, I'll have about 5 or 6 points. Then he'll come and say, Venki, last week there was in this particular journal, this particular point. That is the way he updates himself. Not only updating himself, the willingness to share the knowledge with others is something unique in Velu. Now it's up to Velu to talk to us about the pre-intervention phase, starting the conversation initially.
Back to Square A, respected chairperson, senior doctors, my doctor friends. I'm happy to make a presentation on pre-intervention phase, starting the conversation and initial assessment. Of course, this particular program is sponsored by Lilly. I have been contracted by Lilly for this particular talk. So, one slide. Back. Okay, my disclosures. So my disclosures, I have been contracted by Lilly for this particular talk, and I know Dr. Venkatraman right from the day when I joined my first MBBS in Kilpatrick Medical College. He's the second student who ragged me. First, Dr. Gopinath, he's a logician. Second, doctor. He used to keep mustache simulating Brijesh Patel, cricket player from Karnataka in those days. We used to call him Brijesh Patel. We both did MD together, and we joined the government service same day. And of course, I submitted my resignation much earlier. He submitted resignation after he became the professor of medicine. So we have been coordinating with all our academic forums. We share many forums. In fact, we also participated in many debates. Right. Now let us come to the scientific session. Right. Dr. Anand Kumar Ramnan, like he has made a very beautiful presentation regarding the, I think some, regarding the anthropometric parameters to make a diagnosis of obesity. He has beautifully made a presentation. Please remember those points, which are very important as far as the clinical picture is, clinical scenario is concerned. So obesity per se is a multifactorial disease. It has biologic underpinnings, and it is related to complex interaction between genetic and environmental factors. Weight reduction or weight loss reduces the risk for and the outcomes of most of the diabetes-related complications. Very important thing, we recognize obesity as a disease, but due importance is not given to this particular management. So even though it is considered as a disease, it is not treated as just like diabetes or hypertension or dyslipidemia. So it should be considered as a disease. And very important thing is, while managing, before you tell you are overweight, you are obese, we need to certain terms, we need to avoid certain adverbs which may have negative impact on the patient's clinical aspect. So let us talk with this particular slide. How clinicians raise weight concerns to their patients. This particular slide shows the communication practices and the consequences. A particular study was conducted in UK, that is Gender Identity Clinic. This particular study explored how the clinicians initiate discussion about overweight in a patient population. In fact, this particular clinician used 3 common, that is communication practices. That is, announcing people are overweight. That generate delays and minimal responses from patients. So we need to assess whether the patient accepts the word overweight or obesity, whether there is any denial, and whether they accept wholeheartedly, whether they show any negative answer to this particular. That is very important. Next is asking about overweight feel, that is judgmental and trigger resistance. So first one, least aligning practice. Second one, comparatively aligning. Comparatively aligning means they can accept, but they may show some resistance occasionally. And third important thing is deducing through BMI calculation. So check the patient's body weight, take the waist circumference, take the BMI, and take other parameters. You just tell them you are overweight and obesity. That is the most aligning practice. And we can tell this particular individual has obesity, and we can direct the patient for the objective instrument, namely the treatment plan. Next very important thing is seeking permission to discuss weight, improve communication. You can tell them that patients who are overweight, patients who are obese, if not taken treatment properly at the appropriate time, they may likely to develop metabolic problems, they may likely to develop mechanical problem. In the long run, patient can develop certain complications. As if you are telling to your third person, rather than pointing out, you will develop diabetes, you will develop dyslipidemia, you will develop hypertension, and so on. So seeking permission to discuss weight improves communications. So clinicians who use collaborative, sensitive, and objective approaches foster stronger alignment and more productive conversations about weight. Next is preferred weight-related terms. Again, yet another article published in a peer-reviewed journal. They look into the online survey, patient with obesity and doctors who are managing patients who are overweight and obesity. So this particular study was conducted. And very important thing is, the way healthcare professional communicate to the patient with living with obesity, they are supposed to use certain terms, that is preferred weight related terms. You can tell weight, overweight, or based on the BMI calculation, rather than telling I am more comfortable addressing my weight as unhealthy weight over super obese, chubby, extra large. So this type of adverbs we need to avoid, because this will create negative impact. So choosing respectful, non-stigmatizing language is critical. Word choice directly shapes emotional reactions and trust in the patient-clinician relationship. So the preferred terminology by the healthcare professional, we used only, that is weight problem, BMI, overweight, excess weight, weight control. These are the preferred term what the patient expects from the healthcare professionals. And the patients, they preferred weight, overweight, rather than fat or extra large or the chubby. Next is people with obesity face barriers to accessing obesity care. So failure to recognize obesity as a chronic disease delays its diagnosis and treatment. 70% of people living with obesity, exercise, experience stigma. Person first language is important. So healthcare professionals not trained in obesity care. People with obesity remain underdiagnosed and undertreated. So stigma, misrecognition, and lack of training hinder access to evidence-based obesity care. So obesity, that in turn imposes, or that is often associated with psychological or psychosocial burden. In turn, that reflects the global health care, health expenditure cost, expenditure cost. Next is regarding the stigma. That is very important. And this particular stigma carries a lot of impact on this particular patient. So while using words, we should be very careful. That may result in, and in fact, we need to have a good rapport with the patient. The patient-doctor relation should be very nice, as far as we need to move with the patient as if he belongs to our family member, and we need to talk to them in a polite language so that he can understand the real problems and he will also understand the real situations. The 5 A's of weight management in adults: assist, ask, assess, agree, and advise. Regarding the management of obesity, we have a lot of mnemonics: 4 M's, 3 M's, 5 A's, 3 P's, like that. So assist, that is assistant for appropriate resorts and providers, that is arrange follow-up appointments. Next is ask for permission to discuss weight and explore readiness. Assess obesity-related risk and potential root causes of weight gain. Agree on health outcomes and behavioral goals. Advise on health risk and treatment options. So this approach improves patient motivation, enhances clinician-patient communication, and support sustainable behavior change. So the way the healthcare professional communicate with the patients living with obesity, that is very much important. It may have an impact on the relationship between the doctor as well as the patient, and motivation also. Right. Questions to the audience: what percentage of people with obesity believe that Weight loss is their own responsibility and is a matter of mindset and lifestyle. So 15%, 16 to 36%, 30%, 31 to 50%, and more than 50%. So I want our participants to answer. Very good. So less than 50% of the patient, they agreed they have obesity, and that this individual body weight can have an impact on future health. That is number 2. And less than 50% of the patient with obesity, they accept it is their moral responsibility to bring down body weight. No doubt at all. Both healthcare professionals as well as patients living with obesity, they agreed it's a chronic disease and that treatment is lifelong and that treatment should be initiated much early. So most people with obesity see weight loss as a matter of personal responsibility. Again, it is an action epoch study, and this is again online survey. And this online survey was conducted among patients with obesity as well as healthcare professionals, and several doctors participated in this clinical trial and clinical survey, including the patient with obesity. So it was a cross-sectional, non-interventional descriptive study, online survey of healthcare professionals and patients with obesity, and study location, so multinational, multicentric study. And if you look into the views of the healthcare professionals, they believe they will actively contribute to their patients' weight loss effort. And 30% believe my patient's weight loss is their own responsibility. With patient with obesity, believe my weight loss is completely my responsibility, nearly 63%. 42% of the patient, they believe my healthcare professional has a responsibility to contribute to successful weight loss. Right. So weight loss is self-attributed, leaving clinical support underutilized. So question to the audience. What percentage of healthcare professionals believe that people with obesity are motivated in losing weight? Less than 15, 16 to 30, 31 to 50, and more than 50%. Less than 50. Right. So we never spend much time on weight reduction. We simply give a prescription on glucose lowering drugs, lipid lowering drugs, hypertension, blood BP lowering drugs. We spend little time as far as weight reduction is concerned. Pardon? Yes. நான் சின்ன குழந்தையிலேருந்தே வெயிட்டாக தான் சார் இருக்கேன், நான் சப்பியாக தான் இருப்பேன். எல்லாருமே என்னை ஸ்கூலில் படிக்கிறப்பயே குண்டு பாப்பான்னு தான் சொல்லுவாங்க. That is a common terminology. Yes. But the thing is, healthcare professional, we should identify much earlier. We should create awareness much earlier, motivate them, properly educate them, and initiate treatment much earlier. Most healthcare professionals believe that patients with obesity are motivated to lose weight. So healthcare professionals and patients with obesity participated in this particular study. 64%. My patients are motivated to lose weight, and 53% of the patients with obesity, I am motivated to lose weight. So healthcare professionals overestimate patient with obesity motivation to lose weight. Right. Delay in patient with obesity and healthcare professionals discussing weight management. So this is very important. Delay in discussing weight issues, as pointed out by Dr. Selvapandian. So we see the patient right from the age of 18 years. We started treating the patient with obesity around 30 years. There is a gap of nearly 12 years. So in this particular study, there was a median duration of 6 years between the time the individual with obesity began struggling with overweight or obesity and the time they discussed that particular weight has to be reduced. So there was a delay of median duration of nearly 6 years. So 54% of patients with obesity discussed their weight with their healthcare professional in the past 5 years. 36% diagnosed with obesity. 21% offered a follow-up appointment after being diagnosed. So that was a time their discussion about weight management, and healthcare professional has given next appointment. So delay in discussing weight issues, that is with healthcare professional minus 6 years. Obesity related complications may develop during this time. So obesity care is delayed at every step, increasing the risk of complications, right? So what is weight bias? This is very important. Some of the patients, they have bias internalized bias that results in a particular fear that they are overweight, and this amount of fear can result in anxiety, depression, stress, and this may impact the quality of life also. So weight bias, negative attitudes and judgments about people of different body weights. So associated with unhealthy eating and exercise avoidance. So there are certain individuals with internal bias, and very important thing is, once you tell you are overweight and you need to give importance to your body weight in terms of that is caloric restriction, they will start overeating. Next is linked to anxiety, stress, depression, low self-esteem and body image issues. It harms physical and mental health. Unconscious weight bias hijacks our clinical judgment. Recognize it and unlock better outcomes for patients with obesity and metabolic disease. So that is weight-related bias. Challenge to obesity care, social stigma and discrimination. So obesity stigma, that is prejudice, stereotype and discrimination. So if you come across patients who are obese in the school, at work, in the clinics, they are treated in a different way. Next is stigmatizing beliefs and stigmatizing acts. It is fueled by inaccurate ideas about obesity causes. So common stereotypes include lazy, non-compliant, gluttonous, lack of willpower, bad hygiene. Impact on day-to-day life that includes less respect, eye rolling, touching frequently, less opportunities workplace and altered quality of life. So stigma we perpetuate is more harmful than the obesity we treat. It's time to break the cycle. So we need to give importance to the bias, number one. Number two, stigmatization, very important. We are not supposed to discriminate them. We need to provide them, we need to make them to sit comfortably in a different chair, right? Weight bias in healthcare. Healthcare professionals may ascribe stereotypes to people with obesity. They label patients with weight issues as non-compliant. Shorter consultations than with the healthy weight patients. So hereafter, please make a point, whenever we come across overweight or obese individuals, spend little more time compared to patients who are normal weight. So healthcare environment may be biased, contribute to stigmatization. Gowns, chairs, scales, exam tables can't accommodate people with obesity. Nearly 53% of men and 54% of women reported hearing inappropriate comment from the healthcare professionals. Very important. More than 50% of the patient, they get certain adverbs from the healthcare professionals. So healthcare providers, they are not immune. Our biases create barriers that patients can't overcome. So impact of weight bias on medical decisions. So systematic review, they have analyzed so many studies. In descriptive analysis also, the objective was to assess the bias in clinical decision making, and obesity bias harms medical decisions and reduces quality of care. This is very important. Less visual contact, that is lower physician adherence. Less diabetes treatment intensification. Fewer pelvic exams for women with obesity. Fewer cancer screening exams in patients with obesity. So while managing patients who are obese,
we need to approach them in a different way. We need to give them sufficient time. We need to do certain tests which are specific for the management of obesity and obesity-related mechanical as well as metabolic problems. Bias doesn't change beliefs, it changes prescription. Right. So mitigating weight bias in the healthcare environment. So if you look into the exam room, waiting hall, and the scale we use for measurement and for healthcare professionals. In the exam room, step stool with handle, that is very important. Large sized gowns, larger BP cup, wide examination tables, sturdy armless chairs. Right. Next is in the waiting room, open arm chairs, firm sofas, space between chairs, bathroom with crab boards, and handled urine specimen collector. Scale that measures more than 350 pounds. For individuals with disabilities, location offering privacy and confidentiality. For healthcare professionals, weigh privately without judgment. Ask permission before weighing. Focus on health and fitness goals. So, weight bias mitigation, start with a scale and end with equality. So, we are not supposed to discriminate. Right. So, with this, I complete my presentation. We'll take up the question now or? Right, okay.
Thank you, Velu. I think Dr. Shanmugha Velu cautioned us about the terminology that you should be careful when encountering a patient who is overweight and obesity. And then the various aspects have been nicely touched upon. And one thing that highlighted, which is not disfamiliar or unfamiliar to these audiences, whenever we talk about the diabetes, we always talk about the clinical inertia. That is, by the time that the molecules on board are not adequate enough, and then we have to be more aggressive in our approach to achieve the glycemic target, it goes on, you lose about 6 to 7 years of poor glycemic control. Likewise, I think you nicely highlighted the data wherein close to about 6 years of time is being lost when you have a patient who is motivated to be started on the appropriate intervention for the weight. Yesterday I had a patient in the outpatient. One of my diabetic patients brought her daughter. She has had the second dose of the vaccine for cervical cancer. Extremely knowledgeable. Most of the girls are now being offered and they accept it. But she was about 5'5", 5'6" and weighing 92 kgs. I asked, I appreciate yourself having a vaccine for protecting your cervical cancer, but should you not be bothered about your weight? Yes, sir, I'll do something. I'll cut down my junk food. In other words, what shall we say, the inclination that she had for preventing a cancer by taking such a costly vaccine, it costs about 10,000, 15,000, close to 10,000 rupees, 3 shots. It's not an issue, but when it comes to obesity, it's not being viewed as, it's part of my personality. And there are some people who do not want to lose weight as well. We have seen it in the diabetic population. He says, do me something, bring down your blood sugar level, but don't give medicine till. There are a category of patients. Anyway, I think you nicely alluded to the fact that how the intervention phase, one has to categorize, one has to be very careful with the language. And the last thing that you told about the clinic wherein you have, in fact, Krishna, if you remember, we did one same master class. Somebody came with a suggestion, if you have got an obesity specialized clinic wherein you have a lot of these aspects have to be incorporated, in the washroom, the closet should be to the floor. It should be grounded to the floor, not the wheel-mounted closet, because nowadays when we construct houses, it looks very fancy, it looks very attractive when you have a wall-mounted closet. I think in the context of obesity, these are all very, very subtle points, but I think make a lot of sense. So I think we'll have the questions along with Anand and Velu after our hero makes his presentation. So you have a patient, say about 5 feet 8 inches, 92 kgs, whatever it is. He or she is on about 1,800 calories. You advise a diet. Let's ask that he or she meticulously follows it. You have produced a deficit of 500, 600 calories, so it should work out about 1,800 calories, which is about 2 kilograms of fat at the end of 1 month. Do you witness this? No. Number one. Number two, whenever we advise a diet for our patients, be obese or in the diabetic context, most of them are motivated to cut down on their carbs, etc. Yesterday I went to a marriage, I didn't have the chapati, I didn't have biryani, I just had salad, filled up my stomach, but I had that halwa and ice cream. And likewise, if you look at the IT segment, these girls and boys who are obese, they don't have much of the regular diet, but in the evening, they stay in the office, pizza, samosas, etc. If you calculate the calories that they have, this is the pleasure of eating, not the appetite related eating. So there are aspects which are there wherein we need to have some sort of a meaningful understanding, because we discussed in Anand's presentation, obesity is a brain, gut, adipose tissue disorder. What does this brain do? I think to listen to this, we don't have any other person less than the caliber of Krishna. Krishna is a colleague of mine and a great friend of mine and most sought after clinician. In fact, I was asked to introduce you with a bunch of details. I said, Krishna is known to everybody in this audience, but I'll introduce him in my own way. Probably the most knowledgeable endocrinologist with access to so much of research in the context of metabolic diseases and the basic sciences, and the way he understands and disseminates the basic science. The classical example was a few of us, we witnessed his presentation yesterday, and always I'm a fan of Dr. Krishna's erudition as well as the way he connects, the effort that he puts to understand the nuances of some of the subtle aspects of the medicine, which I think some of us may feel, oh, it's too boring or too technical, it's too complicated. Let me allow Krishna to read and then do it for me. I think that's what he's going to do in the next 15 minutes, understanding how we eat, move and behave.
Okay, two quick requests. Shrey, sit down. Second request, turn that light off. Thank you. Just to let you know that I am 58, and what happens is maybe I'm getting a cataract, but that blinds me. Okay, so you name a farmer and I slept with them all, so that is my disclosure. Yesterday we did have a deep dive on reward systems, so what I'm trying to do is summarize this whole thing. For several reasons is my favorite sloka from the Gita, Ashamshayam Mahabaho Manam Dhurnitsa, meaning definitely the mind is capable of being shaken. Ashamshayam, without doubt, Mahabaho, Krishna says, right? I'll tell you the second part of it, which is I have to have a story and then a conclusion, right? I'll come to the second part of it. So, in many ways, we think about, whenever we think about food, we think about it as a need. We think about it as a need, and therefore, if it is a need, then we will know where to stop. Right? If we think of food as a need, we will know where to stop. But for the last 100 years, we have looked at food as a reward. And because we know whenever it's a reward, we are not happy, it doesn't become enough for us. We don't know where it becomes, where it has to stop. I'm going to extend this and tell you, from a reward, it becomes an addiction. Why? This becomes a positive reinforcement cycle. This is the key to understanding this entire business. I have spent enough time. I recognize almost everyone in this room, and I've seen many of you in my talks over the years, and I can tell you, all of you understand that the homeostatic mechanism, which is what is happening in the hypothalamus, a balance between the orexins and the anorexins, gives you the thing. In the past, we thought leptin, GLP-1, all the others go into that area and they tell you what to eat. What we did not understand in all these years is that the other inputs that come into it, that drive this. In the past, we used to call these as hedonic inputs, but when we mean hedonic, what we really mean is that there are three parts. I'll use a Sanskrit analogies, chitta, mana, and then, of course, viveka we'll talk about later. That is the mana, indriya, mana, and chitta. Indriya is your senses. What you see. I keep talking about the kind of food we are providing. When I say tonight we have baklava, we have quesadillas. I'm giving you the menu, right? It makes you okay. Maybe I should stay back and eat. Correct? So that's the input. The second is the way it is processed. The way it is processed is that, okay, there are two parts of the processing. One is liking. The second is a motivation to go and eat. Liking is mediated by opioids. The motivation to eat, to get that food and eat. If I say, okay, I have baklava. Can I have less talking, please? When I say baklava, many of you will like it. But that does not mean you will make that extra effort to stay back tonight and eat it. But when you do that, that's motivation. Liking is mediated by opioids. Motivation is mediated by dopamine. I'm going to tell you that this is true of food. This is true of money, power, sex, drugs, and alcohol. The reward system is the same. Now, depending on how your reward system is programmed, Dr. Venkatraman resists the halwa. I eat the halwa. And there are people who give me halwa also. So, the reason that a large amount of obesity occurs is because in the last 100 years, people have learned to make us eat by promoting food as a reward. Many of my patients and your patients actually eat because they see pictures of food on Instagram or on YouTube, or they become foodies because they are always talking about food. So we are not able to overcome the word in Sanskrit, indriya nigraha, meaning to be able to tell your senses, I know you're beautiful, but you're not for me. You can apply it in any context, but that is the truth. When you're able to say no, you don't get into trouble. When you're not able to say no, you end up with a divorce. Right? So, that is all it is. One, there are peripheral signals. Second, it's our central thing. To this, you add certain other things that are happening. One, for example, in the gut, the kind of food that you eat, and I'll talk about this tomorrow when I talk about longevity and NASH. we think we are one organism, the body thinks that the bacteria think that we are a super mammalian organism. They have been given the task of protecting us. When you eat refined food, when you eat processed food, which I'll come to, it actually alters the gut bacteria. And these bacteria work through three mechanisms. They work through LPS, they work through NUSH hormones, and they work through epigenetic alterations by HDAC and the others, and they actually modify your responses. So, for example, in the nucleus accumbens, which is where dopamine is present, if there is inflammation, your food reward mechanism, and there are enough number of pictures where when you look at food, people with obesity, people with inflammation, their area lights up much more in their nucleus accumbens than anyone else. Or in the area of learning, which is the amygdala. The amygdala is what helps you learn this is good, this is not good. But if there's inflammation there, just like Alzheimer's, you have inflammation in these places, this exactly happens. So there's a reward system. That reward system is conditioned. That reward system is modified by all these hormones, inflammation and others, and the consequence is obesity, right? Now, but remember that this stimulus control can also be modified both ways. You exercise, you jog, you do all of that, there is a positive reinforcement of opiates. On the other hand, you sit in one place, you get deconditioned. But the important part to this is this, that if properly trained, your brain can overcome the inexorable effects of these stimuli. And the GLP-1 RAs that we use and the dual agonists that we use are actually examples of that the hedonic overload can be overcome. How do these drugs work? One is what we've heard, they work by restoring the orexin-anorexin balance. But what we now know is how these drugs work is that they project to the reward centers, alter the dopamine response, alter the amygdalian response, and create an artificial vairagya for you. They create aversion to certain kinds of food. They create early satiation. In fact, there are many studies that say that you can use them in alcoholism, in cannabinoids, poisoning, and interestingly, while it improves performance, it also decreases libido in some patients, right? So clearly, the effects of reward-driven behavior can be overcome. If anything that these drugs tell you, this is the proof. Now the question is, can you train your brain to do this without drugs? The biggest problem is, and I'll tell you this, we are all goal-oriented, but we are not process-oriented. I'll give you an example of this. My daughter has a problem with folding her clothes every day and putting it. Now, the simple thing is, what do you generally address her and say, why is your room dirty? Why can't your room be clean? Right? That is being goal-oriented. But you can say, can you train yourself to make sure that your clothes are folded and put every day as part of your daily routine? That's process orientation. Meaning, we are always talking about 10% weight loss, 15% weight loss, 5% weight loss, but instead, we never talk about, you know what? Why don't you learn the discipline of eating food? Why should I learn the discipline of eating food? Because there are consequences of eating food badly. Can I reinforce it? So, the reason that we don't maintain weight loss is two things. One, the body is tailored for millions and millions of years. We have lived in food scarcity. Therefore, the body is trained to store energy in terms of fat. That is the default. It is not a bug, it is a default. This is the first part. Any attempt at weight loss will be countered by the body by an alteration of metabolism. This is life. And the moment, and this is exceptionally done when you use SGLT2 inhibitors. The moment you start using SGLT2 inhibitors, you're losing glucose in the urine, right? If you continue it, you should be losing about half a kg per week for indefinitely, but it doesn't happen. By the end of month 3, you're plateaued. Why? Your body compels you to eat more. Without you knowing, suddenly you start eating more. So the nature programs you, if food is available, to eat it and keep it. And that is why weight loss attempts fail. The second reason that weight loss attempts fail is because we sell it badly. We tell them, if you lose weight, 5 kgs of weight, you're a good boy. Wonderful. Therefore, no. On the other hand, when a patient comes, even if they don't lose weight, if you say, no, doctor, I'm eating less now, I'm exercising more, I feel healthy, we are not happy. We say, you haven't lost weight. Meaning that we have become so goal-oriented, we forget the sadhana aspect of it, the anushtana aspect of it. In fact, the process is more important than the end in many of this. Because that is a long-term fix. It doesn't get over in a day. So to take this back, now I talked about GLP and GIP and how these work. Just to let you know that the GLP-1 works at the hypothalamus, and importantly, it works at the reward centers by altering, by projection. The second part is the blood-brain barrier. It is not through a direct effect. It's through a projection from the vagus and maybe the area posterima into these particular ones. Now, does GIP have a role? GIP has always been controversial about this. But what we do know about GIP in this is that there is an important facilitatory role in the hypothalamus and in these, especially because it works through the mTOR pathway. The mTOR pathway is a pathway for longevity. It's importantly a pathway for neural plasticity. Therefore, do you get this added benefit? We can go on this, whether it's a super GLP or not, but let us look at this. This part is, I'm going to get into this. Now, enough data have said that if you have more than 3 ingredients in the package, then that food is bad for you. I'm going to add to this palm oil. RBD, do you know what RBD is? Refined, bleached, deodorized oil. You have this, it's a sitting disaster. And any of you who eaten chips, murukku, any of these from anywhere in India, they are either made with palm oil or it's a Tata, it's cottonseed oil. The only store outlet that uses groundnut oil is Annapurna. And one Karnataka-based company called Adukale. Everything is palm oil. Refined, bleached, deodorized. How does it work? The moment you use RBD oils, your gut microbiota changes. They become inflammatory. Archimenzia dominans goes down. Cristinella comes down. There is an alteration in the bacteroides firmicutes ratio. Remember I said the gut microbiota work through the gut hormones. GLP-1 changes, increases the inflammation, lipopolysaccharide increases, makes you want to eat more. Simple. Exercise, I won't get too much into it, but you eat well. The problem with exercise is not that exercise is orexogenic, but many people who exercise feel entitled to eat. There's a reward center. You see, many of us who do exercise come home and eat. Why? I've exercised well today, so I should have that extra helping of pongal. Correct? It's a reward center. So a lot of times I tell people exercise late in the afternoon.
Especially resistance training, I tell them do it in the afternoon because you've eaten and you don't feel like. Just like you tell people, before you go shopping, eat and shop. Don't go there. If you go hungry and shop, you will start picking up all the high-calorie food. So, let me come back to this. I'm not going to go into this whole thing, but I'm going to tell you this something very simple. Remember, I talked about Indriya, Mana, Chitta. But there is Viveka. It's called discrimination. This is Western stuff, but I'll make it so simple because we're all Indians. We understand this very well. How do you tackle a problem? First is to acknowledge it. The second is to understand and reinforce that the negative consequences of this. If I eat, yes, this food is fantastic. But if I eat this, it is going to hurt me. The word that Indian texts use is called dosha darisanam, meaning understanding the problems with something. In fact, somebody will read old Puranikas, they will say, payasam is fantastic. You want to eat cups and cups of it. But the one time that you see a cockroach fall into that very tub of payasam, will you touch it ever again in your life? Every time you go and try to have payasam, in your mind, that cockroach is coming in. You need to start putting the cockroach into the payasam to stop. Mentally, you need to start to learn to do it. Meaning, yes, in fact, you can tell patients to visualize. When I see a lot of my, I have patients who say chocolate is not sweet. And I say, do you eat sweets? Yes, doctor. No, doctor. Do you have chocolates? Yes, doctor. But that's a sweet. No, sir. Chocolates are not sweet. Right? The first thing that you can do is to train people to visualize that every time you have a chocolate or a sweet, that you're adding a gram of fat into your abdomen. This is called have you heard creative visualization? Many of you have done it with your favorite actors, actresses, all the others. Similarly, right? Creatively visualizing the negative effect of eating. So every time you do that, it starts working. This is called, in other words, this is called cognitive therapy. That, when I say dosha darshana, understand that there is a problem with it. The second thing is to apply that at every time that you do. And then I teach people reflection. Reflection is, let's say you went to a kalyanam, they said you have to eat, but they told you to eat, but they didn't tell you to eat everything on the plate, right? So, but you did. You came back, you feel bad about it. So what do? It's the same thing that when your child makes a mistake. You don't go and beat them up. What do? You say, okay, what is good about it? Good was that I did actually say that I can't eat. The second is what is bad about it? But when they made me eat, I ate everything that was available. All right? So what could have been done differently? That I could have eaten a small amount, not asked for a second helping, and left the dessert and come out. So if you were to do this again, what will you do? I will eat before I leave. I will tell them, look, unfortunately I've eaten and therefore I can't come. I do this when I go to any meeting. Dr. Venkatraman knows. I never eat in a meeting. I never eat in a buffet. Why? It makes me eat more. So initially, everybody say, oh, I want mind control. But that's not, see, even the sages don't do that. If they want to reach heaven, they first try to go to a silent place where there is no attack on the senses, right? So you avoid those situations where you. Second is, learn creatively to visualize the negative consequences of it. And then bring that into practice. Then eating right? For example, I was talking to Shailaja this morning that there is a yogic way of eating. Drink water first, eat half a stomach, allow air to circulate and get up. Meaning, eat only as much as you need. Now, All of us Indians, because we grew up in a famine-based, please stop me when I have to, famine-based place, we were told, don't waste food. I actually tell patients, it's all right to leave it back on the plate. But sometime, if it is excess, leave it and get up. It's all right, get scolded. But then the next time say, see, last time you put me a lot, I had to leave it and go, so serve me less. Right? It's all right. It is me. I have to change myself. And to do that, and the second thing is to also not to make this into a guilt trip. You will fall, you will fail. But I remember my mother telling my daughter, Virinda Paravala Yurindra, meaning it's all right to fall, but get up each time. That's more important. But if you put shame, guilt, all of that, it doesn't work. So, to summarize this, behavior therapy is something very simple. The Western world needs lessons in this. We are masters in this art. We just have to get back and into our own roots and start learning it. So, to summarize this, remember I started with this Nashamsayam Mahabaho Manam Dushnigraham Saham. There's a second line. Indeed, the mind is a very, very difficult thing to control. Abhyasa enu kaunteya. With practice, you will reach where you have to. That is the most important. Teach patients the art of discovering the right way to eat. Help them understand the problems that arise with this, instead of giving a laundry list. Third, support them when they fail. Tell them that the process is more important than the outcome. And then, you will still use a GLP-1 RA, but then there'll be a few of your patients who will not need it. Thank you so much.
Thank you, Krishna. Just a couple of points, I think, which he himself reiterated in his, as usual, brilliant presentation. A complex topic, the interplay or the participation of the brain with respect to the eating habits. So the homeostatic as well as the hedonic component, nicely. What has impressed is, you should have vairagya. When it is lacking from your efforts, which is common for all of us, which is not unexpected totally, then you have the artificial vairagya, and these molecules help you to have this artificial vairagya. That is, you have the aversion. That's number one. And number two, when you exercise has got an effect on modulating the hedonic component. Third thing is, I think as you rightly said, quite often, when you advise your patients on a lifestyle or a molecule, whatever it is, when the goal is not achieved, you fail to appreciate them. Rather, as he himself shared the details, the patient makes a sincere attempt. I think that should be appreciated, which is found wanting in many of us. I think you nicely highlighted. So these are the three aspects. And last slide that you projected about the various behavioral aspects which you can do, etc., etc. One thing that was impressive was preventing a relapse. Maybe debate 2028 or 29, if you are around, we'll have an answer for that. So thank you so much. I understand that now there's a time for a tea break. We'll reassemble after that the rapid fire sessions, and then we'll have the question and answer session. At that time, all the faculty will be there. I'll combine the pre-frame questions with some of the questions, if time permits, and if you the boss, no? Pardon me? Is that okay? Now it says tea break. All faculty is not here. Number one, rapid fire. Most of the questions will be for you only. No, it's okay. We'll probably in such a way. Now we'll have a tea break. Okay. Come back, have the rapid fire sessions, then we will have some other.
Move forward for the next session, I request everyone to kindly scan this code. We request your honest feedback. This will help us improve for our next program as well. Thank you very much for joining us back after a short tea break. The next session is Obesity Clinical Quick Fire. So till now we have covered all the basics of obesity, understood the pathophysiological aspects as well. But now we have cross-speciality presence here as well. We'll be discussing some hypothetical cases from different specialty, and we'll understand that what is the impact of obesity and the comorbidities. And we'll also have a panel discussion at the end. To begin the session, we have with us Dr. Shamnugavelu, who will be leading this session. He will be the moderator for this session, and he'll be welcoming our other speakers as well. Sir, over to you.
Thank you very much for inviting me to moderate this particular session. So it is a rapid fire session, so I don't want to waste the time. Let me invite Dr. G. Vijaykumar to take the first topic, obesity and type 2 diabetes. We discussed about adiposopathy, excessive deposit of fat that initiates inflammation, that in turn interferes with insulin secretion as well as insulin action at multiple sites, resulting in hyperglycemia. Let us hear furthermore from Dr. G. Vijaykumar. He's our diabetologist attached to Apollo Hospital, and moreover, he is the All India EC member of National RSSDI. Over to you.
Good evening, sir. Thank you for your kind introduction. It's always been an honor to be with you because you provide so much of input so that we learn from you. And thank you, Lily, for organizing such a program with only science, and there is no commercial interest in this. So this is a very rare entity or a species, so very rare. Thank you. Can I have my slide? Okay. This lecture is being contracted by Eli Lilly. Okay. Now, actually this session is going to be quick fire. Just 10 minutes. I try to finish as much as possible. Now, we could have heard in the earlier lectures about the obesity. And then what is the connect between obesity and diabetes care? Is it necessary, or how essential, how important is that tackling obesity as a target? It's targeting fasting, targeting postprandial, targeting HbA1c, targeting, the glycemic variability. These are all things which have been there. But targeting obesity as during diabetes care is a very, very important thing that we need to look into that. Now, what is the connection between these two? See, there is a connect between diabetes and obesity. Basically, we know that it's basically an inflammatory disease. Now, if you look into the diagnosis of diabetes, previously we used to say that it is a metabolic disease. Then we came to know that metabolic cum vascular disease. Then in latest what we say is a metabolic cum vascular cum inflammatory disease, absolute inflammation. Now we know that obesity is based upon the genetic and environmental factors, which you could have learned in the earlier lectures. And then there is a connect between through chronic tissue inflammation. Now, how does this happen? Is that basically the central obesity and the free fatty acids which comes in and then cause insulin resistance in several organs, and along with that it creates inflammation along the metabolic changes that happen is chronic inflammation. This causes insulin resistance in the skeletal muscle, so glucose uptake is and in the inflammation secondary to lipotoxicity of the beta cells and inflammation, ensuing inflammation can cause reduced beta cell dysfunction as well. So you develop type 2 diabetes, and all of us know that the comorbidities that whenever we have obesity and diabetes, you have cancer, increase in cancer, MASLD is part and parcel of it, type 2 diabetes, CVD and sleep apnea are the thing. Now, this is about how the connection is there, how a diabetes develops because of inflammation. Now, suppose you are a diabetic and you have a obesity, how it worsens the diabetic status is a very important thing to need to address. Again, if you can look into that, the whole, the the algorithm, what happens is that accumulation, expansion of adipose tissue, that is basically the ectopic adipose tissue. Okay, that is one, which in turn causes lipolysis, increased lipolysis, in turn causes free fatty acid circulation, and that causes problem in uncontrolled diabetes coupled with inflammation. Okay, so it is a free fatty acids and coupling with anti-inflammation. In the muscle, if you could see that there is what is called as, once you have a lipolysis, you have what is called as the diacylglycerol. So that increases, and then it has got a say on the insulin receptor proteins, and so that you can see that the glucose transport or glucose absorption, and look at this, glycogen synthesis. Any excess of glucose that has to be there has to be converted to glycogen and deposited first into the liver, then into the muscle, then into the around the kidney. So these are the way we have to do it actually. And this problem is being the glycogenesis, that is synthesis of glycogen, is not there, so the existing glucose also will increase in the circulation. Now, the same diacylglycerol can cause the lipotoxicity of the beta cells, and initially there will be dysglycemia. In fact, there will be dysglycemia, which increase the volume of the beta cells, and then they get exhausted, and apart from that, they will have what is called as lipotoxicity, and in turn, there is exhaustion and reduction in insulin production, and so you can see that hyperglycemia will ensure. In the liver, the same thing. Diacylglycerol get accumulated, what you call as fatty liver, and then you can see that neoglucogenesis is there, glycogenolysis also will be there, because there is a lot of substrate for it. That is because both the free fatty acids as a substrate to be there, secondary to the visceral adiposity or ectopic adiposity. Now, because of these things, the various guidelines have shown that we have our own guidelines, Indian guidelines, through Endocrine Society of India, which says that when the BMI is more than 27 or when the BMI is more than 25, along with any comorbid conditions such as dyslipidemia, type 2 diabetes, OSA, osteoarthritis, hypertension, if any of these things are there, there is a suggestion for pharmacotherapy. That is number one. And European Association for the Study of Obesity framework recommends same thing. Anything more than 27 plus any related, because you can see the difference between the Western and Indian. It is 27 and 25. Here it is 27 and 30. Same thing, but the numbers differ. Now, what are the benefits that, suppose you start a treatment, bringing down blood glucose is one thing, but how you bring down the blood glucose levels is the most important thing that we need to think about. You can put any number of sulfonylureas, insulin, everything you can bring down. That is not the idea that we need to do that. How is it we need to do that? Is that if you can tackle, especially in the early stages of the disease and even later on, especially later stage is very important. Is very important because you can see that this reduction, targeting weight reduction will get into better outcomes. Like 5 to 10% of weight reduction will give good glycemic control, and then 10 to 15% of weight reduction can cause disease modifying effect. This is a very, very important. Now in the next slide you can see that this disease modifying effect can be converted like from pre-diabetes to diabetes type 2 is impaired, right? Because you know that pre-diabetes is nothing but, if you look into the natural history of the disease, there is a mild dysglycemia secondary to adiposity for almost 10 to 15 years. But as earlier said, that there is beta cell increase in size and also increase in the numbers, so that it gives ultimately get exhausted. Once you get exhausted, in the last 3-4 years of this compensatory period, which is about 10 to 15 years, you get what is called as pre-diabetes. Again, this is again because of the insulin resistance syndrome, which includes because of obesity. Now, if you have weight loss, you can disease modifying effect in the sense that prevention of pre-diabetes to diabetes, and then it also improves glycemic control, blood pressure and lipids, and OSA, osteoarthritis, everything can settle down. But whether it can be converted into CVD benefit is a big question to be answered. But I personally feel that if we have a type 2 with a good glycemic control, hypertension and lipids are altered, I think that makes a very good, all the cardiovascular markers also are addressed. And then good HbA1c control will reduce the microvascular complications. Now let us look into one case here actually. It's a lady who is recently diagnosed with diabetes, which has got, you can see that her BMI is 37, and then HbA1c is 7.2, EGFR is okay. She's already on metformin. And you can see that how far weight reduction is more effective in the LSM. See, whether you use pharmacotherapy or not, LSM, that is lifestyle modification, is a must that you need to do that. In spite of having pharmacotherapy, you need to continue with lifestyle modification. And then you can see here that look ahead trial, which has given so much of thing. Even look at it is not such bad thing actually. Even after 3 years of looking into that, actually for information, you can see that 42% of the people who are on what is called as ILI, that is intensive lifestyle intervention, ILI, is at 10%, more than 10% weight loss at 4 years. And at 3 years, about 9.9% of the people had increase in the, they overshot the baseline overweight. But over the time, we can see that they'll be regaining of the weight, but it is still not bad at all. So even in spite of pharmacotherapy, we need to continue that. There is a benefit of going for LSM. You know that drugs, you can see that most of the drugs are either weight gain or neutral, but only thing is that SGLT inhibitors have got a moderate weight reduction in these drugs. So bariatric surgery, this is a very, very important thing actually. See, the tendency towards a surgery and pharmacotherapy, you know, this morning, I think Dr. Puri was telling about that. There is a, that we can, with LSM, we can get about 5 to 10% of weight reduction. And then with bariatric surgery, we get about that 25 to 35% of weight reduction. And there is a gap in between, that is 5% to 25%. And this is where I think pharmacotherapy will set in. The pharmacotherapy is going to be useful between these two groups. And that is the reason, if you can see that the number of surgeries, bariatric surgeries, is going to come down, but whereas the increase in the use of GLP-1 receptor analogs for weight reduction. I'll finish in 2 minutes, sir. So this patient needs not just glycemic control, but weight reduction. And at the background of metformin, I think GLP-1 receptor analogs will be GLP and GIP therapy is a best option that you can think about. Similarly, one more case, a lady who has got 8 years history of type 2 diabetes, that's a early diabetes, this is a long-standing diabetes, already on metformin and SGLT inhibitor. You can see that her BMI is 33, and then you can see that the waist circumference is 112. That's very, very high. So what happens is that in this case also, if you can see that adding a GIP, GLP analog can do a lot of benefit in the sense that the waist circumference will come down, the BMI will come down, all the metabolic factors also can come. So target it, I mean, just trying to say that it's not just bringing the blood glucose, target the obesity, especially, I mean, any part of the disease, any time of the disease that you have, but start early. That's the most important thing. Start early, have the benefit. If you can do it in the first 10 years, 5 years of diabetes, the remission is possible. So this is what we need to think about. Thank you for your patience.
Thank you, Dr. Vijay Kumar. So the key message is obesity is characterized by chronic inflammation that may increase the risk for diabetes, can cause worsening of the glycemic parameters through inflammation, oxidative stress, mitochondrial dysfunction, endoplasmic reticulum stress in various organs. There is one. And he has also pointed out nicely the weight-centric comprehensive management of patient with the type 2 diabetes with reference to reduction in the risk for atherosclerotic cardiovascular disease versus glucocentric management of patient with the type 2 diabetes. And he has also given two case scenarios in our routine clinical practice. Now he wants to go much early, so I can ask the participants to ask one question. Any question from the floor? Okay. Because he wants to go right now.
I have One more talk.
Yes, yes. Okay, thank you, JK. Please stand up, pick up the microphone and ask.
Do you supplement all these patients who are on GLP and GIP on micronutrients, sir, or it is only based on the blood levels?
Okay. As far as the, there is a lack of appetite will be there whenever you use the GIP and GLP based therapies. Definitely we need to replace the, definitely the food, but the problem is that you got aversion for certain, especially your favorite foods, you get aversion for that. Depending on the situation, in fact, in my series of patients, we didn't find any nutritional deficiencies except for, if at all you find any signs of that, probably you need to replace it with vitamins. Otherwise, in general, we have not seen that actually. I hope our
Yes, yes. Of
chairperson
course,
will.
you can prescribe, sir. It is safe. It is not contraindicated.
No. He's asking whether we need to compulsorily give it. So that's the reason I am telling. If there are any signs, even not only with this, I think in your mind, I think you're thinking about the bariatric surgery and then the vitamin deficiencies that happen, and that's why you have to give that fat soluble and water soluble vitamins. Maybe that is what in mind. But those things we are not able to see, at least in my practice, I'm not seeing those things.
As far as the data is concerned, there is no. Yes, thank you, Dr. Vijay Kumar. Next, let us move on to next topic, yet another metabolic problem we come across in our routine clinical practice, the metabolic dysfunction associated steatotic liver disease. Can I have the intro slide of Dr. Arun? So, he's a consultant gastroenterologist, hepatologist, and interventional endoscopist, Apollo Main Hospital, Creams Road, Chennai. Yes, over to you, Dr. Arun.
Thank you very much, sir, for your kind intro, and I would like to thank team Debate-2026 who gave me an opportunity to be here, and also I would like to thank team Lily who gave me an opportunity to be here. And MASLD, it is clearly a heterogeneous terminology being used in the initial phase. Why there is so much of confusion in diagnosing a patient with MASLD? That is the one thing, before I'm going to wind up this session, you should identify certain things about MASLD. Initially, the term NAFLD was there. After that, it has been replaced by MAFLD in 2020. Now, MASLD. Why means that American Academic Society and European Society, they are not convincing. What is the reason? Because most of the patient, this alcohol will be a coexisting confounding factor, which will be always a confusing area. How much of alcohol? Suppose you need to maintain at least around 20 to 30 grams. If the patient is going to consume more than 50 grams of alcohol, which means the patient is predominantly going to land up with evidence of alcoholic liver disease. So, if the patient is going to consume less than 20 grams of alcohol in the background of your cardiometabolic various risk factors like your dyslipidemia, hypertension, your BMI changes, all those things will be having a contributing factor. Even if one of the strongest point, if it tends to be positive, that means the patient, there is high risk for the patient to land up with evidence of metabolic associated steatotic liver disease. So now the term obesity has been having always interchangeable. Your obesity, your diabetes, all these things is going to worsen your MASLD. It's vice versa. Apart from that, you should know about the basic pathophysiology and all those things, but in this 10 minutes of talk, the most important thing is, it is always overdiagnosing in India. So it doesn't mean that if any patient comes with MASLD, comes in the background of fatty liver, in the background of obesity, doesn't mean that the patient is going to land up with evidence of MASLD quickly. And one ALT elevation doesn't mean that the patient is having MASLD. So always a serial pointers, clinical assessment of the picture, obesity with multiple other confounding factors, along with the patient in the background of your enzymatic changes, in case if the patient is having biopsy proven, or if the patient is having evidence of, for example, fibroscan assessment, your various parameters, your biomarkers can be healed, a significant assessment to diagnose this early MASLD clinical criteria. So what is the basic semiology? So if you're going to do an ultrasound, you're going to identify a patient with evidence of fatty liver. If the patient is having fatty liver, which means around 80% in Indian scenario will be very common. This is how the semiology will progress. And this kind of patients, around 10 to 20% of the population, they may have evidence of metabolic associated steatohepatitis, in which the patient is going to land up with evidence of ballooning and other changes, inflammatory changes, with evidence of your liver enzymes being elevated. And once this is going to get happen, around 10 to 20% of the population over a period of years, around 10 to 15 years, can land up with evidence of cirrhosis. If you're not going to compensate, if you're not going to look into that, then the patient within a span of around 8 to 10 years, they may land up with evidence of more decompensation within 6 years, and within around 4 to 5 years, they may land up with one of the most dreadful causes in what is called as hepatocellular cancer. And always steatotic liver disease, metabolic associated. So even though all the parameters, we should remember that MASLD is always a diagnosis of exclusion. We should always rule out all the significant coexisting pointers before diagnosing your MASLD. And virology, your drug abuse, apart from that, any other metabolic coincidence, your genetic parameters, monogenic focus, all these things we need to take into account before confirming, before you're going to rule the patient as metabolic associated steatotic liver disease component is going to be there. And apart from that, how are you going to address? Which is a major area you're going to contribute? Whether the patient alcohol is going to address, or the virology like B and C we are going to get addressed, or the metabolic component which is going to get addressed. This is how we need to segregate the patient, and then we need to analyze. This is what, even for the best of gastroenterologists in India, we'll be having a difficult task. How do you going to, because when you're going to, because based upon the diagnosis, the treatment guidelines will be entirely changing. So some patient will be having hepatitis B virus with the MASLD, hepatitis C virus with the MASLD. All these things we need to look into a coexisting confounding factor before labeling this as a predominant etiological component. So to take on with a simple case, this 50-year-old male who had a BMI more than 50-35 in the background, who presented to us apart no other major evidence of decompensation like jaundice or ascites, now presented in the background of fatigue and abdominal discomfort. He is more sedentary and is in high carb diet, no major history of alcohol intake. Apart from the no other major medications, and the diet and exercise not major. Apart from the lab picture showed in the background of fasting plasma glucose almost going around 185, HbA1c in the range of 9.2, and LDL is in 155, and the metabolic parameters like your liver function, ALP, AST, ALT, all the parameters in the higher side. ALP is okay, but AST and ALT in the higher side. So with this, so more than 5% accumulation of liver fat hepatocytes along with these clinical pointers, this patient more in favor of MASLD. Okay, fine. But that doesn't mean it's always the negative markers. We need to look into that. As I told you, it's always a diagnosis of exclusion. And clinical pointers, fibroscan, others, so many invasive. So always we should remember that the clinical assessment of the patient as a whole is very important. Ultrasound, basic guidance, and one significant gold standard to diagnose is MRI, proton density diffusion fraction, all those things, P and MRI fraction, and this is very costly issue. So most of the time in Indian centers it will be very difficult. And basic your fibrotic assessment. What you're going to do with your fibroscan, there are various scoring to assess the marker of severity. One is FIB4. What is the FIB4? H, AST, platelet, along with ALT, with these 4 components. And there are so many other things, AST to platelet ratio, that APRI scoring system. So many scoring systems are there. That's not the area to discuss, but you should remember that what you're going to see in that, once you're going to do a fibroscan, you need to remember 2 major pointers. One is control attenuation parameter, in which you are going to assess your stiffness of the liver, which means steatosis component. Steatosis component. Apart from that, once if you're going to see your liver stiffness measurement, if it is going to be more than 9, if it is going to be more than 12, which means the patient is going to land up with evidence of cirrhotic changes. So we need to tackle with evidence of your control attenuation parameter along with your liver stiffness measurement. And nowadays one more scoring which has been included, what is called as fast scoring, in which your fibroscan along with your AST can be taken into account. And there is another scoring what is called as mass scoring, in which your MRI fraction along with your AST. All these pointers you can take into account to diagnose this patient. There is high risk for this patient to progress for metabolic associated steatotic liver disease component, which is going to take on or not. So this is what the basic algorithm. You should remember that the FIB4 scoring, enhanced liver fibrosis, simple thing, 3 major. One is your hyaluronic acid component, Apart from that, your procollagen, and the third one will be your tissue inhibitor matrix metalloproteinases. So in which these basic things, if we are going to look into that, and how far we are going to execute these things in India, it's still a challenging issue because for most of the Indian patients, we cannot do all the investigations. So what is the best possible investigation? And fibroscan, basic assessment, your vibration control, thromboelastography, and along with that, we can able to identify these basic parameters to diagnose your fatty liver disease, whether the patient is going to land up with evidence of your metabolic associated steatohepatitis or the patient is going to land up with cirrhotic and other complications. As I discussed, your various scorings can be add on to the criteria to diagnose. Apart from the gender prevalence, almost no major changes. Men will be in the higher side, around 49% when compared to women. And so what is going to happen? The steatosis, the gluconeogenesis is going to get impaired. Apart from that, the patient is going to have worsening of changes like your hepatocellular cancer, cirrhotic changes, your decomposition, all these things, if you're not going to control in a prompt way, will be having a proper worsening of presentation as the day, if it progresses. And impact of obesity, weight loss. So what is the weight loss? So if you're going to have around 5 to 7% loss, which means more than 10% of loss, the patient is going to have a significant improvement in a steatosis component. That's why the role of diet and lifestyle modification is going to take into account. And there are various biomarkers, your genetic models, you should remember that. So there are good prognostic markers, there are bad prognostic markers to diagnose. So this is more of theoretical. You should remember cytokeratin 18, in which the filamental component of your protein break down, so you can able to identify the severity of your hepatic steatosis. Apart from that, there are better prognostic markers and bad prognostic markers. In this is toxin-like protein, that's TOR1, AP1, apart from the human leukocyte, and HCC associated biomarkers like your canopy associated gene and endocytodase associated genes. Apart from that, your secretogranin genes. These are all the things can be taken into account. So if you want to diagnose this, clinical assessment, ultrasound, pick up the diagnosis, look for the changes of obesity, tackle the patient with metabolic syndrome, whether the patient is landing up or not, and what is the best line of therapy, whether the patient is going to choose for liver biopsy or you're going to choose the patient with dual incretins, or either the patient is going for any screening purposes, or we need to refer the patient to hepatologist to diagnose this presentation. Still, always if the patient liver stiffness, if it is going to be more than 8, refer the patient promptly to hepatologist and make sure that you're going to see only 2 major criteria, your FIB4 as well as your APRI scoring. FIB4 has to maintain in the range of 1 if it is going to be high, and APRI if it is going to be more than 0.45, which means the patient, we need to refer to a prompt hepatologist to diagnose this kind of presentation effectively. And what is so mild steatosis, moderate, severe, if the fat, if it is going to be more than 60, along with the diet, lifestyle, as you all remember that fatty diet, carbohydrate-based elimination, so make sure that the saturated fat not supposed to go more than 10%. All these parameters we need to take into account, and this is what the weight loss guidelines, if the patient is going to be more than 10% of weight loss, which means the steatosis will be having significant improvement, steatohepatitis will be having significant improvement, and hepatic fibrosis resolution along with your regression of changes with most of the molecules when you're going to, and the weight loss will be having for that, the molecules like dual incretins have been taken into account. And so what is the basic goal? Identify the patient promptly, do a minimal investigation, pick up the diagnosis early, and significant weight loss is the major glycemic targets with lipid control, reverse your MSLD, and outcomes, we need to maintain a sustained weight loss, and cardiometabolic benefits has to be augmented. So we need to target, so always we need to target the fibrosis as not a major destiny, so we need to control that in an effective way to overcome this presentation. Thank you very much.
Thank you, Dr. Arun, for your lucid presentation in a simple and easily understandable way. Nice presentation, sir. And clinically, we can make a diagnosis, and only certain cases we refer for hepatologist. Yes. And early identification and proper treatment much earlier will definitely save the life of the patient, and also progression from MAFLD to MASH to cirrhosis and hepatocellular carcinoma. Thank you, sir. Sure. Again, he wants to leave for yet another commitment. So may I request our, yes, Mohan.
One question, like a lot of patients do they come with fluid retention when you start ruling out other things and find out that they are in cirrhosis. Only the FIB
score seems to be rising, ALT, AST seems to be normal, ultrasound seems to be normal. In such patients, do we need to go for FIBO scan to prove that something is going wrong, or accept that it is this thing and
So once the patient is going to land up with evidence of fluid retention, which is in the form of multiple ways, it might be pedal edema, ascites, or volume overload status. Once the patient is going to land up with volume overload, almost the patient is gone for evidence of decompensation. In that kind of background, there is no role for fibroscan at all to diagnose clinical presentation, because the clinical...
how do we fix the cause? Because like everything else seems to be normal.
No, that always metabolic associated steatotic component is always a diagnosis of exclusion. Even though if the patient is diabetic, we need to work up the patient as a whole, and we need to look for all possible etiologies, alcohol, virology, all these pointers we need to rule out. Then only we can able to come to the conclusion this might be predominant etiology because of MASLD. Then the management spectrum will be completely changed.
So he has already informed hepatitis B markers, hepatitis C markers, ANA, everything before we make a diagnosis. Thank you, sir. Thank you very much.
Thank you very much, sir.
Next, let us move on to obesity and cardiovascular disease. May I call upon Dr. Vinod Kumar? So, Associate Professor and Senior Consultant Interventional Cardiologist, Sri Ramachandra Institute of Higher Education Research, Managing Director, Chennai Cardiac Care. Over to you, sir.
Thank you, sir. So basically, this is Eli Lilly, and I'm being engaged by Eli Lilly and other pharma companies. I have a trial grant with Novartis. This session is purely sponsored by Eli Lilly and the company. So, been discussing about case studies in different aspects like obesity and diabetes, obesity with MASLD. Now we are moving into cardiovascular disease, which is quite interesting. So, Mohan sir was here and he was asking about the fluid retention. Probably whether we should suspect heart failure with preserved dissection for that too. That should be the first diagnosis rather than with the MASLD. I would go with the heart rather than with, so I will start with the NT-proBNP value. So now we will move into the case scenarios. So now I'm going to discuss two case scenarios. One is very standard garden variety. Nobody will miss. Even a finished GP practitioner who is post MBBS will pick up this. A patient is coming with a 62-year-old male with 95 kgs, recurrent chest pain for 3 months with a high BMI, who has a prior MI history with CAD, hypertension, diabetes. Now BP is around 148/90, HbA1c slightly above the normal range, and patient is obese and he has gained weight in the last 12 months. Patient has exertional angina and is restricted, his walking is restricted by angina. That is what currently happening. If you see his blood parameters, LDL is out of range, triglyceride is on the higher side, LPA and HDL is on the lower side, LPA is on the higher side, and HbA1c is not in the range. Fasting glucose insulin sensitivity is 168 it is. Troponin is borderline positive. Patient has NT-proBNP being on the higher side, and inflammatory marker HSCRP is rising. eGFR is less, it's 72, and UACR is also on the higher side. So we have a case scenario where the patient who is a known case of coronary artery disease, prior MI with known CAD, now presenting with chest pain regularly and troponin being positive, obviously we should suspect a recurrence of event. So what we should do? We do a ECG, we do a troponin test. If troponin is positive, the patient has ECG changes with ST elevation, obviously patient will require a reperfusion therapy either in form of angioplasty or in the form of primary angioplasty or in form of thrombolysis. If no, then we have to do serial ECGs and troponin to look for STT changes in the ECG in form of ST depression or T-wave inversion along with the troponin. Once the patient has ST changes and troponin being raised, then what we do? We initially stabilize the patient and then take the patient for an angiogram and evaluate his coronary disease. So this is what we all do. So what we should do, first stabilization is, we load these patients with antiplatelets, statins and heparin. This is what the standard set of treatment we do for every patient once the patient comes, because we love to stabilize the ischemic component of the particular patient. So we put all these drugs on the initial stage. Once the patient is stabilized with heparin, antiplatelet, statins, everything, and especially we have to, in ACS, what is the rule? Dictum is high intensity statin. If you are using atorvastatin, you should use 80 mg. If you are using rosuvastatin, it is 40 mg. Now ACC 2025 guideline says, in spite of atorva 80 mg and rosuvastatin 40 mg, you can add estimab at the start go. Previously till 2024, we have been using estimab as the after 4 weeks. Now current guideline says we can add them even on the go, the first step itself in ACS conditions. Second, once you have stabilized this patient, then what is the plan? We have to take them for an angiogram. Angiogram shows coronary artery disease. They say about, nowadays we have image-guided angioplasty, where we use intravascular ultrasound or OCT to define the lesions and then address the lesions, so that the re-stenosis rates have come down with the image-guided interventions. That is the new added kit, and we are able to modify the calcium very significantly with the newer devices. So re-stenosis rates have come down with the stenting process. Once that is done, we have to stabilize this patient for a longer period of time. Any ACS patients who is either undergoing a stenting or a bypass surgery or a medical management will require dual antiplatelet therapy for first 12 months, and he will require intensive lipid lowering therapy. And we all know beta blocker is very, very extremely important. Why it is important? The excellent drug which can give you extraordinary mortality benefit. It gives about 30% mortality benefit within a month's time. So, and within 24 hours, you have to initiate these patients on beta blockers. That is very, very important. And then RAS blockade is a part of any coronary artery disease therapy. And the important glycemic optimization. Now this patient is a secondary prevention case. So there is no need to calculate any ASCVD risk scores in secondary prevention. So any patient should get a SGLT2 inhibitors and GLP-1 analog in case if they deserve for it. SGLT2 inhibitors, no doubt, it should be on the part and parcel of the therapy. And if the patient is obese and if you want to control his sugars, then obviously GLP-1 analogs will come into the glycemic picture also. Then blood pressure control is good, and lifestyle modification, smoking cessation, and physical activity. So this is what, with this therapy, what happens? ECG improves, echo improves, heart rate settles down, lipid profile comes into the balance. So patient becomes stable with a concluding therapy of probably with high dose statins, dual antiplatelets, RAS blockades, and a good glycemic control. Everything is fine. But this is the garden variety we see day in and day out. But the problem is not this. This everybody picks up. Now the problem, real problem comes in. This is the case 2, where we are very much confused. A 58-year-old lady walks into your room with complaints of dyspnea. You auscultate her chest, it is quite okay. And the patient says she has fatigue for last 6 months, and she is in the obesity range. He has diabetic hypertension, and JVP is elevated, bilateral basal Krebs are there. Immediately what we do, we get an ECG done. ECG turns out to be normal. We send these patients for an echocardiogram. Echo comes out as LV function normal. The problem lies here. During a busy day practice, we tend to miss at this point. We feel it could be an occult asthma or a bronchitis or a previous last week LRTA. That's why the patient is having this kind of symptoms. But actually what is happening, we should think about another condition of heart failure with preserved ejection fraction, where EF remains constant and other factors get changed. We will look into the factors which are going to get changed. First factor is biomarker, which is NT-proBNP. NT-proBNP is always gets elevated in heart failure with preserved ejection fraction. Here this patient, troponin is also mildly elevated, and EF remains normal. It is 56. And what are the other factors will increase? We will see this graph. Patient will have a severe diastolic dysfunction. Diastolic dysfunction is one of the key features of heart failure with preserved ejection fraction. If EF is normal, then look that echo report for diastolic dysfunction. If it is grade 2, grade 3, usually diabetic will have grade 1. If grade 2 or grade 3, it's very significant. That might be the cause. We all should remember that diastolic dysfunction, higher grades like grade 2 and grade 3 by itself is a mortality predictor. So it's a very, very important factor to reminder of diastolic dysfunction. Second is the commonest thing which we miss is LA enlargement. We always see in elderly patients LA enlargement, which doesn't give importance. We see the ECG. Most of the time, there is a possibility of paroxysmal atrial fibrillation, which might not be there. I always tell my residents that when you do an ECG, it is only a 30 seconds or 5 beats you are seeing. You are not seeing the entire day. If the patient says palpitation, give importance to it. Look for left atrial enlargement in echo. If it is there, go for Holter. Try to identify atrial fibrillation in your patient. That could be the reason for the palpitation. The third is this patient is having pulmonary hypertension. Why we should worry about pulmonary hypertension in this kind of patients? Because the RV dysfunction is very difficult to treat. Take it from me. It is easy to treat LV dysfunction. It is very difficult to treat RV dysfunction. Once the patient moves into RV dysfunction, it is deemed very difficult to treat that particular patient. So pulmonary arterial hypertension is also a very important marker. Then troponin. Now EF is normal, troponin is borderline positive. We should not think whether the creatinine is borderline, that's why troponin is positive. It can be any other reason, recent infection or any other thing which can contribute to this troponin. No, never. It could be even elevated in a heart failure with preserved ejection fraction. That should be kept in the mind. And then third, elevated NT-proBNP. Whenever BNP is elevated significantly, that means there is a significant hemodynamic stress. That is a very good indicator to identify heart failure with preserved ejection fraction. So once the clinical assessment is done, then we have to look into the NT-proBNP value. NT-proBNP value is on the higher side. You have a diastolic dysfunction in echocardiogram, then it becomes heart failure with preserved ejection fraction. So you have to categorize your patients into 3 groups. Heart failure with reduced ejection fraction less than 40, mid-range, which is 41 to 50, and preserved, which is between 50 to 60. So once you know with your echo and NT-proBNP value whether the patient falls into which category, whether really patient has an heart failure, the biomarker will tell you. If then echo will tell you which category the patient will fall across. So with that, we have a very beautiful score. This is called heart failure, FF score. It's very simple score. It says if the patient is having obesity, because obesity is a very, very important factor in heart failure with preserved ejection fraction, where BMI is more than 30, it carries score 2. Then the patient, if he is hypertensive on more than two medications, then it carries a 0.1. If the patient has an atrial fibrillation, it carries this extreme value of 3. And if the patient has a pulmonary artery systolic pressure more than 35, then it carries 1 point. If the patient is elderly, more than 60, then it also carries 1 point. If the patient has a diastolic dysfunction, it carries 1 point. Any score above 5, anything, it is scored up to 9, it's any score above 5, you should strongly suspect heart failure with a preserved ejection fraction. So which is the subset which you will commonly see? Obese patient, women more than 60 years with mild diastolic dysfunction and irregular heart rate. This is extremely suggestive of heart failure with preserved ejection fraction. What is the current treatment guideline available? There is an error in the slide. SGLT2 is currently is class 1A indication after 2023 ACC ESC guidelines. So it's class 1A. The only drug which has class 1A indication is SGLT2 inhibitors. Diuretic is also class 1 for fluid reduction, that is draining of excess fluid. So why SGLT2 inhibitors? It provides both cardiovascular mortality and morbidity benefit, as well as it provides quality of life improvement. The other drug which is coming into the market is Fendrinone, which has heart failure benefits in heart failure with preserved ejection fraction. So what are the non-pharmacological strategies to improve heart failure with preserved ejection fraction? So heart failure treatment is always not single person. Probably a patient comes in, I do an angiogram, I put a stent, I send. Probably I will meet him after a year's time. So everybody has to be involved. Physician has to be involved, a heart failure specialist has to be involved, a technologist has to be involved, a physiotherapist has to be involved, dietitian has to be involved. So it's a multicentric care. What is the lifestyle? Lifestyle, basically we have to have a healthy lifestyle. Diet should be advised. Salt restricted diet is always better in a heart failure patients, and especially exercise. Patients has to be exercised again, and that improves the quality of life. And comorbid management. Whenever we are talking about heart failure with preserved ejection fraction, we talk about comorbid management like diabetes, hypertension, coronary artery disease, and valvular heart disease. So mentioned by our first speaker, Vijay Kumar sir, we get a cardiovascular benefits when the weight reduction is more than 10%. We see very good changes in blood pressure and triglyceride even with 5% of body weight change. When it goes above 15%, you have incremental benefits. So weight reduction is always good for cardiovascular benefits. So obesity is as mentioned by the first speaker, Vijay Kumar sir, it causes a low-grade systemic inflammation. Our diabetes can reach to microvascular dysfunction. This together, obesity and diabetes, can accelerate your left ventricular remodeling and push these patients to heart failure. So obesity, diabetes, CKD, hypertension, deadly combination. These are the patients who this interplay of diabetes, CKD, hypertension can lead to heart failure with preserved ejection fraction. This is the subset of that you should keep in your mind. Whenever you are seeing an obese patient with diabetic and hypertension who is 60 years of above and is complaining of dyspnea, then it's a very good clue that it might be a heart failure with preserved ejection fraction. That patient deserves further evaluation. So we all know diet and exercise will improve a patient's obesity platform. Thank you one and all for this wonderful episode.
Yes, sir. I need a rapid fire question. Number one, what is the dosage you recommend for Finerenone? Finerenone along with ACLT2, because if you look into the 5 Notes trial, they have given up to 40 milligram.
Sir, but we generally recommend
Not 20 milligram.
10 mg, and we monitor percussion. If the percussion is within limits less than 5.5, then I uptitrate to 20 mg. And
Right.
whenever there is a rise in percussion, we decrease.
Right.
40 mg we are not using.
Right. What level of LDL will you suggest as a goal? 30 milligram, 50 milligram, or 70 milligram in that case?
If my patient is the first patient, then I will recommend less than 40 milligram per deciliter. First patient who already has a known CAD, now have a second event within 2 years, then obviously his LDL should be less than 40. According to ESC. According to law India guidelines, Lipid Association of India, it should be less than 30.
Yes.
So it is, if you consider if it is going to be the first event, they say it is
50.
less than 70. But let us be aggressive, we can keep around 50, 55.
Yes, actually, the latest article on SGLT2, it improves the microvascular dysfunction also.
Yeah, that is the main thing. It has a
Yes, sir.
beautiful improvement in the
Yes. Thank you so much, sir. Thank you. So next, I call upon Dr. Meenakshi Sundaram. Yes, please, onto the stage. She's going to deliver talk on obesity and women's health. She is a senior consultant gynecological, endoscopic and robotic surgeon with over 2 decades of experience in advanced minimally invasive gynecology, internationally trained academician, profile author. Yes. Over to you, madam.
Thank you for the kind introduction, sir. It's a great honor and pleasure to be here today as a part of Debate 2026. And I thank Team Lilly for contracting me here and sponsoring this session. I have no conflict of interest or any pharmacological ties. So today I'm going to be speaking to you all about the common things that we face in our clinical practice. Every woman who walks into the clinic has this problem of weight gain. Whether it is a young girl, somebody who wants to get pregnant, somebody who has delivered, or somebody in the perimenopausal or the postmenopausal phase. The commonest problem all of them have is weight gain. They always are concerned about obesity, an important thing. Can I have my slides, please?
Madam, you have to operate. You have to operate, madam.
All right. Thank you. Right, so across all age groups, whether it is adolescents, reproductive age group, older age group, obesity is an issue. In the adolescent, you find there's a lot of psychosocial impact, low self-esteem, and mental health concerns. In the reproductive age group, predominantly we see increased risk of infertility, polycystic ovaries, and pregnancy-related complications. In older age group, there is definitely an increase in the cognitive decline, dementia, Alzheimer's, and even the maternal obesity affects the child in the long term. So one of the commonest things that we see in adolescent girls is polycystic ovary. Now, polycystic ovary is predominant cause for infertility and all the gynae-related endocrine disorder. And there is an increased risk of miscarriage, low fertilization, and biochemical pregnancy loss with PCO. Obesity, if you look at on the other hand, there is hormonal imbalance as well as menstrual irregularities. So because of the disrupted signaling to the LH-FSH, there is anovulation and menstrual irregularity. And also because there is an unopposed estrogen action, they can have endometrial hyperplasia, which can in turn cause menorrhagia. So it's a spectrum. There is both heavy bleeding as well as anovulation and less bleeding. This combination together definitely affects especially the adolescent girls. So PCOS, there are 2 of the 3 criteria that is important to diagnose. If there is a presence of hyperandrogenism, either clinically or biochemically, and chronic anovulation, and ultrasound diagnosis of PCOS. One of these, out of the 3, at least 2 criteria are positive. You diagnose as polycystic ovaries, and they are at increased risk for metabolic dysfunction. So they are at increased risk for prediabetes, diabetes, dyslipidemia, and cardiovascular disease, and also reproductive dysfunction. So they have menstrual irregularity, anovulation, which causes infertility, and also pregnancy-related complications. Now, if you look at IVF, So a lot of women with anovulation, with obesity, after trying, eventually when they land up with IVF also, they can have mitochondrial dysfunction in the oocyte, and this can lead to decreased pregnancy rate with IVF. So there can be a low fertility rate. There can be miscarriages, especially in obese women compared to the non-obese women. So there is fertility and conception challenges in obese women. There is reduced fertility, and higher BMI reduces IVF success rates and also increases the chance of multiple pregnancy. The benefits of weight loss: even if there is a 10% weight loss, there is an increase in the pregnancy rate, increase in the ovulation rates, and it restores the normal reproductive function. So the first case scenario, as we had seen, is polycystic ovaries. Young girls who come with a high BMI, waist circumference is more, they have infertility, obesity, hair loss, and also hirsutism. There are subclinical features of hypothyroidism. They are trying to conceive. If you look at the lab parameters, there can be borderline elevated TSH, increased triglycerides, and HDL. Like I said, the diagnostic criteria for polycystic ovaries is any of the two being out of the three positive. It can be a biochemical or a clinical hyperandrogenism, anovulation or oligoovulation, and PCOS morphology on ultrasound. So when the ultrasound picks up evidence of polycystic ovaries. So you look at the BMI and you do further endocrine testing. There is an TSH. If it is normal, you can do prolactin. You do the mid-luteal progesterone to see if it is low. Testosterone, DHA is increased. The hirsutism score is more. The ovarian volume is more on scan. And you confirm the diagnosis of polycystic ovaries. So in polycystic ovaries, there are menstrual irregularities, clinical or biochemical hyperandrogenism, as we have seen, and the treatment for them is definitely multidisciplinary. So this definitely has to involve the gynecologist, because the commonest complaint is irregular cycles, especially in young women. This is one of their problems. They get periods once in 3 months, 4 months. You treat them for a brief period of time with contraceptive pills to regularize the cycles. Again, once the treatment is stopped, for a few cycles they are regular. They come back with the same problem because the basic underlying thing, the obesity, is not addressed. So if you do not address that part along with giving medications to regularize the cycle, you will invariably find that these girls come back to you repeatedly with the same problem of irregular cycles. So the most important thing is you have to also advise them about lifestyle modification. Nutrition is very important. Teach them, especially young girls. I find that especially when you have adolescent kids, start teaching them young, even before they start getting their periods. I think mindful eating is something they should know. If you suddenly go and tell them don't have pizzas and burgers and Coke, they're not going to listen. I think it's the way you train them right from your dinner table. You teach them what to eat. Then they, when it comes to a point where you have to treat them for any of these problems, it is easier to tell these children. Otherwise, they don't listen to you. They say yes, yes, and they go out and do the same thing. And also, with the help of the endocrinologist, we address these issues of insulin resistance and manage with drugs like metformin. This is what we preliminary start off these girls with, and we find that it improves the ovulation. So, PCOS treatment, the non-pharmacological intervention is basically also try to teach them about exercise and diet. When I say exercise, it's very difficult to tell them go to the gym and all of them are studying, they are in their 10th, they are in their 12th. It becomes difficult. So I just tell them do whatever interests you. It can be aerobics, it can be Zumba, it can be cycling, it can be swimming. Anything that involves a physical activity for about 30 minutes a day, 4 to 5 times a week is what I tell them to spend on themselves. Modification in their diet, especially if you allow them to have one cheat day and then follow clean eating the rest of the days, they might be at least able to listen to you once in a while. Pharmacological intervention for a brief period, combined contraceptive pills will definitely help in regularizing the cycle. That also gives them a little bit of motivation, because when they have irregular cycles, they always feel the weight gain is because of the irregularity in the menstrual cycle. So when you correct it, and along that time, if you tell them to follow the lifestyle modification and the exercise part of it, definitely it will help. Insulin sensitizers we start giving, especially if they are very obese, and they also require, they have a lot of skin changes, hair loss. So you have to treat them for the acne, for the skin changes. Some of these contraceptive pills also help in giving them a little better, clearer skin. So if you tell them what exactly will help them, they will be definitely compliant to the treatment. So based on the particular management goal that you require, you'll have to advise these patients. The second thing is postmenopausal women, an exactly opposite spectrum. But again, weight gain is one of the most very, very concerning problems. Apart from hot flushes, mood swings, they have urinary issues like stress incontinence, insomnia, fatigue, knee pain because of the obesity. Lab parameters, again, if you see, when you do all this, there is an increase in the LDL levels and triglycerides. Diagnostic tests will help in identifying the metabolic aspects of the weight gain. And when you look at the menopausal symptoms, it is the hot flushes, sleeping problems, muscle and weight joint pains can be there. Psychological issues like mood changes, anxiety, physical and mental exhaustion, and urogenital problems. These all become very important in the postmenopausal age group. So you find that most of them have either a few of this or almost all of these problems in the postmenopausal age group. Treatment, again, when they have the metabolic issues, you'll have to address the lifestyle changes with physical exercise and also weight loss with the diet. And these lifestyle changes sometimes, even in that age group, when you tell them to do a lot of physical activity like exercise, it becomes difficult. So trying to again go back to the modification of diet will help them. Pharmacological therapy only if they have vasomotor symptoms. If hot flushes is their predominant symptom, then HRT will help. If hot flushes is not the predominant symptom, if it is only weight gain or any mood swings, I think trying to counsel them, reducing the weight itself will help. But vasomotor symptoms is definitely an indication where they would require hormone replacement therapy. So these are all some of the things that menopausal patients get affected, and all these will definitely improve, especially the mental health, and it enhances the well-being when weight loss is there. These are all the benefits of weight loss in menopausal women. And summarizing, if you look at in all the age groups, adolescent age group, all the key issues due to obesity are the menstrual irregularities, polycystic ovaries. Reproductive age group, it is infertility, pregnancy-related complications, and in adult, apart from the metabolic functions, it can be related to menopausal mood changes and hot flushes. So I think this spectrum has to be addressed in all women, right from the adolescent period till the menopausal age. Thank you, sir.
And thank you, madam, for a very good illustration. My question, rapid fire. So we are managing, we both are managing one particular patient, obese with polycystic ovarian syndrome. I have prescribed incretin-based therapy, and you have given hormonal therapy. Now all the parameters have become normal. She wants to plan for pregnancy. What advice will you give?
So I think once they have lost weight, and anyways, I would remove all the hormonal medications that I have given, because they have to plan for pregnancy. I'll definitely ask them to go ahead with pregnancy after consulting with you, whether they have to continue your medications or not.
So we'll take up at the end, incretin-based therapy, whenever we want the patient to go for planning for pregnancy. Thank you, madam. Next, shall I invite a bariatric surgeon, Dr. Balamurugan, to deliver his presentation on perspectives of a bariatric surgery in the era of better incretin-based as well as gliflozins for the management of all the metabolic parameters.
Sure, sir. Thank you so much for the introduction, and thank you so much for the Lily, and thank you so much for the Debate 2026 for giving us this opportunity. See, apart from all the medical crowd, I must be the only surgeon, I must be present, I think so, because I was searching for any one of my colleagues, I cannot find any one of us. So, obviously, sir, thank you so much.
I think you are cornered.
Yes, sir. Sir, I have been contacted by Eli Lilly for this talk. See, as a perspective of a bariatric surgeon, the topic what they wanted me to talk is like whether a surgeon will deny bariatric surgery or not. Obviously, we will deny for some reasons. As a surgeon's perspective, when it comes to bariatric surgery, we have some guidelines fixed all over India. We have some guidelines in all over India. One is patient perspective. If we see as a patient, we see if the patient is not responding while counseling, we know that if patient won't be adherent to any lifestyle modifications or patient is psychologically not able to accept that patient is not going to follow any diet. So that is where that we need to assess the patient is not going to complain. So when I deny the patient, or right now you are not surgical candidate at all. You need to wait till our counseling finishes, till you feel that you are going to follow something, we need to deny, yes, no bariatric surgery at present. And next other thing is, anesthesia complications. Patient is very high risk for anesthesia, we need to avoid, yes, we need to wait his wait. Last week when patient came, patient had a history of just 3 months back, patient had a CAD and stent was kept. We cannot, patient BMI was 50. Patient BMI was 50. 3 months back stent was kept. So even though patient came to me asking for bariatric surgery, we cannot do bariatric surgery. So patient had another 9 months more time. So I need to advise only GLP-1 at that time. So there is no option because what is best we need to give the patient at that time. So there are some protocols which we need that when the treatment should be given. But when it comes as a surgeon's perspective, yes, we can think about diet and lifestyle modification, yes, pharmacotherapies and even surgical options also. We need to analyze whether they are a surgical candidate or not, or we can give them what is best. Yes, when a surgery has to be declined either by the patient or by a surgeon, or else we need to support with pharmacotherapy. And apart from with that one, yes, the patient has to follow with dietary protocols and psychological therapy also, even with GLP-1s. So this was a case scenario where a patient was 45 years, weight of 129 kgs, height of 175 centimeters, BMI of 42. Patient had hypertension where the BPSI and pulse rate and multiple unsuccessful weight loss attempts. When it comes to, yes, patient had hypertension, dyslipidemia, pre-diabetes and knee joint pain, severe sleep apnea, social withdrawal and low self-esteem, and clothing was difficult and restriction physical activities. See, when we counsel all these patients, we used to analyze we used to assess the two type of patients. One patient is referred by someone only for obesity, or patient comes and asks directly for something. But patient doesn't have anything knowledge. When Shanmugal sir was speaking about how to counsel a patient when it comes to obesity, we take around minimum 45 to 1 hour to counsel a patient, sir. The maximum patients we can see is maximum in a day is 8 to 10 cases. So last 3 years, I left all my GI practice and only confined with only bariatrics. I left all my GI practice because time for counseling itself takes a lot because we need to properly counsel the patient or patient won't accept that they are obese itself. So we need to analyze whether the diet and physical activity is working. Then we will counsel that this is why it is not working. Then we need to choose some other option as a support. Even bariatric surgery is support and medicine is also going to be supportive because this is going to support their excess body weight, which is going to be helpful. And long-term options will be some diet and physical activity. See, for this patient, the laboratory is like HbA1c was 6.1 and LDL was 150 and HDL was 42 and triglycerides was 180 and ALT was 55 and AST was 48 and CRP was 5. But when the patient was diagnosed with class 2 obesity with the metabolic syndrome and obesity specialist, so to explore the treatment options, she was counseled for multiple options. But even though we know that she was a surgical candidate, we gave them an option for surgical candidate, but she was not ready for surgery because she wants to go for invasive method. The only thing is she must be frightened of surgery or frightened of some complications. So she denied, so we also accepted it. So patient was class 3 obesity and patient went on consultation. Patient decision, we made it as the final treatment and the non-invasive treatment was accepted. So when it comes to benefits, yes, when we think of GLP-1, it is a superior diabetes remission and durable weight loss and cardiovascular and hepatic protection also. When it comes for bariatric surgery, the pitfalls, whatever we think of nutritional dependence and malabsorption and surgical complications even. So this was the things that patient was denied bariatric surgery at that time when patient in point of view. The problem of obesity management was the problem severe obesity, BMI was 42 with multiple obesity related complications, persistent weight gain and despite lifestyle modification attempts, psychological distress and family pressures to seek medical intervention, and patient declined bariatric surgery. But the clinical impression was class 3 obesity with metabolic syndrome, high visceral fat burden contributing to increased cardiometabolic risk, meets criteria of BMI of bariatric surgery more than 40 BMI with comorbidities. The solution what the patient had was GLP-1 agonist for the appetite suppression and improved glycemic control, and in case non-invasive patient can go with endoscopic bariatric procedures plus pharmacotherapies for long-term management even, and with lifestyle intervention which is needed. But when to address with GLP-1 has to undergo, yes, in tirzepatide it has to be 2.5. 2.5. In semaglutide, the maximum it is around, we need to start with, 0.25, it was something is wrong. The dosage is, the dosage should be increases plus 0.25, and this is the maximum dosage, it can be gone up to 2.4 in semaglutide. The maintenance dosage is 5 milligram, 10 or 15, or in the semaglutide it should be 1.7 or 2.4. The maximum dosage is, this one is 2.4. The frequencies both is weekly ones, whereas in tirzepatide is GLP-1, GIP-1, whereas in semaglutide is only GLP-1. With dietary modifications with GLP-1, it should be calorie deficit and meal structure has to be done, food restriction and portion control, which has to be followed by clinical nutrition, where we have a protocol that every 3 months that patient has to be followed. With physical activity, whatever the type of physical activity patient can do, we always advise. For this patient, it has to be like nearly 5,000 to 8,000 steps and moderate activity and gentle stretching and daily walking at least 15 to 20 minutes, which impact lower level. At 3 months, the patient weight loss was 8% of the body weight reduction achieved. Blood sugar control came up to 102 and HbA1c for 5.8, and cholesterol LDL was reduced and triglycerides also reduced. Knee joint pain improved, enabling 20 to 30 minutes of daily walks. And this was the patient scenario of case 1. This was the case 2, which is like 5 years back, patient has underwent sleeve gastrectomy. After sleeve gastrectomy, at that time patient was 124 kgs, patient reduced up to 84 kgs. So patient lost around 38 kgs after surgery. So after some particular period of time, patient had 86 to 106 kgs. Patient has weight regain of 20 kgs in a span of year, after 3 years might be. 3 to slowly, gradually started increasing. Now the BMI is again 38. HbA1c started rising, and the diabetes control achieved within medications was HbA1c dropped up to 5.7. So right now patient has a weight regain phase, so which has to be addressed. Before, like when the GLP analogs came into practice, there was only revision bariatric surgeries. Revision bariatric surgery, sleeve converted to gastric bypass surgeries, sleeve converted to Roux-en-Y gastric bypass surgeries. But right now, since GLP-1 analogs has come into pipeline, we started reducing, or it come to nil practice for revision bariatric surgeries. Because this GLP-1, again it has an appetite suppression. So it goes to again 5 to 6 months or nearly 1 year of appetite suppression post bariatric surgery. So patient will have again weight loss can happen with good physical activity. So this patient was advised, again preferred choices was endoscopic bariatric surgery. We can again suture the endoscopic sleeve gastric, we can again make a tube. But revision metabolic surgery or again complication. But more than that, the pharmacotherapy patient is again non-invasive. So it was a preferred kind of treatment. Right now in last 1 year, the scenario has changed all over India. All over India. So to summarize, yes, when a bariatric surgery is declined by either by surgeon or patient, don't compel the patient. From market, we don't compel, because patient compliance is more better in any kind of medicine or surgical management also. So it has to be pharmacotherapies, approved anti-obesity pharmacotherapies for weight loss. The clinical evidence review the trials like STEP and SURMOUNT to understand the treatment efficacy, multimodal strategies like implementing comprehensive approach and combining various therapies, individualized planning like tailored treatments to plan meet specific patient needs, and regular monitoring, conducting ongoing assessment to optimize the patient and ensure long-term success. And more often, we need to motivate the patient regarding that you are doing good, do some physical activity, you will be good. So thank you so much.
Thank you, Dr. Balamurugan, for a nice presentation. You have accepted the role for incretin-based therapy, when to prescribe, and also when to advise your patient for undergoing surgery, and after surgery, if the patient regains his body weight, what is the role of incretin-based therapy? So you have highlighted nicely.
Thank you.
Thank you very much.
Thank you so much.
I thank all these 10 minutes. Yes, now, yes, I hand over the mic to Professor Dr. Venkatraman. Okay. Please come, sir. Please come. Okay. I think one more mic you can hand over. You can hand over, yes. Yes, now the floor is open for discussion. All these presenters, they have made a very clear-cut message to all of us. Now it's a time for us to interact with the panel member. They're expert in their field. Yes, Venki, you can initiate. No, you can take this microphone. You can hand over.
I think great presentations. And of course, as usual, brilliant moderation by you.
Thank you.
Both for, I think, the last two presentations. Now, whenever guideline recommended intervention is there for weight loss, we are able to achieve. It's no more a theoretical pursuit. We are able to see it. What I want to bring to your mind, probably as a leading practicing obstetrician, is there is a paper which you are taking tomorrow in your journal. It is a cohort data in obese women exposed to GLP-1 and non-GLP-1. I'm not talking about the molecules. I'm complying with the. What happened was, the target weight was probably achieved with the exposure of the two molecules, and then they conceived. Now here is the catch. The weight gain in the people who have already been exposed to GLP-1 was 3.5 kgs, much more, which resulted in increased early labor, gestational diabetes, and hypertensive disorders. Because early weight gain is associated with these. While this message I am not sharing to belittle the importance of the pharmacological intervention, which you are fortunate to have, a couple of molecules alluded to. What I thought was, maybe in such a situation wherein women has been exposed to a GLP-1 receptor therapy, achieving the target weight loss, because the advantages are huge, beautifully alluded to by you. Fertility improves, ovulation improves. In fact, a couple of examples, including a medical professional, in spite of all the precautions and whatever thing, she conceived while she was on the GLP-1 receptor agonist therapy, and unfortunately, we have to terminate. What I'm trying to say is that because she took it for granted, it's very difficult for her to conceive, going by the previous experience. And this few months and then about 10 to 12 kilos of weight loss restored that fertility to that extent that she was overconfident. And so while we cannot deny the benefits of this amount of intervention, which is a reality now, the other side, the flip side of the story is when the weight regain is that, normally you expect, depending upon the various attributes, you always monitor and then advise your patients. Maybe in situations like this, you have to be more proactive. So could you give some suggestions? Somebody has been exposed to GLP-1, conceives, so how do you monitor? Of course, again, if other metabolic parameters are going to be a problem, we'll take care. That's not an issue. With respect from the obstetric point of view, the weight gain and the associated problems like your early labor, in that particular, there was no increased incidence of cesarean section, etc. And loss for gestational age babies as well as those things were not there. But GDM was there. PAH was there and early labor was there. So this has been attributed to the rapid weight gain because we know this. Right from the afternoon we have been learning this is a chronic relapsing disease. You have remitted, if I can use the word Velu, you have remitted by your intervention. And as soon as you discontinue, you are forced to because you have to wash out for 2 months and then only advise your patients to conceive. So there is a relapse. The so-called rebound weight gain is nothing but a relapse. That's the nature of the disease. So on the one hand, we will not deny the benefit of this molecule. On the other hand, be cognizant of the fact that this weight gain, which is probably much more than somebody who has not been exposed to this molecule, possibly should make the clinicians and especially obstetricians, and then your advice to us as to how proactively you can, to an extent, nullify this effect.
So I think, like what you said, it's a very difficult situation because sometimes when these patients are on these drugs and we tell them to stop at least 8 weeks prior to planning for pregnancy, so that is a window. Actually, that 8 weeks itself is pretty tricky because most of them gain back at least 50% of the weight in that period. So unless, when they are put on the drug, they can't take it for granted that the drug alone will do all the work. Because they will also have to simultaneously look at, their modifications in diet as well as physical activities. They have to come to a phase where that low appetite which is there with the drug exists even after stopping the drug. So that kind of conditioning, it is very important to reinforce because they lose weight well, but by the time we give them that window to stop the drug and then conceive, they gain back at least 50% of the weight. So that is one issue. But if they are already counseled about it and they don't gain that weight back, then that pregnancy issue of, an increased maternal weight gain is not generally seen. But if they do conceive in that, quickly, and they are off the drug, yes, that is there. Then during the pregnancy, it becomes a challenge to do that nutrition counseling. Because again, there is a lot of social aspect to it in pregnancy. When we tell them too much of diet restriction and calorie restriction, the entire family comes around and says pregnancy means they have to eat so much, they have to eat well, and they keep feeding the mother. So I think this sensitization has to happen when the patient is on the GLP itself. Because we have to tell them that it will happen in the 8 weeks of wait as well as during the pregnancy this can happen. So I think that is the only way we can.
Yes, nice point, yes.
Once you initiate, prepare them so that they are extra cautious, of course with your inputs, so that the weight gain is always an issue, but this extra weight gain possibly has to be anticipated and then shared in the conversation with the patient. I think that's all.
Nice, madam. Thank you so much.
Thank you, sir.
Yes, any other question?
I think to Dr. Balmurugan, I'm sorry I'm asking a lot of questions. Anybody in the audience wants to ask? What I thought was, you nicely highlighted the advantages and the disadvantages of the bariatric surgery vis-a-vis the pharmacological. One thing that we have, of course, very rare is, one of the complications we have not seen, maybe one case I've seen, is the nesidioblastosis. So such a huge level of stimulation of the beta cells by the GLP-1 results in so that
Proliferation, yes.
unwanted, extreme episodes of dangerous hypoglycemia. To that extent, some patients have been resorted to partial pancreatectomy.
Okay.
So that being the case, so far I'm not aware of any such event happening with the pharmacological intervention to the best of my knowledge. I'm not very good in going through literature. Probably that also could be a advantage for the pharmacological intervention vis-a-vis the bariatric surgery, even though it's extremely rare.
Yes, sir. Sir, actually that kind of symptom, what we call it as a dumping syndrome actually.
That is totally different. Histoblastosis is different.
Histoblastosis.
That is because of proliferation of the beta cells.
Proliferation of the beta cells. Okay, sir. Sir, so far actually, because last nearly 9 years, I was into only bariatric practice from 2016 onwards. So far, and I have been working in high volume center also. It's like maximum of the volume per month we used to operate as 80-90 cases per month, which was in Ahmedabad I was working. So far in that cases I have not seen. It is because of bariatric surgery. So far in literature we have not seen related to that one also. But yes, dumping syndrome, yes, more cases we have seen. That is totally, that's a difference.
Yes, doctor.
Regarding the pregnancy thing which you pointed out. It's an important issue which needs to be covered. The GLP-1, can it be given in the pregnancy, first of all?
No, 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 no.
So when you stop it, when the weight gain happens, it's going to happen, right? That's where the embryogenesis is going to start and things is going to affect it in many ways because the weight gain and diabetes part. And the diabetes part, it is like almost like a diabetes going in for pregnancy and things. So the problem is always, it's been highlighted, the weight gain should not be there. What about the role of metformin in that first trimester? Because the weight gain that can minimize it and thereby alleviate.
Yeah, I think metformin, you can definitely continue through pregnancy. So maybe if the GLP-1 that you have, the endocrinologists have started, you can taper it when you're close to planning the pregnancy, when they're already reaching their target weight loss. No, metformin can, I'm saying that even prior to pregnancy, you can start tapering the dose, add the metformin, in the interim period, continue them on the metformin so that, again, this problem of gestational diabetes as well as the increased weight gain, maternal weight gain during pregnancy, both can be tackled. So, tapering the dose once they have achieved the target weight or when they are closer to achieving it, as well as adding metformin in that process will definitely help in combating this.
Wishful expectation is, if you continue metformin, to an extent whatever we highlighted in that paper, this extra weight gain of GLP exposed, can it be to an extent mitigated by the continuation of metformin? Yeah, wishful thinking, we should let it happen.
Any question to Professor Dr. Vinod Kumar, please? Dr. Vinod Kumar? Because I have asked 3 questions already.
I have a question, sir.
Sir.
No, this is generally to the endocrinologists who are prescribing the GLP-1 and GIPs. What about the ophthalmic side effects, which a lot of, worry that starts? That's one question. Second thing is, as gynecologists, are we allowed to prescribe these injections when a patient comes to us? Because invariably every patient asks this. It's available all over in the news, net and all. So the first thing they always ask us is there an option for weight loss? Because when we tell them diet and exercise and all these stories, they always want a little shorter route to it. So,
Madam, you counsel them properly, educate them properly, motivate them properly, go through the indications, contraindications carefully before you start prescribing. Regarding the ophthalmic problem, if you treat nearly 2,796 or cases or so, one patient may likely to develop, but still the cause is not proven.
so are gynecologists allowed to prescribe these drugs?
I think as I understand the prescribing label indications, endocrinologists and physicians are the people who are supposed to prescribe this molecule. That's number one. Second thing is you asked about the ophthalm. Now let's be very clear on this. When you talk about the eye and diabetes and the medications, first and foremost, it comes to your mind is retinopathy, diabetic retinopathy. So somebody who is a pre-gestational diabetic, what is the risk of diabetic retinopathy? Does this molecule or this class of molecules precipitate new onset of retinopathy? The answer is no. Like your pregnancy. For example, a pre-gestational diabetic, yes, pregnancy worsens retinopathy. I would say that situation is similar to, from the point of view of the retinopathy, but it can worsen the retinopathy. Are there GLP-1 receptors there in the retina? The answer is yes, but there is no mechanism studies to associate that the molecule per se is responsible for the worsening of the retinopathy.
Not proven.
The worsening is because somebody has got HbA1c of say 8.9, 9.1, rapidly it comes down. The sudden reduction in the HbA1c, which we have seen right from the DCCT in type 1 diabetic subjects, can worsen the retinopathy. One of the theoretical reasons which I found out in the books of 80s and 90s was, if you have a patient with proliferative retinopathy, the new blood vessels, are there any ophthalmologists in the audience? They can supplement me or correct me if I'm wrong. So the new blood vessels do not have a supporting basement membrane. They are supported by the intraocular pressure.
Hypoxia.
When there is a metabolic swing, for example, when you have a reduction of the HbA1c say from 8.9 or 9.1 to say around 6.8, This cannot be accomplished without episodes of hypoglycemia if molecules like your SUs or insulin are on board. Absolutely. So when the intraocular pressure comes down, then the supporting framework is lost, they go in for vitreous hemorrhage. This is one of the theoretical explanations given at that point of time. Second is again, because of the sudden reduction of the blood sugar level, the osmotic changes that can worsen the macular edema. These are the two situations. The summit substances, retina, no fresh onset of diabetic retinopathy, but it can be worsened. The worsening is probably related to the rapidity of metabolic control rather than the molecule, even though GLP-1 receptors are there in the fourth layer of the retina. What about neon? I think this is one condition which has come into limelight after the exposure of semaglutide, captured by one particular center of neuro-ophthalmology in Boston, if I remember right, and subsequently we have been getting cases. This is one of the complications of...
Recently they have removed it from the label.
Yeah. This is one of the complications of diabetes, even though it's very rare. Only after that we came to realize, even some of the ophthalmologists, they came to know this is because of the rarest conditions. So it can happen. Whether preferential exposure of this molecule has been found to have an increased prevalence, it's questionable. So far the data are there with SEMA. I understand some cases have been associated with precipitate exposure as well. I'm not too sure because this was shared in some other meeting by maybe the Lilly, Dr. Shrey will give an answer to this in the end. So from the ophthalm point of view, a pre-gestational diabetic certainly requires a pre-initiation ophthalm consultation, number one. Maybe some of the anatomical aspects like a crowded disc, because one of the features were a crowded disc with a lot of optic fibers could be a, this is off-label discussion that you are having.
I think as per Lily's...
cut off the mic because I'm audible.
Yes, we are not supposed to talk.
But the question was with respect to the retina, eye and the... So when you discuss about the eye and diabetes and the molecule, it becomes an inadvertent discussion which trespasses probably the limitations that you have exposed. Yeah. So that's all. No further explanation is required. But
Thank you.
certainly an ophthalm evaluation is required.
To surgeon, sir, 2 days ago recently, I got a 26 or 28-year-old female patient, came with the complaining of weakness, myalgia, and she was not holding her back. Then when I inquired about treatment and other history, I suspected first anemia, and I have elicited the history about the causes of anemia. She told me that she underwent bariatric surgery in 2016, I think. She told me that she was so weak for the past 6 months. She consulted so many doctors, like 4 or 5 physicians, and they prescribed her all the hematinics. But still, then they advised her to eat iron-rich foods. She is being an educated lady. She has been doing everything, but in spite of that, she feels weak for the past 6 months. I sent for HB and group. It was 6.2 grams, sir. Then I inquired how much the HB 6 months ago. It was 9.4 or something. Later, it has come down to 7 grams last month. Now I have advised her to have blood transfusion. I admitted her in other hospital. What would be the cause? I want to know.
True, sir. Sir, when it comes to bariatric surgery, we need
Dr.
to basically
make
understand.
little fast, because we have to make it.
We need to basically understand that what kind of surgery has been done for the patient. Any bariatric surgery.
Yeah, that I inquired, sir. Whether liposuction
No, sir.
or
So
or
liposuction
sleeve
is
gastrectomy.
Yes, sir. No, sir.
No.
Liposuction is a...
No, she told me my stomach was cut, sir. They removed some stomach, bit of... Yeah. No,
Yes, sir. Sir,
being,
actually-
she is a
Sir-
non-medical lady, non-medical lady. She told me, I asked her, bariatric surgery, a piece of stomach is cut off, sir. She told me.
Sir, actually, liposuction is totally different scenario. It's
Yeah,
a
yeah,
cosmetic
that-
surgery. But when it comes to bariatric surgery, sleeve gastrectomy, gastric bypass,
Yeah,
and
sleeve-
mini gastric bypass, these three procedures
She
are the
did not
commonest
show me
procedures.
the file and
Yes, sir,
everything.
fine. But in gastric bypass surgeries or any bariatric surgery, patient has to be on lifelong supplements, which is mandatory. That as a surgeon, that we need to emphasize the patient before surgery itself. We need
Sir.
to counsel the patient that it has to be continued. Somewhere this patient and doctor's rapport must have missed. So she must have
Another thing,
somewhere.
Balamurugan, I
Yes,
thought
sir.
we can end up this discussion by saying that when a woman has got a sudden drop of hemoglobin from 9.1 to 6.4, you have to look for other causes of anemia rather than the nutritional alone, which is going to be maybe sustained enough. She might have a chronic anemia, but sudden drop in the HbA1c, which probably happened over a period of few weeks.
No, other physicians have already tested, she told me, sir.
HbA1c 9.1 to 6.7, I'm not too sure whether it is
No, sir, it can be related to be bariatric. It can be related to bariatric surgery. The thing is what kind of surgery. But in sleeve gastrectomy, if you say that only removing the part of the stomach, in sleeve gastrectomy, HB drop is not going to come, sir. If
Oh, what
there is
ab-
any bypass surgery. if
Sir,
there
what
is-
about the intrinsic factor, sir? Whether
What, sir?
loss of intrinsic factor, that means a deficiency of.
Sir, that is what vitamin B12 is not going to have anything related to iron drop. If there is anything related to bypass surgery, see if the duodenum and first part of the small intestine has been bypassed. At that time, the patient has to be on lifelong supplements, which has to be counseled mandatory. See, my question to that patient, if it had been patient came to me is, what is the patient that you have, are you taking supplements right now or not?
No, she told me that she has been taking supplements for the past 6 or 7 months. In spite of that, she is becoming
Then that
anemic.
must be not related to, if the supplement is still
to
on.
have this panel discussion over by 7:30. 7:30 to 7:40 we have time. I think Bala can
We'll talk.
No,
offline.
regarding
Don't mind,
intrinsic
before we
factors,
wind up
sir,
this session-
does it affect by bariatric surgery?
continue
That I
this
want
discussion.
to know.
Sure, sir. Sure, sir.
Yeah, I think before we proceed further, we'll profoundly thank my great friend Velu, I think for excellent moderation of the session and then for his inputs at every stage of the presentation and every clinical entity that has been discussed so beautifully by all the three. Now we have only limited hour, of course. Krishna has joined, so I can start the question answer session. Right. Again, thanks Eli Lilly, because last time I forgot to acknowledge you by my oral acknowledgement. Yes, I thank you for contracting me. Thank you so much for asking me to do the second leg in this wonderful session. What are the frequently asked questions? Yes, we did discuss about a lot of comorbid conditions. This is one aspect which is very important linked to obesity, the mental health burden in obesity. Maybe Vinod was left out answering, maybe we'll try to. Of course, there are some figures given in the slide itself. I'd like to supplement, substantiate.
Probably in obesity, mental agony is there.
Yes, Krishna.
Yeah. The thing is,
Come to the podium. Lily wants you to be in the podium. Yeah, yes, Vinod.
since the body image perception, mirroring the image, when I feel obese, it gives you a lot of patients depression and anxiety to be in the public forum. And a lot of time they create a self-pity over them. There is a significant neglect of person. So obviously psychiatric component in obesity is very, very strong. That has to be addressed very efficiently. And even Krishna sir was talking about how to train the mind in lifestyle interventions during an obesity patient. So I strongly believe it has a role.
So all these entities, are there evidence to suggest that they can be reversed or the incidence can come down with pharmacotherapy or with the target weight reduction? Are there evidence?
Yes, sir. There is some evidences. Sir. More than evidences, patients themselves will feel more motivation. The motivation doesn't only depends on only the weight loss. The whether the lifestyle modification, whatever they are going to make, which will again make them to do the same thing, whatever they are doing. I'll just give you one example, sir. One patient is a just 22-year-old female, weight of 160 kgs, 22, and BMI of around 61. Patient mother is a single mother. The patient right now, patient weight from 160, she has come up to 70 kgs. Mother was previously complains of she has suicidal tendencies. She doesn't go out to any social function. She doesn't because she is obese. Right now she is complaining of again she is not coming out because she wants to go to gym.
Can I come in? There's a caveat here that any pharmacotherapy that has addressed obesity in the past, whether it's Zimonabant, Sibutramine, have all been ultimately discontinued because of cohort studies which showed increased risk of suicide. Right? So, this is something very, very important to understand. Now, there was an Australian guideline that talked about that if you have very severe depression, that some of these drugs should not be used simply because they may increase suicide. There is a re-evaluation by the FDA. They say it is not true that these drugs do not actually increase the risk of suicide. But I will tell you, from a clinical point of view, when you have patients to whom you're considering this medication, I'm giving you the flip side of the story, and they have evidence of, if they say that they have self-harm, or let's say there are 2 or more psychiatric medications along with it, then my suggestion is do not start any of these medications unless the psychiatrist tells you that they are not at an increased suicide risk. Because when you work at the level of the hypothalamus, when you work at the level of reward centers, when you work at all those levels, that if they have increased amount of a suicidal ideation, I would not put these patients. So that's a little caveat. While depression will come down, overall illnesses will come down, the important and most important thing is that if they are at risk of self-harm, do not start these medications.
Yeah, that's a good warning and a good message clinically. But Krishna, I want to ask you, how do you tease out somebody has got a suicidal tendency, whether it is attributable to the disease in question, obesity with the depression or whatever it is, or how can you attribute it to the molecule?
Irrespective of what you're doing, right? Sir, the way I look at it is, first thing is to protect yourself and your practice for the rest of your life. Don't do something that will put your practice and your own legal career in jeopardy. If somebody has suicidal ideations, get the right help, get over it, get the help of a psychiatrist to tell you, look, I don't think this person is under further risk of self-harm. Sometimes...
No, that I differ, because the psychiatrist can tell you her 5-year suicidal risk is probably it was so much so, now it may be this much, but you cannot eliminate that risk totally. Am I right?
Correct. So all I'm saying is only this. Because there are studies and because there is some evidence that in patients with increased risk of suicide, that it can push these patients over, till we get further guidance, be careful about using these drugs in patients who are at increased risk of self-harm. That is
So the
purely
answer to
a
this question-
personal protection plan.
Good, totally agree with you. So the answer to this question will be, certainly as Bala pointed out, the self-esteem, which results in social ostracization, self-imposed social ostracization, has been significantly improved, and we expect it to be. But on the other side, if there is going to be a major challenge with respect to going by the previous experience, yes, Rimonabant was such an excellent molecule, but there was issues. So going by the previous experiences, since it's very difficult to attribute, let's be careful. I think the clinician's discretion will be better in the background of...
So, I just want to tell you what I don't practice. If somebody has major depression and are on 1 or more medications, I actually ask them, has it ever crossed you to hurt yourself? Second, if I find them they're on 2 medications or above, I actually call up the psychiatrist and ask them to tell me, is it okay if I start the medication?
But quite often, the obesity contribution by the antipsychotic medication is much, much more. It adds to the damage. Fine. I think the point is well taken. I think this question, we have already addressed it partly or totally, the fertility as well as body image issues. I think the same question, self-esteem, etc., etc. So how should practitioners counsel patients who notice body changes? Yeah, this is absolutely important. I think you mentioned it in your presentation. Somebody is very sincere, has started on not necessarily a pharmacological intervention, lifestyle modification, reduce the diet, but not reflected in the scales. But on leading question, yes, they admit, yes, that the attire has become a bit loose, the trouser size has come down. So you know that the fat is getting converted to muscles. So don't go only by the goals, as you nicely mentioned. So appreciate the attitude of the patient, the participation of the patient, and it is producing results. Do not go by the scales. So anything else that
Sir,
to add?
yes, sir. Again, one case scenario which I just wanted to share, and one patient, BMI was around 36. Patient is age of 33-year-old male. Patient weight was around 122 kgs. 3 months post GLP-1, he lost around nearly from 122 to nearly came down up to 19 kgs he lost, approx 19 kgs. But in that, out of 19 kgs, there was a 2 kgs muscle mass gain also, which we were able to elucidate through body composition analysis. We have a body composition analysis before any bariatric surgery or a GLP-1 we take it, and we used to assess the fat percentage, and in that 3 months we have emphasized him to take more protein with protein supplements. He used to go to gym, so 2 kgs weight gain and 19 kgs fat percentage loss.
Good. Thank you so much. I think one point that you would like to highlight, which you have been talking so far, is the amount of protein that you recommend. Probably it's very difficult to get it from the diet alone. So you need to have a protein supplementation. Agreed? No? Yes.
No.
As usual, he is not agreeing. Give me your answer.
No, I don't agree. I think this whole protein game is gone way beyond its required. You need a
So
mind.
between protein supplementation and of course strengthening exercises, probably you would prefer the second one.
I'm going to tell patients, if you can increase your dietary protein by 10 to 20%, and it can come from your dal, it can come from your thing. You don't have to go take eggs. You don't have to go eat meat. You don't have to change your familial beliefs. Start doing resistance training, and your idli has sufficient amount of urad dal. Make sure you add some more dal to your sambar. Have some chana every day. You really don't have to live on paneer.
Will it come to this 1.2 gram of ideal body weight vegetarian diet? It's very difficult in my opinion. Even GI tolerability with respect to too much of dal.
Even this 1.2 is not based on level A or level B evidence. There's a lot of level C
Conceptually agreed.
pseudoscience that's going into all of this. Sir, I can tell you.
So,
our people have lived for centuries and survived.
Let me summarize. So, even though we harp on protein supplementation, you don't have to go in for any fancy foods. Dietary modification with the help of the dietitian will suffice. That is
And
the
no, I'm going to
message.
add one more thing. And you don't have to change your familial traditions of eating just because you want more protein. Just ensure that you take the foods that have a little more protein in it. And remember, this whole thing has gone to a point where the leucine levels are going so high that they can cause harm.
Good.
So that's what I just wanted to check about the inflammation process with all these protein increase. So, some of them don't tolerate the high levels of protein intake and all that. So how do we address that when we counsel them for the diet? Just stick to your regular diet, but just reduce the carbs?
I tell them, whatever your grandmother ate, because your mother would have probably been eating junk also. Whatever your grandmother ate, eat modestly. If you can eat half your stomach and get up,
Live
that is
like your
good.
grandmother, that's difficult.
Huh?
Live like your grandmother, which is difficult, I say.
Exactly. Don't eat processed food. Make sure that you have the discipline of eating food on a regular basis. And then the only other thing I tell them is make sure you do resistance training. It's more than sufficient. Everything else is largely pseudoscience and mostly gobbledygook.
I think Lily really has to do this part of the slides with inputs from Krishna. This one
Let's
particular
agree, let's
aspect-
agree to disagree on this because you'll see that when people quote these articles, you will find that most of them are not well done studies. I actually go with what Dr. Mohan does based on the pure study, based on the ICMR and ICMR recommendations. A modest reduction in carbs, 10 to 20%, not more than that, and a modest increase in protein without changing the overall composition of the diet. Now, if you want to go back, the new US pyramid, then you have to eat like Donald Trump.
What about this 1 meal a day, 2 meal a day?
I think the 2 meal a day concept is very good. This whole breakfast is brain food is complete Kellogg's and cereal companies build up, right? Traditionally, people have been eating 2 meals a day or 1.5 meals a day for centuries. In fact, I don't know how many of you know that in India, in temples, there are only two main prasadams, and there are only two mantras for giving food to the god. Morning Satyam Tattvena, evening Ritam Tattvena. So people have lived with 2 meals for many years. This idea of having breakfast is less than 80 years old. And breakfast is brain food is basically a food company advertisement.
Insinuation. Okay, now, I
And by
think
the
this
way,
is one
even
of the
these
favorite
wholemeal
aspects.
cereals, if you look at the new data, we have no data on these cereals.
And more than the protein aspect, I think the controversy is about the much promoted in the social media, all these fancy diets. So intermittent fasting, keto diets, so that's what we're discussing. I believe in the concept that pharmacological manipulation of ketones, even though the evidence is not there, at least conceptually, probably better than, another 3 minutes, another 2 questions, we'll finish it up. So that's better than the dietary supplementation. I'm sure all of us are in sync with this. So no fancy diets has to be encouraged by us because the evidences and of course, as usual, I think the promotion by the respective industries, I'm not too sure we're violating the norms of Lilly. So
It is a scientific
no diet is
meeting, so
proven
we
the
don't
best.
violate.
No violation. Okay. I always believe that you discuss about a molecule, you discuss about a concept. I think we come to when we talk about the diet, I think it's always, in fact, we used to do a program 3D. Vijay always used to keep it at the, it used to start at around 1:30 and then go on till 3:34, we have to stop it. Because diet is one aspect which is integral. And we want to have a synchronous opinion as much as possible. But unfortunately, the evidence is not allowing us
See,
to.
remember, it's very, very interesting. Most of us eat out of boredom. You should understand that. A lot of times, snacking and excess eating of food occurs because of boredom. It doesn't occur because of anything else. So, you see, on Sundays you eat more. Why? Because you're not doing anything. At the same time, if you're making enough money in your clinic, you don't feel hungry.
That is because dopamine is already there because of the money that you see.
Is it true that if you skip dinner, your visceral fat comes down?
No.
Intermittent fasting.
Well, what really happened, I'll tell you what happened. There is a mitochondrial partitioning of food, right? This is a very, very ancient thing in the sense that we are hardwired for it, that we day awake animals, we do glucose in the day and fat breakdown at night, right? But remember, glucose metabolism will inhibit fat metabolism and vice versa. This is called hysteresis. So the longer you fast, the greater is the time it takes for fat to work. So in theory it works, but ultimately, at least in human beings, all the others, you have data on intermittent fasting or caloric restriction and longevity. In humans, we still don't have that data, but what it does is, it gives you a longer time. That's all it does. But ultimately, restriction of feeding without restriction of calories does not work.
Thank you. Anything that you would like to supplement? Otherwise, we'll go to this question before we wind up. Another 1 minute. What are the food adjustments to be made and advised pharmacotherapy for obesity, especially in the context of the incretin-based therapies?
So,
When it comes to again GLP-1, yes, we know that somehow it is going to reduce the calories. There is going to be food restriction is going to happen. But the priority should be always on high protein, high fiber, and good hydration should be there. Or else, yes, the complications like whatever the constipation or muscle loss will happen. And apart from that, patient has to stick on with the nutritionist protocol, where patient has to listen to us. That is what we mainly attach with. So counseling before the patient should be like this. Patient,
Sure. Sure. So the message is, whenever you are on this mode of therapy, be cautious of the deficits. Yes, the muscle mass certainly comes down, it is not the fat alone. So be aware of that, and then appropriately you incorporate the protein. As Krishna just now said, if you can manipulate in the diet, which is a natural source, well and good. If not, I think there's no harm in the protein supplementation. That's what I feel. Now I'm telling it very boldly because Krishna is not there. He's just now left. Second thing is, of course, there is unanimous opinion with respect to the strengthening exercises, because you provide the amino acids for incorporation, but for the muscle fiber to take it up and then increase the, or at least not retain the sarcopenia, the obesity associated with the aging, supplemented by the intervention that you're going to. I think you have to combine both. Yes, one question and then we'll wind up.
Yes, I'm Dr. Kavita. I think never an obesity-related program should end without endorsing the sleep hours. Okay? A good 7 to 8 hours of sleep makes a wonderful difference, because all your cortisol levels, your leptin, your satiety hormone, your ghrelin, everything which contributes to obesity, I think it has to be mentioned. As a practicing sleep physician, I just would like to add this to this, because all your hormone levels and your obesogenic genes have a epigenetic modulation with your good sleep. And one more thing is, as religion, which is a lifestyle for everybody, choice of food is also very personal. I don't think anything can make a point, because as we all know, as scientific people, the vegetarian diet, bioavailability of protein is very minimal, and I would like to have endorsement for again the lean protein, because when you do strength training, your muscle repair needs more protein for its regrowth, and all these micro injuries, definitely they need amino acids for the buildup of muscles, and I think we need to supplement with micronutrients as well as the thing, depending upon the procedure, whether it is GLP-1 or the bariatric. Thank you.
Thank you so much. I think
Actually,
that was a very good message. What I thought was, I think you raised a point. Whenever you talk about the lifestyle modification, always you harp on the various aspects of diet and exercise alone. Sleep is sleep hygiene. Sleep hygiene is one thing. We talk so much about the sleep disorders in all the metabolic diseases, including obesity, OSA, CPAP, etc., etc. So how important sleep hygiene? I think probably, I think work should start from this country, wherein sleep hygiene is also included as
true,
a lifestyle modification.
Actually, Madam has,
And since,
Madam has emphasized just one particular important point, sir. When we treat obesity, the sleep apnea should be evaluated, because when we ask the history, if we ask the stop bang scoring itself, that stop bang scoring, if it is very high, if it is moderate to severe, patient has to be concomitantly treated with CPAP, because the percentage of weight loss with GLP-1, with CPAP, or with bariatric surgery with CPAP will have a good effect on weight loss. So,
yeah, thank you so much. I think we started this program at 3:45, close to about 4 hours. We have done, I'm sure you have done justice. And thanks for the wonderful opportunity for us to be together and have the inputs from these great presenters. Let us give a big hand to Lakshmi, Balamurugan, and Vinod for the great presentations, and then the participants also not least, but you, the audience, and especially the points have been well taken. I think whenever, as I told you, when you discuss about a molecule, you can always have a beginning and end. When you talk about the lifestyle modification, you can go on and on. We will continue in the next debate next year. Thank you so much. Thanks, Lily, for the opportunity.
Thank you. On behalf of LLE, thank you very much to our esteemed faculty members, and thank you all the healthcare professionals for your presence here. And we truly appreciate the opportunity that we got here to be part of debate conference. Have a wonderful rest of the conference. Thank you.
So thank you all. Now we will move on to the Hall A. There is a session in Hall A, a non-academic session.
Dr. Chitra Madhavan is going to give a talk. So I request you all who are interested, please join us in the other hall.